So I'm Dr. Ashwini, your host for today, and let me tell you that I'm very grateful for the opportunity for hosting this workshop with most of the great clinicians that we have in our country. Today's session will be full of academic feast, and I'm sure at the end of the session, everyone will be full of knowledge that helps us in dealing with the challenges in the critical care. So without further delay, let me call upon Dr. Akshay Chalani, Lead Consultant and Medical Advisor of Apollo Hospital, Navi Mumbai. So I request him to come on the stage and give welcome note and start the program. Over to you, Dr. Akshay Chalani.
Thank you, Dr. Ashwini, and on behalf of Apollo Hospital and Critical Care team, I welcome you all for coming here on the Sunday morning. I assure you at the end of the day when you go from here, you will learn a lot of new things actually. At the same time, I expect you to learn a few things. To start the session, I invite Dr. Sharmili Sinha, who has flown down from Bhubaneswar. She will be talking on the critical care emergencies, and to chair this session, I invite Dr. Suman Goswami and Dr. Vivek Kumar. Dr. Sharmili.
Very good morning to one and all, and at the outset I would like to thank immensely the organizing team of this Apollo Critical Care Conclave for the kind invitee, and my dear friend Dr. Akshay, who am I known for now 18 years. It's a wonderful organization, and it's a really pleasure to see on a Sunday morning this much crowd willing to listen about management of acute pulmonary embolism, one of the life-threatening conditions in the hospital and intensive care units. I hope my slides can be shared now. No, it's not visible here, no? Oh, yes. Is it visible to the audience? I think one of the lights could be switched off. Is it visible? I think one of the lights can be switched off. So we'll be talking about life-threatening embolism. When we talk about embolism, most of the thing we'll focus our discussions on the thromboembolic events, that is related to venous thrombosis, and we know that other kind of embolism also do exist, like fat embolism, amniotic fluid embolism, and some of the rarer kinds of embolism as well. So these are the learning objective of today's sessions. The basics we'll just stick to, because this is what actually in diagnosing, preventing, and then treating in case of life-threatening situations happens. So just recapitulating the basics of thrombosis, varicose striates, of intimal vessel injury, stasis, and hypercoagulability, which actually sets off the right platform for starting thrombosis, and if it keeps on propagating, ends up in thromboembolic events, including life-threatening conditions. And in our hospitalized patients, ICU patients, where do they generate? Most of us usually think that it is usually in the lower limbs, legs, thighs, and lower limbs, but also in contrast to that, it also does originate in the upper limbs, like especially in patients who have long-standing central line catheters or the hemodialysis catheters, porta cath, etc. And also iliophalmic veins are actually a big huge seat of venous bed where these can originate as well. I'll start with the case scenario. It's a 22-year-old man who had sustained a femur fracture diagnosed outside and shifted to our hospital from periphery or after day 5th of the fracture. Now on day 2 of the hospital admissions in our place at 2 p.m. when actually he himself was assisted to go to the bathroom, while returning he suddenly collapsed. We were just finishing rounds on a Sunday, and then he had a cardiac arrest, brief CPR was done. He was brought to ICU with 12 liters of oxygen, saturation hovering around 85 to 88%. BP was 80/40, and there was tachycardia. So what would be the diagnosis? That's a very frank case of thromboembolic event. When DVT with thromboembolic event, you'd think, and of course there remains also a differential diagnosis of fat embolism in these cases, because it's a long bone fracture. So just quickly go through this long list of risk factors which can give rise to venous thrombosis and thromboembolic event in these patients. First and foremost is age, obesity, immobility. Immobility leading to arising from any kind of systemic illnesses, be it sepsis, multi-organ failure, fracture, any kind of post-op surgery, etc. And of course there are many other medical cases also, conditions which can be responsible for immobility and giving rise to this. And this is a long list. I'm not going to go through it. These are available in any routine textbooks or the literature. And of all the medical cases, we see ours being a now onco center, we see a lot of oncological cases, and believe me, malignancy is a very high risk factors for fitting the right background for DVT and embolism, and it goes unnoticed because most of these patients will be malnourished, they'll be confined to bed, they'll be just generally weak, there'll be tachycardia, there'll be little tachypneic, so you will not know if this submassive subclinical embolism would have started, and sudden one fine day they just collapse, and it can be attributed to it was due to cancer, patient was weak, etc. But this could be highly likely to have pulmonary embolism event. And you see if you see the incident, it's a wide variation, starting from 10 to 80%. So it's a wide variation. So suspect risk factors and then preemptive the diagnosis is the most important step, I would say, rather than waiting for the event to happen and then trying to save lives. So summarizing how you diagnose acute PE, which could be life-threatening, patients who are risk factors, every patient that we see in the hospital, in the wards or in the intensive care unit, apart from this daily fast track assessment, we must see T is T stands for thromboprophylaxis, is one of the important component for assessment, and you need to assess if these patients require DVT prophylaxis or not, either mechanical, pharmacological or combined assessment. And then look for signs and symptoms. Every signs and symptoms you see need not be assessed to either sepsis or just pain or discomfort. That keep in mind somewhere, though diagnosis pulmonary embolism as a diagnosis of exclusion, there could be an element of PE. In these cases, if your sudden oxygen requirement is increasing, patient has unexplained tachycardia, and we have all seen it during COVID times, like every patient suppose recovering, suddenly they develop tachycardia, and most of these cases, yes or no, it was probably some submassive pulmonary embolism. Clinical examination is important. Most of our patients, while they are lying, they are covered, and the lower part of the body, including the genitals, are covered with sheets, and we are in the habit of this, we are so used to this equipments and reports that patients, we just talk about it, you stand by the patient side, but we do not uncover the patient to see what is happening. And remember, many times you would see there will be a cough, swollen cough, there will be some thigh pain. Patient, the staff nurse may not have noticed, and it is up to the nurses, of course, during the grand round during the day, that you must examine the patients from head to toe with your hands, to see if there is any abnormal swelling or not. And more often we see this in neuro patients because they are is it not audible? Okay. Better? So most of the patients, it is in neuro cases, mostly the TB, traumatic polytrauma or the traumatic brain injury, stroke cases. They'll be lying for long. You already talk about bedsore hair and other things you see, but we do not examine. If you have seen the patient on Monday, you do not think it's necessary to see on Tuesday. But these patients are the ones who are very high risk, and whatever assessment you do, either, as I said, mechanical, pharmacological or combined prophylaxis is highly recommended in these cases according to the cases. And then imaging is of course necessary. Imaging again depends on the hemodynamic stability. If a patient is unstable, many times we see suddenly like this patient crashed in the ward. He was with 12 or 15 liters of oxygen, BP was low. This is not a very prudent idea to immediately take these patients for CT pulmonary angiogram. You can bring these patients, stabilize the patient, because the patient has to survive first to have advantages of any subsequent interventions or therapy. And we have many modalities, like mostly what you take help of these days are this 2D echocardiography by the bedside, and of course you have some of the lab tests we will discuss, and CT pulmonary angio though remains the gold standard for diagnosis, but of course it depends on the context specific state. So why am I worried about it? Why a pulmonary embolism becomes life-threatening? Because when there is a massive PE, you see it causes physical obstruction of the pulmonary vasculature. So there is a physical factor and there is a neurohormonal factor which leads to increase in the pulmonary artery pressures, increase in the right ventricular afterload. So there is dilatation of the right ventricle, it leads to right heart dysfunctions. And once there is right RV dilatation, it shifts the interventricular septum to the left side. So LV preload also reduces, LV output reduces, there is hypotension, and it leads to decreased systemic perfusion. At the same time, there is increased RV wall pressure that compresses the coronaries. So again, perfusion of the right ventricle also goes down. So all these are combinedly reduced to cardiac dysfunctions, and there is hypotension leading to systemic perfusion. And because the pressures are increased, you have physical obstruction of the pulmonary vasculatures. That is VQ mismatch, profound VQ mismatch at the pulmonary bed, which leads to this disproportionate hypoxia. Remember, in cases of PE, what abnormality you see mostly is disproportionate hypoxia, and this CO2 level is low. That is hypocarbia, because patient is hyperventilating. And this kind of hypoxia are a little different to other kind of respiratory failures. These patients usually tend to remain alert for a long time, though they are hypoxia requiring higher oxygen, compared to other kind of patients where probably both CO2 and O2 may be affected simultaneously, because they are chronic. It gives you time, but this is because acute, and it's one of the obstructive causes of shock as well. So this is a distinct feature of hypoxia in cases of acute PE. Signs and symptoms again vary widely, but life-threatening cases, as I'm talking, usually there is hemodynamic instability, and you'll find life-threatening signs in these cases. Now, what about how you predict it? Apart from those risk factors assessment, there are various probability prediction scores are there. This is Wells variable course. I'm not going to the details. Based on this, they have been divided into low probability, intermediate probability, and high probability. Why you are talking about it? Because you see, when you see patients in ICU or hospital in the wards, there is if your multidisciplinary team is managing a patient, there is a contradiction of opinions. Somebody say, nahi, heparin dene se bleeding ho jayega, I will not give patients. Suppose a classic case of CLD, chronic liver disease patients. Many think that they are having high INR and they are prone to bleed. But in contrast to that, these patients are actually, they are more prone to thrombotic also. They are hyperthrombotic as well, because coagulation factor, whatever routine test we do, PT, PTT, INR are only part of, they look at only part of this cycle or this coagulation cascade that we do. There are many other kind of factors which are not assessed by those routine tests, and only thromboelastogram can assess those, but which are again not routinely available, and it's not necessary to do so also. So again, depending on the patient's clinical status, mobilization status, we have to assess this risk probability scores. Now what about this? There is another score called Geneva score. This is again divides into low, medium, and high probability. There's a well predictions rule that we have already discussed. So based on this, DVT is either likely or unlikely. You can see once the patient develops some signs and symptoms in these cases. And this is a pretest probability of DVT going into developing pulmonary embolism. DVT does not equate to pulmonary embolism. It could be local, but when it disseminates, it becomes embolism. So massive pulmonary embolism, as you have come to understand, it can lead to one of the obstructive causes of shock, and also a cardiac component also can add in as when the RV dysfunction starts, and multisystem organ failure can set in these patients. All organs again get affected because there is systemic hypoperfusion. And what about this clot? This clot are usually massive. They are usually present bilaterally on both the side vasculatures. Chest pain may or may not be present. That is again a distinct sign or difference in these cases. And hypotension again has to be addressed as we address hypotension in other cases, like with fluid boluses and followed by vasopressors. And if your patient is frankly going into respiratory failure, you have to intubate these patients. Massive to moderate to submassive pulmonary embolism, again around 60 to 70% of the vasculature is affected, but these patients remain at repeated risk of embolism, which might become life-threatening embolism at some point of time. Pulmonary infarctions is one of the important differential diagnoses of sepsis mimics. We cannot diagnose it on the X-rays. But you see patients of suppose was recovering, suddenly develops fever, they have leukocytosis, tachypneic, it's not looking frankly septic. You do not have really any reason to suspect sepsis in those cases. Keep this in mind as a pulmonary infections. It is again a diagnosis of exclusion though in these cases. Non-thrombotic pulmonary embolism, we are not going to discuss in details, but remember in all polytrauma cases, especially in the context of long bone fractures and even pelvic fractures, they are an important differential diagnosis because it can happen, and it again goes unnoticed because these patients may develop it slowly, chronically over a period of time. I remember seeing a patient who had polytrauma, he has an external fixator done, shifted to ward because he was hemodynamically stable. That was on weekend. On Monday when I went and saw that patient, he was in general ward. And he was, initially when we shifted from ICU, he was just on 1 liter oxygen. He was probably started developing fat embolism at that point of time. He was on room air, then he required 1 or 2 liter of oxygen. On Monday after 48 hours, when I went and saw this patient on a reference basis, he was on almost 6 liters oxygen mask. And what the attending staff will do is, patient was not complaining of hypo, he was just dull, he was not eating and drinking, and nobody probably just thought of checking the saturations. When I checked the saturation, it was 77% with 6% of with 6 liter of oxygen. Patient was not overtly tachypneic. So this kind of permutation and combinations can happen in these patients. Unless the patient manifests signs of respiratory failure, tachypnea, tachycardia, which is the most common ones, then it may not draw attention that patient might have developed saturation, develop embolism in these cases. But the clue here was increasing oxygen requirement. Somebody is requiring more and more oxygen, that person needs to be evaluated. And for fat embolism, again, it's a diagnosis of exclusion because there is no particular test that can clinch you the diagnosis, unlike the thromboembolism cases. So these remain the important differential diagnosis of PE. Sepsis and septic shock, of course, in a patient who has been in the hospital for a long time, TBI, lines, urinary tract catheter, they come with these kind of things and with the background of fever. First and foremost comes is sepsis, because we always think of common things are commoner. But do not forget to rule out this pulmonary embolism also. And that could be a wide variety of other presentations as well. What are the blood tests that we commonly do? Most common is D-dimer, and also if you think there is a cardiac dysfunctions, because myocardial infarction is also one of the important differential diagnoses, we end up sending this cardiac biomarkers. Small is the proBNP and cardiac troponins. Plasma D-dimer assay. I think this is almost all of us do believe in this, and remember this has got high negative predictive value. If it is negative, it rules out PE, but if it is positive, it need not necessarily counts it in. It definitely raises your probability of having either DVT or pulmonary embolism according to the cases. So a normal D-dimer assay appears to exclude PE rather than, so it has got a high negative predictive value. Now what are the ECG signs of pulmonary embolism? What is the commonest ECG sign that we see in these cases? Suppose that patient who came, of course he was too unstable, but if I do, what is the commonest ECG manifestation in a case of pulmonary embolism? This is S1, Q3, T3. Most of us, we have seen this red disc during our MBBS and post-graduation day. Sinus tachycardia, atrial fibrillation, ventricular fibrillation. What is the commonest one? Sinus tachycardia. This is the commonest one, because though this is the classic one, you see, I have probably never seen this in my 18 years of practice, and I would say sinus tachycardia is the commonest. And if it is sudden onset, always remember keep it as an important differential diagnosis, because it could be just submassive, apart from electrolytes, pain, etc. and other things. Chest radiogram, again, what is important is a normal or an oligemic chest x-ray in the context of hypoxia, which is requiring higher oxygen, patient is going into respiratory failure. That is most important. Echo signs, as we have understood the pathophysiology, there will be RV enlargement, RV dysfunctions would be there, and various, if you are doing good for the Doppler and the velocity studies, there will be, you will find those values, and there will be a dilated IVC also. If there is an obstructed, there is a backward pressure, and inferior vena cava would be dilated. And if you are going for a direct TEE, transthoracic echo, which is very rarely done and feasible in these cases, you can visualize the direct thrombus also. CT pulmonary angiogram remains the gold standard. You give a contrast, you are giving fluids, you give a contrast, you can localize the location of the thrombus, various distributions, any other and concomitant pathologies like pleural effusion, collapse, etc. you can see in these patients. But of course, this organ function and the feasibility of transport has to be kept in mind. If a patient is hemodynamically unstable, he is not, airway is not secure, it is certainly not prudent to shift those patients to CTPA just because you want to deliver or you want to go for thrombolysis. You have to, in those cases, do intubate those patients, take them for a ride to the CT scan and bring it back and then do, but do not take them if they are not stabilized. So this is just few pictures of a thrombus. You can see this is the gross filling defect, and this is a subsegmental vessel. Subsegmental vessel, there is a thrombus. It's called like a small pillet is there. It's a Polo-Mint sign. Pulmonary angiogram directly is not practiced these days because CTPA has taken over. But some of the cases when they are going to directly address or remove this thrombus, this like suction catheter embolectomy, mechanical clot fragmentations, or catheter directed thrombolysis, if you are planning, this can be done, and usually it is performed in the cath lab. Again, the infrastructure has to be there and the expertise has to be there. Lung scans are again rarely performed these days, only if there are contraindications for doing CTPAs and you are not able to give contrast, etc. These indications, you can think of obtaining a lung scan. There is a renal insufficiency, anaphylaxis, pregnancy cases, of course it's not a preferred one. Duplex ultrasonography. This has become very popular these days. Not only this one, the cardiac and the local echocardiogram of the vessel suspected areas also is being increasingly practiced. Again, you need to have the infrastructure and the expertise as well. But one of the greatest disadvantage of this it might miss the iliopelvic veins, because there's a large seat of blood vasculature is there, venous vasculature is there, and your probe may not be able to penetrate there. If you're doing it per abdomen or on the pelvis area, if your bowels have to be deflated, if they're inflated with gases, etc., you cannot assess these things. Contrast venography is also again not commonly performed. However, if you are going for this for IVC filter placement, and in patients who have got THR or TKR done, these patients, it is more sensitive than venous ultrasonography. But you have the risk of contrast exposure, and you have to take care for your kidneys as well. So of course, patient who is unstable, chances of mortality is more, with more of organ dysfunctions. Now how you manage? High risk cases, massive PE, you have to go for thrombolysis after, of course, judicious assessment and risk factor assessment, and do explain to these patients, because this is a thrombolysis, a lot of complications can happen, and these patients already are having risk factors, so the probability having complications are also high. Most important these days is about documentations. Apart from cost, documentation is important, because something goes wrong. If you think there is a cardiac arrest situation like these patients, we are almost ready to thrombolyze these patients, young patient. If something goes wrong before suppose the next of kin comes, then if you're just doing it, you're thinking that in a good faith that I'm going to save life, but if there is an ICH thereafter, you will be caught for that if there is no proper documentation and consent has not been obtained. So if any particular attendant, from practice point of view, I would emphasize again in these points, because many of the peripheral centers now, people have become very scared of thrombolysis because of these complications. They have gone into medical legal issues, so say kya karna hai, we will not do, they give just heparin and supportive things, they do not go for thrombolysis. But if you keep your path straight with documentations and all that, it is safer to do that. Intermediate risk and the patients who are less unstable, you can think of anticoagulations and prophylaxis after stabilization in these cases. So these are the doses. These are available in most of the textbook and the literature are there. You can most commonly in the acute situations we use unfractionated or standard heparin. You give according to the body weight and try to maintain a therapeutic APT for around 60 to 80 seconds. And you repeat it around 6 to 4 hourly according to the patient's APTT values and titrate it. What are the agents we use for massive PE for thrombolysis? Altiplase, urokinase and streptokinase is there. In our place, we mostly use altiplase. This is a stress easier to use, 100 milligram infusion over 2 hours, and it is followed by unfractionated heparin. There are different doses of different agents that we can find out from the charts. These are the doses, and there is retiplase, tenecteplase is also available in some of the places, and these are usually costly drugs, so the cost, if the patient is to incur that cost, it better be explained to the patient and as in document as I mentioned. This is the initial bolus dose around 80 units per kg, and then infusion of around 18 units per kg, but this is all titration based. Make sure that you have a good IV line and you have a sampling line, because you are also often going to prick those patients for sampling. So it is these two things are necessary for these cases. Now the question arises, one of the dilemmas commonly in practice is when to use heparin before and after thrombolysis. This is need to note that we have to discontinue the continuous infusion of IV of standard heparin as soon as you have decided to go for thrombolysis in these cases. Suppose you are waiting for the family to come and give consent, you have started standard heparin infusions. Once the decision is made for a thrombolysis, stop the heparin. Both cannot happen simultaneously. But at the same time, do not wait for APTT. You do not think that I'll send an APTT, I'll see what the APTT is, and then I'll thrombolyze. Because if you have to thrombolyze, you have to dissolve the clot to save life, to relieve the obstruction, you have to thrombolyze immediately. And infuse thrombolysis as soon as it is available. At the conclusion of 2-hour infusion, suppose you are using the altiplase, then obtain a start APTT. Now your APTT is less than 80 seconds, then you resume unfractionated heparin as a continuous infusion. No need of bolus in those cases. But if your APTT is more than 8 seconds, then hold off for starting the heparin for 4 hours and then repeat the APTT. And if it is less than 80 seconds, you can start again heparin infusion without a bolus. And of course, avoid the unnecessary pricks in those periods unless it is necessary. You can always think about switching on to the oral therapies, commonly warfarin, and now you have this DOACs, that is direct or acting oral anticoagulants, so the near-acting oral anticoagulants are there. These are the different ones, fondaparinux, idraparinux, and there are a variety of drugs that is expanding day by day. These are the doses for these patients according to the body weight, and this is very convenient. Patients who are go on require therapy for 3 months, 6 months, or even longer, depending on the case. These are convenient for oral home therapies. These are the synthetic direct factor 10A inhibitors. Dosing is very convenient. It's almost they're replacing this warfarin these days. And then how long to go for therapy? Because this is also a question often asked. Transient risk factors are there, usually 3 months would be probably suffice. But if you have an unprovoked thrombosis, then 6 to 12 months again is necessary. Of course, when these patients we are calling for follow-up, you have to screen their legs or the site of origin for thrombosis, thrombus size, etc. Cancer-related VTE, usually it is required till the cancer remains active. And I have seen mostly in the advanced stages of cancer, stage 3, stage 4, once they develop, usually their mortality, their prognosis is not good, survival chances are not high, but you have to continue thrombolysis in those cases, anticoagulation in those cases till long, because these patients usually get immobilized, poor nutrition, etc. But then the dilemmas do arise. Like recently we had a patient who had got a periampullary carcinoma. This patient had a DVT. We could not, of course, thrombolyze this case, and an IVC filter was put, and then he was started on oral anticoagulants. But then he started developing GI bleed. This is mostly to the local invasive nature of the disease. This is not due to systemic anticoagulations. So these are the permutation and combinations you'll get in your daily life when you see cases. Again, you have to weigh the risk and the benefit ratio in those cases. And we did continue anticoagulation, but of course we switched to standard heparin in that case. Just a quick look at this IVC filters. These have become very popular these days. These are the preliminary ones, and things have become more and more modified. The material that they are manufacturing this IVC filter are getting more and more biocompatible. That's what they claim, and it is being performed in most of the cath labs. It is easy to perform compared to other angiographic interventions. But they have their own. What are the accepted indications? If we have contraindications to anticoagulations, and as the first case I mentioned about the periampullary carcinoma, bleeding complications during anticoagulations, there is extension of thrombosis or recurrent PE during therapeutic anticoagulations, and patients who might be having chronic thromboembolic pulmonary hypertensions. In acute situation, it is usually difficult to put. Usually it is semi-elective when you have time, because you have to prepare these patients. They have, there are possible lot of complications for these filters. There could be reactions, dysarrhythmias during the placement of this IVC filter. You could have chances of air embolism and other intervention related complications. Filter can migrate, filter can fracture. You saw these things, these are metals, and these might fracture. A bit of it might fracture and go in the circulation, and it's very difficult to diagnose or capture those where it has lost, etc. So it's not without complication free. So go for cases where it is necessary only. Again, it has cost issues also is there. Now, catheter-related embolectomy. This is again a more directive invasive therapy. Patients where you cannot do or do not want to do systemic thrombolysis or anticoagulations. You can, and expertise has to be available. The infrastructure has to be available. You can put a catheter in that vein, suppose in the pulmonary vasculature, and try to extract the embolus or do a direct catheter-directed thrombolysis in those cases, and using those same agents that you are giving systematically for thrombolysis. These are the different catheters that are used for these purposes. I'm not going to the details of this. Surgical embolectomy is very, very rare in these cases unless you are having an open heart surgery for whatever other reason is there. It is rarely performed in this these days. Fat embolism, as I say, always should remain a important differential diagnosis in these cases. There are few criteria, minor and major criteria that we see, but it's again a diagnosis of suspicion and exclusion. You have to suspect it, then you can find it. And if you're very lucky, classically, recently we had a patient, this patient that I was talking about, when I brought him to ICU, the catheter was covered in a sheet. We found there was some whitish urine, flat globules. It was very rare those days, these days. General factors, usually males are affected, young patients, and multiple long bone fractures. So key points summarizing, remember that we have to remember the risk factors, assess every patient that we see in the medical ward or in the intensive care unit for assessing risk factors for developing thromboembolisms if they are mobilized, not being mobilized for a long time. It is usually sudden in onset and it's a diagnosis with exclusion. Local and systemic examinations are important, followed by of course your blood tests like this ECG, etc., ultrasound, echo and CTPA as when possible. Thrombolysis for hemodynamically unstable patients is definitely necessary. Do assess those cases, do document and proceed for these cases. Prevention is always better than cure, and it is one of the important parameters of the care plan in our patients as part of the fast track. Thank you very much for your kind attention. Any questions or comments? Thank you.
Yeah, you can hear me?
Yes, sir.
Yeah. Good morning. My name is Sanjay. I'm just wondering about a few things that you mentioned. In the earlier days, warfarin was the way to anticoagulate people and to think about the therapeutic. When you mentioned about some cases about particularly hepatic failure or so, raised INR, is there any cutoff that you have seen in your personal practice that this was the INR, highest INR? In spite of the INR, the PE was diagnosed or the patient had a thromboembolic event? Because you mentioned don't go by those figures. Second is, are we lacking in the CPR guidelines about the emphasis on PE? Third question is about the radiographic finding. The first line that you mentioned was, if you see a chest X-ray which is clear, possibility of massive PE. I think most of the clinical experience will indicate that it's rarely that you see an X-ray which is not having some wedge shape facility or some abnormality that you start suspecting PE, which is not a very common suspicion. Thirdly, about the electromechanical dissociation and the lack of a training sort of or a group involvement where somebody would be daring to get to the pulmonary artery and do an embolectomy as a salvage procedure. So few things and hematology involvement. Are there hematologists that you routinely involved in such cases? Thank you.
Right, I actually forgot the first question because you have five. Okay. So actually it's a very good question because we have also a very busy gastroenterology unit, and most of the times these patients are sick in multi-organ issues when they come. And recently only we had a patient who had got dilated cardiomyopathy. He had developed decompensated CLD with dialysis dependent CKD also. You can CKD or hepatorenal, that I do not know when he came. He was almost in a bad stage, but he was conscious. He was little encephalopathic, but airway was maintained. And this patient had developed, he had a swollen leg, unilateral leg, and there was a DVT present. It was documented. And INR was 4.3, this patient. There was a DVT was there. We do not have thromboelastogram. And these patients, remember many a times, if I have patient, a CLD patient come, other patients I am telling, patient will come, so whatever reasons, INR is 3, the gastro team will go, no, don't put a central line, do FFP and then put a central line. They do not always bleed. It is one of the components in that coagulation cascade that we measure, shows as PT or PT or INR. But they have many other procoagulant factors also which are there and which makes the patient actually prothrombotic. So this classic patient which I am telling now, this patient had a documented DVT was there. We did systemic doses of hypertension and he did not die of dialysis. He of course passed away after a few days, but he did not die of bleeding. He had a DCM, he had arrhythmias and he passed away. Probably it would have embolized again, we do not know. He had too many issues. So as high as, if you ask me, the last case I am telling is 4.3 of INR. So best cases, if we have a problem or dilemma in these cases, is to send the samples from TEG, at least 5 or 10 cases, suppose it's center specific, because this kind of discussions do arise among multidisciplinary participants, and if you have to convince them, if you have a cardiothoracic unit, you are using TEG, just send the blood and show them what is, how much is procoagulant, how much is prothrombosis or antithrombosis, and then you can establish your case for starting the VT prophylaxis for these cases. Second is about, you told about CPR. I think CPR in ACLS, they have this 5 Ts and 5 Hs are there. One of the 5 Ts is about this tension, obstructive shock, that is thromboembolism, it is there. Again, it is when you are giving CPR, just because it is not coming out. If suppose you have discovered a swollen leg, that case is something you can go for thrombolysis. But having said that, compared to the Western cases, because AHA guidelines are Western made, and we also have a ICLR, Indian Resuscitation Council has adopted those, etc. But if you're just seeing a thing and without, as I mentioned about documentations and consent, that is very important. Suppose I give this, in a good faith, that in the night 2 a.m., this has happened, my team is doing, and they see a swollen limb and they give a thrombolysis without taking consent and documentations. It is going to be a difficult task because the patient may not survive, either whatever reason it is. And if the patient, an expensive drug has been given, there is a complications, and they may later on say the patient might have bleed, etc. There are Google and doctors, etc. So that's going to be a problem. So I think you have to have a very close and fast state of communication periods of time. You can always say that we thought of it, we try to give it, because it does give you some time. When you're giving 2-3 cycles of CPR, you have at least 6 to 8 minutes for the procure time for these cases. But it is very important, and it cannot be overemphasized, that systemic patient examinations on a daily basis is important, more so in the cases of cardiac arrest, because you might be seeing missing cases. Many patients have been discharged even with a femoral central lines home, because it remains covered, it is in the groin area, patient ko pata nahi hai, I mean it's not very obstructive. They have been discharged and they have come back with a DVT. We had a patient, actually polytrauma patient, who was discharged from ward in such a manner. About this, you talked about embolectomy. Surgical embolectomy is not the first way. Nobody, I mean, I would say across the world also, I worked in Australia also, no one right away goes for surgical extractions. Only in chronic recurrent cases when patients have been stabilized and not being able to from ventilator, etc. And those days, again, this good agents were not available. They will probably attempt it. But remember, such a therapy where they are doing a thoracotomy and doing opening the vessels to extract therapy, these cases are really bad and they do not do well.
Just add actually, 2021 AHA guidelines clear-cut mention that even if patient arrested and clinically you think that the patient has a pulmonary embolism, even if you have pulmonary angio, you can thrombolyze the patient. Regarding hematology, they say now, if you feel and anticipate the patient needs anticoagulation for long term, then only you investigate this potency and thrombophilic profile, but not in first 3 years. Thank you.
Good morning. So we recently had a patient, late 30s patient, who underwent orthopedic surgery on her ankle, and she was obese, and she was about to get discharged, and in the process of getting discharged, she was mobilized out of the bed, and they were about to leave, and then she collapsed. So code yellow, and then we ran, resuscitated, and the clinical suspicion was pulmonary thromboembolism. We got her to ICU while doing CPR, and then we continued CPR for 2 hours, and it was only clinical suspicion because we couldn't get her to any investigative modalities, and we also got bedside echo. And we definitely suspected pulmonary thromboembolism and then thrombolized as well. And finally, 2 hours time, we could get her heart back. Cardiac output, spontaneous cardiac output was there. But finally, we lost the patient for neurological insult. In this situation, we suspected and then we treated with thrombolysis, but we couldn't get the patient back to normal. So we were reviewing the literature, and then the question was, what is the role of ECMO in this situation? So is this something that we can think of? If we are a regular ECMO center, probably it's an option, and it won't take too long for activating the ECMO. But what is the role of ECMO is my question. And the question number 2 is, what are the long-term consequences? So it's a submassive pulmonary thromboembolism, you thrombolized it, and then if the pulmonary vasculature, smaller vasculature, gets blocked with the thrombolized fragments of thrombolysis, are they at risk of long-term pulmonary hypertension? is my second question.
Yes, first question about ECMO. Of course, if you are an ECMO center, you have the infrastructure and expertise. It's a kind of shock, isn't it? Either at the outset you think it is cardiogenic with a thrombotic component, or the thrombotic is added to the cardiac component. You can very well go for a VA ECMO in these cases. And at the same time, try to draw more evidence in favor of a thrombosis and go for, anyway, you are systematically anticoagulating these patients when you are putting them on ECMO. That might itself do the job to some extent to lyse the clots. And of course, you are supporting the circulation or the hypoperfusion at that point of time. So ECMO is certainly an option if it is available in your center. Number two, about doing this chronic pulmonary embolism, I think that's what I also mentioned, because these are the cases who are submassive, recurrent pulmonary PEs are there, and they go and lodge in the smaller vessels and are a case for chronic hypertensive. And this is one of the KLB indications for IVC placement. Good quality IVC, biocompatible IVC filters are available, and it is usually technically also easier to put compared to this extra catheter-related thrombolysis or extraction, etc. That can be put these patients on long-term anticoagulation, and some of them actually would also qualify for lifetime anticoagulations. And then after some time, 6 months, 1 year, something, the IVC filter also can be removed. But definitely they can be again, you just put them for follow-up on the basis, on the OPD basis with regular follow-ups, and PA pressures can be measured in these cases. And I would put a mention, a word of caution for all practitioners and for all of us actually. What is happening in the community, as I see, is we being a higher centers, many patients like this patient example I mentioned, fracture has happened 5 days ago. He comes to hospital, so that is day 6 of his fracture. On day 7, he had a cardiac arrest. I mean, as a thrombus and a cardiac arrest. So these kind of patients, sometimes he may not, if suppose this patient would have gone to OT table, and actually there was also a case in the city, the patient on the OT table after induction, the patient, or peri-induction, the patient developed cardiac arrest, right? And when they did an immediate ultrasound in that place, then they found there was a big thrombus in the calf veins, right? So these patients, again, if they are showing thromboembolism on this kind of perioperative period, it becomes a very challenge, especially once the patient is inside the theater. And that becomes a huge case, because they would say patient was conscious, acha gaya tha bhi, patient is unstable, and that patient died also. So these cases, I would say that if they are coming from outside, do screen these patients also. Just a venous screening, Doppler screening to see if they have developed thrombosis at least in the leg veins or not, because of course then you are not excluding the iliopelvic veins, because that is not accessible by the duplex ultrascan that we routinely perform. And then the point is, do mention in the files that this patient is coming after 5 and 7 days of the fracture. There is chance of thrombosis and thromboembolism in the perioperative period. You cannot pinpoint, of course, and of course we are taking maximum caution as possible. Even if you are giving, suppose this patient would have started heparin 6 hours, 12 hours before, it has to stop for the surgery, isn't it? Of course, but documentation would count in the court of law if you are being questioned for that. Thank you very much.
Thank you.
Thank you, Dr. Sharmili Sinha. Now I am requesting Dr. Suman to felicitate Dr. Sharmili Sinha. Now I am requesting chairperson to be on stage only for next talk. So as we all know, the ICUs are hubs of infection, and we are frequently dealing with the sepsis. Sometimes the diagnosis of sepsis is the next challenge. So to talk about paradigm shift in the sepsis diagnosis, I would like to call Dr. Aruna Pujari, who is HOD of Clinical Microbiology, Bridge Candy. Over to you, Dr. Aruna Pujari.
Good morning, everyone. And at the outset, I'd like to thank Dr. Akshay and the Apollo Clinical Intensive Care team for giving me this opportunity to be here and sharing some of our experiences in some newer diagnostics. for the diagnosis of sepsis. So what we are going to talk about is there a paradigm shift really in the diagnosis of sepsis, an important problem in the ICU situations. And I think this slide is very much familiar to all of us. We all know that ICU is a hub where you have a lot of sepsis cases. Unfortunately, we also know that sepsis is associated with deaths. And we also know in a situation like India, which is endemic for resistance, a lot of these cases or the pathogens that are involved are actually drug resistant. So we struggle for antimicrobial therapy, appropriate antimicrobial therapy, because of this resistance, and then that also might be responsible for increasing the mortality. And plenty of such studies have been done here in India, which have been point prevalence, which indicate all of these that I have said, and that's one more reason why we need to probably diagnose sepsis early and treat it optimally in the beginning itself. And yet there's another concept that all of us need to remember is that sepsis is actually a syndrome. And it's extremely important to track the source of infection. We know that it could be a bloodstream infection could arise from a urinary tract, from the respiratory tract, from CNS, from bone and joint. So you need to identify where is this really arising from, and that should also be there at the back of the mind so that one can send, apart from blood cultures, one can send specific site-specific cultures in order to be able to pick up the pathogens. So cultures are really the gold standard. They have diagnostic as well as prognostic significance. And commonly the cultures that we send within the first hour would be definitely blood cultures. If you have any site-specific site which is very specific and you identify that this could be the reason for infection or sepsis, then there like urine, sputum and things like that could also be sent as part of the bunch of investigations that we send for the initial diagnosis. Yet we all know that particularly when it comes to blood cultures, we know that time, there's too much time. You don't get results in the first 18 or 24 hours. It's much after that we would get results, usually after about 48 hours. And we lose out on the crucial time of the initial probably 3 to 4 hours to understand what the pathogen is and give directed therapy. So what we really do is basically start on empiric therapy based upon which is the site of infection, what pathogens could be prevalent over there, whether it's hospital acquired, whether it's community acquired, and so on and so forth. So the need of the hour, really speaking, is real rapid microbiology diagnosis. And we know that we cannot really bank on cultures. Is there a pointer here? Okay, so we know that we cannot really bank on cultures. If we were to bank on cultures, this is what would happen, In about 48 to 72 hours, you would get the first results. But what's happening is things are changing. We know that sepsis needs to be identified, the pathogen causing sepsis needs to be identified early. And that's where these two methods have evolved. So one is after the culture, the blood culture comes positive, there are certain methods that are now available at our disposal so that we will diagnose the pathogen that is causing, that's the causative agent or the etiology earlier, preferably within 24 hours. And there is another methodology which is, direct patient testing. You don't have to rely on your cultures. Of course, you will do your cultures as of today, and yet you don't have to rely on them to flash positive. You can directly perform certain set of testing from the blood specimen. So these are very helpful in patients with sepsis and septic shock in an immunocompromised host, and as well as in those patients who may have a risk of multi-drug resistant pathogens, which is very common in our situation. So for this B type of methods, we have the MALDI-TOF, which is mass spec, and we have syndromic multiplex PCR panels. And for this, we have the T2MR, that is magnetic resonance testing, and we have the metagenomic sequencing, and I will be discussing these in sequence. So coming to the syndromic panels, we know that these syndromic panels are available in India for now close to almost around 8 years. So the process is that you have blood cultures drawn out, they are incubated in an automated system. Once they flash positive, the conventional method would be going about doing a subculture and then doing DST, whether automated or disk diffusion. So that would naturally take time close to 48 to 72 hours. But here what would happen is if a blood culture comes positive, you directly put it into a syndromic panel system wherein you will get a whole lot of targets. There are about 43 targets of bacteria, fungi, and also drug-resistant genes. And amongst the bacteria, you also have anaerobes being present, a whole lot of gram-positive and gram-negative, and a whole lot of antibiotic-resistant genes. So imagine you have a blood culture positive, and from there, in the next 1.5 hours, you are going to get what is the pathogen, the organism identification. This is particularly useful in Candida, because if you really see Candida, probably once the blood culture is positive and I make a smear, I can only tell you that this is an yeast. Okay, rarely I can tell you that this looks like trichosporon, but apart from that, I can't tell you anything more than that at that point in time within maybe an hour. All my results come the next day, so it is at 48 hours or 72 hours to give you an ID and DST. That much time it will take, but here with the gamut of targets that it has for Candida, you could even have Candida auris being picked up, which is a common pathogen to us. And also similarly, it also has Cryptococcus. So that's really an advantage, and literature has shown good concordance with conventional blood cultures, and it provides results within 24 hours. So usually the hands-on time is around, the TAT is around somewhere around 2 hours. And it can help you detect vancomycin-resistant enterococci, methicillin-resistant staph, and carbapenem-resistant enterobacteriales very, very quickly within this time. So there are some studies which have been conducted. Globally, there have been studies, and plenty of studies. I've just chosen 2 of them, which have shown that these kind of technologies actually help in rapid identification, and it also helps in supporting your stewardship programs by improving your the targeted antimicrobial therapy based upon the agent that has been identified. So similarly, another study which looked at just conventional methods, use of rapid multiplex PCRs along with blood cultures coming positive, and the use of multiplex PCRs along with stewardship interventions. That is, if you get the result, you make a change. Whatever is the change, it could be escalation or de-escalation, and clearly what it found is that rapid use of rapid PCRs reduced treatment of contaminants, because we know the coagulase negative staph often, unless you have 2 blood cultures flashing coagulase negative staph, one would really think about or suspect about contaminants. So it reduced the treatment of contaminants. And secondly, when rapid PCRs were combined with stewardship, it not only helped in shortening the time of antibiotic escalation, but it also led to rapid de-escalation. If you see, this is what I'm talking about. This is de-escalation, and that could happen within 24 hours based upon what organisms were detected. So this is a sample to result format with minimal hands-on time of about 1.5 hours. It could range to 1.5 to 3 hours depending upon centers and how much availability of the slots is there. Wide range of aerobic, anaerobic bacteria and yeasts are present as targets. There are common drug-resistant gene targets also that are available, most of them which are useful to us. And it has a small footprint from my lab perspective, because I don't have much space in the lab for so many instruments. So a small one definitely helps. The disadvantage is that it has defined targets. So if you have an outbreak with Elizabeth Kingia meningosepticum, trust me, even if your blood culture comes positive, this particular panel is not going to pick it up, and it will go as not detected because this target is not there. So there are defined set of targets, and if that target is not available, it would turn out to be negative. It requires positive blood culture bottle, so you can't do it with a negative blood culture bottle. You need to have a positive blood culture bottle, and occasionally there are false positive flags for the targets, and this we have seen in approximately probably less than 0.5%, but it becomes important, particularly if you have a CRE pathogen being picked up. and then on culture, you don't see drug resistance being present. So based upon this result, you have already informed the clinical team that there's carbapenem resistance. We have picked up genes. This is rare, but nonetheless can happen because it's a very sensitive technology and it can pick up ARGs like that. Moving on to the next method, which is again from a blood culture positive situation. So this is protein-based mass spectral identification. So basically what you're doing is you're trying to identify the organism based upon the proteins that are present within the organism. Again here, what's important is it's lightning fast. So when it comes to your routine bacteria and yeast, probably half an hour is the time after growing these organisms that you could actually get an identification. In fact, some of the systems have a process where you can get identification directly from a blood culture bottle that is positive. You don't need to grow them. The cost here is minimal and with virtually no consumables, and it can identify absolutely anything that can grow on a plate. So viruses it cannot identify as yet, but anything that can grow on a plate it can identify. So your aerobic bacteria, yeast, aerobic, anaerobic bacteria, yeast, filamentous fungi, mycobacteria, nocardia, all of those it can actually identify. And similarly, there are plenty of studies evaluating the utility of Malditoff in identification as well as in supporting our stewardship programs, because again that's very important in the intensive care setup where we are struggling with antimicrobial agents. We have a lot of drug resistance, and if you could actually de-escalate sometimes the collateral damage that it causes to the environment to the next patient probably could be reduced. So as you see here, time to identification has been reduced in most of the studies. The use of effective antibiotics after using Malditoff has improved. Use of optimal antibiotics also has improved. Length of stay in the ICU has reduced after the use of Malditoff. Length of stay overall hospital as well as mortality has reduced, significantly reduced in some of the studies. And with all this, naturally the hospital cost per patient also has reduced. So Malditoff is yet another intervention that can be done using a positive blood culture bottle, which helps to optimally manage patients of sepsis. So advantage is that it has rapid turnaround time. A single colony is usually sufficient. In fact, there is as I mentioned, there's a direct blood culture protocol where you don't have to wait for the colonies to grow. It's automated, it's high throughput. You can identify anything that grows on a plate. The database gets expanded, so it's basically database oriented. The company keeps adding organisms, and then you can pick up any organism based on this database. So again, it's kind of targeted, but usually has a huge database. Very minimal consumables and cost effective in terms of consumables. But the disadvantages is at this moment in time it is, we use it only for ID, but let me tell you that a whole lot of groups across the world are actually working on using MALDI for giving susceptibility or determining drug resistance. So that work is also going on, and we may have some breakthroughs in the coming years. Most of the testing needs to be done by colonies, but as I said, blood cultures, you have a direct protocol. Identification can be limited by the database, so very rare pathogens may not be there. Closely related species can be misidentified. For example, E. coli and Shigella, the proteomic structure of E. coli and Shigella is very similar, so there is a possibility. But again, from the lab point of view, I know where Shigella is going to come and where E. coli is going to come. Misidentifications could be there if you are not, testing pure colonies. We need extraction process for some organisms. For example, those organisms which have a thicker cell wall, for example, mycobacteria, nocardia, some yeasts, filamentous fungi, they require an extraction procedure so that the cell wall is broken down and the proteins are now amenable to the mass spec. And tiny mucoid colonies. Now, this is something which is very important in the intensive care setup. We may have a CLEB patient, a patient with Klebsiella pneumoniae bloodstream infection, and it has a very thick capsule. Or you may have a community-acquired pneumonia landing in septic shock in the ICU with strep pneumoniae, which also has, a good capsule. And here, this might actually be wrongly identified. And yet, from the microbiologists can easily identify these looking at the organisms. and doing certain other methods. Now moving on to the second strategy or way in which we could identify pathogens associated with sepsis, that is directly the sample format where you're not waiting for any blood cultures. And in this, we have two strategies, as I mentioned earlier, the T2MR, which is based on magnetic resonance imaging, and the second one is the metagenomic sequencing. So T2MR actually is available globally, mostly Europe and US, not available in the Indian settings. But as you see here, what is done is you collect the sample directly. The vacutainer itself is subjected to this equipment wherein the organisms that you could identify. So there are two panels. There is a Candida panel and there is a bacteria panel. The bacteria panel comprises of the escape group of pathogens, while the Candida panel is, comprises of albicans, tropicalis, parapsilosis, cruzi, and glabrata. And in about 3 to 5 hours, usually 5 hours, one would be able to give you results. So here you do not require a positive blood culture. You can take specimens directly on the vacutainer and subject to this kind of analysis. And again, T2MR also has gone through plenty of research, and there is literature to say that it is better than cultures, definitely. And therefore, this group said that it helped with inappropriate antimicrobial therapy administration, which was less as compared to standard cultures. 21-day mortality was less by 2-fold versus conventional cultures in their study, and the mortality difference was not significant. So they said that T2DX might be associated with an increase in appropriateness of empiric antimicrobial therapy in patients who have a bloodstream infection. Plus, there are many other studies. This is actually a systematic review of 14 studies that found that time to detection was significant, time to identification was significantly less. Patients testing positive on T2MR received antimicrobial therapy faster than your conventional. Patients testing negative could be de-escalated faster. Length of intensive care stay was less, hospital stay was less, but the mortality was comparable when you looked at T2MR and conventional blood cultures. So this is a direct blood approach. You don't need to wait for cultures. Results are obtained in about 5 to 6 hours, has excellent sensitivity and specificity based on literature that is already there published. Unfortunately, you have separate GN and GP cards. So if you're strongly suspecting a gram-negative or gram-positive, a bacteria, you have to use a bacteria panel. If you're strongly suspecting Candida based on the risk factors, then you have to use the yeast panel. So that can be a little difficult. That choice can be sometimes difficult, and therefore you might actually lose time. The targets are very restricted, I feel. In our kind of setting, it's not only escape. There will be so many other pathogens that we might be coming up with. Drug-resistant genes are not there, though I'm told that there is a panel for drug-resistant genes that is coming up, and yet it is restricted for our kind of setting. And unfortunately, it's not available in India, at least till now. There is a possibility that it could be launched subsequently, but I believe why it has not yet been launched in India is because it's really restricted in its target, and we need better targets to be of use in our settings. So moving a step ahead in molecular testing of pathogens, we now have sequencing, and for a long time, sequencing was really an important research tool, and I'm happy that today it is a clinical tool available to us clinical microbiology laboratories. So really speaking, sequencing is a process that determines the order of the nucleotides that are present within the DNA and RNA of pathogens. And next genomic sequencing is basically deep, high throughput and massive parallel sequencing. I'm sure it sounds pretty much Latin and Greek to a lot of us. I am also not an expert, and yet we are all learning. So there was first generation sequencing, next second generation sequencing, third generation sequencing, which is this, basically is something which is fast. So earlier sequencing processes used to take days or months, to get results. But fortunately, now we could get those results even in a matter of about 24 hours. And it's not really something which is very, very new. It is globally recognized. There's plenty of published literature on this concept and its applications in ID to help identify pathogens multiple pathogens from a single sample, useful for AMR testing, for outbreak tracking, surveillance programs, microbiome studies, I'm sure all of us have heard about, and host responses. So there's plenty of application which is evolving in this space, and there are two approved such kind of sequencing platforms that are available globally. And for us, thankfully in India, we have a platform available which I'm sure some of us at least are using. And here not only it is blood, but you could also give subject your sterile specimens or even tissues for sequencing. So this is one study which looked at sequencing for pathogens from various different samples. As you see here, there is blood, there is bile, there is tissues, there are sterile body fluids. And clearly, metagenomic sequencing identified more positives versus cultures. So we know that it has higher sensitivity as compared to cultures, and it provides quick results because you can get results less than 24 hours or within 24 hours directly from the specimen. It is less affected by antibiotic exposure. That's something which is very important to us, particularly in the sepsis space. Also in India, where there's a very low threshold to giving antimicrobial agents. And interpreting data of MNGS will be a challenge for doctors in guiding clinical treatment of infectious diseases, mainly because a lot of it is based on bioinformatics, and yet there are teams that are working on simplifying this bioinformatics information so that we get quick results and fast results. Now, one thing to note here would be, because it is extremely sensitive, please remember that it could also be false positive. And that is something that really needs to be borne in mind. So because it is not affected by antimicrobial therapy, your organism might be non-viable, might be dead, and yet might be picked up. So it's not about the result of the interpretation of just a test result, but everything like any other test. It's not the test that you are really treating, it's the patient whom you are really treating, and therefore needs to be correlated with the results and the clinical information. So let me take you for the next couple of slides very quickly through our experience using one such platform. So we did this study in 2023 where we solely looked at blood. We took around 8 ml of blood in sterile EDTA vacutainers. Please remember that this has to be sterile, otherwise you'd pick up everything and anything. Our rejection criteria was volume less than 6 ml, hemolyzed sample, a clotted sample, any leaking vials which will jeopardize the integrity, and sterility, and non-labeled vials naturally. So even before we could head-on go into this, there was the Haystack team actually did a lot of work on understanding whether this particular strategy is reproducible, and this was recently published. So we found that it was reliable on site and could help screening pathogens very, very rapidly. So what we did is we had 251 blood samples where the standard of care, that is our blood cultures, had only pathogens detected in 30, whereas the NGS-based platform was able to detect about 33 pathogens. When we looked at pathogen and drug-resistant gene identification, we had another 15 pathogen plus ARG being identified. And additionally, only ARGs being identified in about 26 specimens. So clearly what we found was that our blood cultures had a positivity rate of 12%, whereas our NGS had a positivity rate of 19%. The concordance between the two methods can be estimated using the kappa statistic, and that was 0.93%. Anything more than 90% is very good. And we also found that the sensitivity of NGS was close to 2.5 times at that of culture, which is important because we know that in the best of the centers, blood cultures could be positive, max up to 15%. So there's a whole lot of sepsis being suspected and no organisms really being grown. And in a setting like India, where drug resistance is so common, we bank on cultures to identify the pathogen. So our learning from this exercise was that, you need to collect samples just like you do for blood culture. So you have to use all sterile aseptic precautions. Remember, this is a very, very sensitive technique, and therefore you could pick up contaminants very easily. So proper skin antisepsis must be done. Ideally, you should collect from 2 peripheral sites in the first go itself, because if you have a pathogen which is rare, you have the other set of tubes to confirm which are same done at T0. Then larger volumes of blood could be taken. So while we took initially two vacutainers, now we are taking 3 vacutainers from one site. Avoid sampling lines because lines can be colonized with microbes. Clinical correlation, as I mentioned earlier, also is absolutely essential. And at this point in time, cultures remain important, and therefore parallel cultures must be done. And something more that I learned more, recently was, don't hurry to get it done in the first set of, along with your first set of blood cultures, because when in that first hour, when you want to do a whole lot of blood investigations, probably you won't have enough sample to collect for this technique. So remember also that it does not get affected by antimicrobial agent administration. So you could very well resuscitate the patient and take the sample in the next maybe 1 or 2 hours. That's okay. You should have adequate volume. The volume is the key. And in the first hour, you could do all your routine blood investigations and get blood cultures. And maybe in the second or third hour, target towards this sample collection for the sequencing. So again, next generation sequencing platforms are open, and they provide an opportunity to detect bacteria, fungi, and viral pathogens in a single assay. Unfortunately, as of now, at least, this particular panel has only bacterial and fungal. The team is still working on detection of viral pathogens, and I'm sure that would come probably at least in about 6 months to a year time. Next generation sequencing can also be quantified eventually because counting of the sequence reads is possible. It's unbiased and it's non-targeted and delivers higher sensitivity and specificity. So with that, I'd like to conclude saying that sepsis, we all know, is a killer. It's very important to trace the source and know the identification of the pathogen at the earliest. Rapid methods, whether it is positive blood culture associated methods or the direct sample to answer formats, are now available at our disposal here in India. Identification of antibiotic resistant genes has a lot of advantages in our kind of settings where we encounter so much of drug resistance. Clinical utility of these sequencing technologies in sepsis is emerging, and I really feel that it's going to be a game changer in the management of sepsis and helping optimize patients with sepsis to better outcomes. And communication between your lab as well as your clinical teams remains the key to improvise on what strategy you want to use, what additional things to be done, and how to really correlate whatever the results we obtain from the lab. With that, I'd like to thank you all for your patient attention and wishing all of you a very happy Hand Hygiene Day. Today is 5th May. And we all know that it's the cornerstone of infection prevention everywhere in the hospital, particularly in the ICU. Thank you.
Thank you, ma'am. That was a great talk.
Thank you, ma'am. Nicely summarized the machine, technique, advances, and future aspect. Now it is the era of artificial intelligence. I think microbiology will expand exponentially with this. Thank you, ma'am.
Any questions? Okay.
Now, I would like to call Dr. Narendra to felicitate Dr. Aruna Pujari ma'am and our chairpersons. Thank you, Dr. Suman. Thank you, Dr. Vivek. Now, as we all know, the MDR infection is becoming obstacle in dealing with the patient, and we can overcome this MDR infection if we use a correct approach to deal with this. So to talk more on this, I would like to call Dr. Rakesh Pariwal, who is HOD of Critical Care Department, Guwahati Apollo, to talk on the MDR infection in ICU rational approach. And the chairing the talk will be Dr. Vivek Singh and Dr. Mahendra Bagur.
So good morning, everybody. I've been asked to talk, maybe continuing from where the sepsis diagnosis was, about MDR infections. And these are the bugs that we generally think of would be multi-drug resistant: E. coli, Klebsiella, Enterobacter, the MRSA variant of Staph, Enterococci, Acinetobacter, and Pseudomonas. And whenever we consider them, we might consider that there could be some amount of resistance, and that will actually influence our choice of antibiotics. And these are the agents. When we are using one of these agents, we are actually targeting something which is probably drug resistant, and most of them are for the first one. I've grouped them together for the gram-positive ones, including MRSA and Enterococci, and then we have the other ones which are majorly for gram-negative bugs. Now, when do you suspect that there could be an MDR infection? Is it at the time of arrival, community acquired? How many patients would you start on suspicion of having probably a carbapenem resistant gram-negative organisms? Day one, would you do that? Or is it only just hospital or community healthcare associated infections where you will initiate? Because day one, you do not know the bug, and probably sometimes we do not know the site of infection. Sometimes we do not know even if there is infection or not. And in that case, the empiric cover is largely guided by severity of illness. So in ICUs, when patients are arriving even day one, and you think it's a severe infection, maybe you will be tempted to start a drug which is most likely to cover any kind of resistance. Very likely we are going to use combination agents. And we know only when culture grows something, or as Madam says, she gives us a report somewhere in some hours of some molecular testing or some genomic testing, we have to really wait to know what the specific bug is. And for all said and done, it's only blood cultures which tell you about the sensitivity patterns, although the identification of genes now for resistance is helping immensely. So we come to the initial choices, and this is a syndrome that we generally have: pneumonia, meningitis, skin and soft tissue infection, abdominal infection, urinary tract infections, and sometimes non-specific like malaria, typhoid, all tropical fevers, or sometimes when the source is not known. What are we going to do? So we have a provisional diagnosis of pneumonia day one. When is it that you'd like to start a kind of a multi-drug resistant covering agent? If you suspect that there could be Pseudomonas, or if you suspect there could be MRSA. If you go to the list of the organisms, the other ones are not implicated in at least community acquired pneumonia. E. coli, Klebsiella, you don't consider them. And your suspicion of Pseudomonas is basically based on prior isolation of Pseudomonas from the patient or prior antibiotic exposure in the last 3 months. Also, you can look at structural lung diseases, bronchiectasis, and now I even say COPD patients, or those with cystic fibrosis more likely to have a Pseudomonas. Or for MRSA, it is again prior exposure to antibiotic last 3 months and prior isolation of MRSA. Or you can add on to immunosuppressed patients and those with IV drug abuse, mainly those who have skin breaches. They are likely to have staph, and which could be MRSA. So that is also the guidance which IDSA tells. So if you consider a Pseudomonas, you can start an anti-Pseudomonal drug. If you consider difficult to treat Pseudomonas, maybe you can start even with ceftazidime, avibactam day one, or you can choose an anti-Pseudomonal like ceftazidime or cefepime, or you can use a piperacillin, tazobactam, meropenem. And if you are considering MRSA, you can use vancomycin. Linezolid is another agent for pneumonia almost comparable to vancomycin. The interesting thing here is the UK guidelines of 2021, they have given a very good MRSA document about the use of clindamycin and rifampicin add-on for better benefits. Now, the most tricky one is, how do you define a hospital-associated pneumonia, or is it there? Because all samples that we send, respiratory samples are always contaminated samples. They are not considered sterile body fluids. They will grow something. And the idea of looking at infiltrates on a chest, already in a bad lung, or talking about the secretions is very difficult. And fever, leukocytosis, elevated procalcitonin does not point to pneumonia. It could be any other infection. So VAP is like a clinical diagnosis, and why this affects is because of the organisms which may be involved. If you go back to the list and we look at VAP, all of them are implicated. So you might have to have a strategy which covers resistant gram-negative bugs, the enterobacterials, or the non-fermenters like Pseudomonas and Acinetobacter, and also you have the enterococci which had to be covered. So enterobacterials here could be carbapenem resistant, and then we have this list of drugs, and I'll just tell what antibiotic options do we have or what other strategies we can adopt at the same time. One watch we do is we send nasal swab for staph. If it is MSSA, you may very well stop day one of MRSA therapy. That is one way. But it's all only negative predictive value. Doesn't mean that if MRSA grows in the nose, there is a pneumonia related to MRSA, not necessarily, but it can help in your stewardship. Molecular testing for viruses, this is we did for COVID. Now we routinely do it for influenza. And we have a panel where we can look at other viruses as well. Very well done in children, where it has decreased the antibiotic usages, even done on OPD basis. It is something that we can do. Molecular testing for bacteria, yes, but if you look at the list, the 3 contaminants, Pseudomonas, Stenotrophomonas, and Acinetobacter, you really need to know whether they are the cause of the condition or they are just contaminants. So that behavior has to be there when you're interpreting the results. For funguses also we can do molecular testing, and we can check for galactomannan. And genetic testing, this is what is available in Guwahati. KPC, Vim, IMP, NDM, OXA48, all the carbapenem resistant ones, OXA23 also we have for Acinetobacter, and MEC-A for staph. So this is something that which we get, you can send the respiratory samples directly. The only problem is with blood. Blood you cannot subject directly to most of this testing because the human DNA content is very high in blood. So to isolate the organism from that is very difficult, but CSF we routinely send for molecular testing. So I got my first immunocompetent Cryptococcus last 2 months back, young chap who only responded to amphotericin, and he had a major turnaround. So it can really help you in picking bugs which do not grow well, like Haemophilus influenza. We grew 2 in last 2 months in our CSF sample. I don't think how much lab can tell us about the growth of Haemophilus influenza. So that can really help you tailor your therapy. At least the sterile fluids you can always consider for molecular testing, and maybe you can send your blood culture also for isolation of these enzymes or for any drug-resistant bug. Meningitis, the standard is ceftriaxone and vancomycin. That is almost standard. And vanco is here added basically to cover for drug-resistant streptococcus. It's not an MRSA cover idea here, because streptococcus may have 5 to 10% incidence or resistance to ceftriaxone. So you add vancomycin day 1, that we all do, and ampicillin for those above 50 years of age. Now, would you like to cover for a gram-negative bug like Klebsiella E. coli day 1, meningitis? Yes. 2 conditions where you should do is post-transplant patients and those who are immunosuppressant. So we grew our Klebsiella in a patient in post-renal transplant, and we really questioned, is it picking too much, the molecular testing? And literature review says that 5 to 10% of these community-acquired meningitis in this subset of patients could be due to a gram-negative organism. So there you may consider carbapenem, or you may even consider a Cas-AV as your first choice. Those with trauma and post-neurosurgical infections, the cover is as per local data, what your hospital grows. CSF is a sterile body fluid, and molecular testing is changing the way we pick organisms. And always send CSF cultures. This is something I didn't know much. The yield is 60 to 70%, which is great. And it not only tells you about the bug, it also tells you about the drug sensitivity. Intra-abdominal infection, we generally have to cover gram-negatives and anaerobes. You can use any of these, carbapenem, piperacillin, tazobactam, Cas-Avi, always with metronidazole, because all cephalosporins do not have good anaerobic cover, and TG-cyclinol, that's the approval for the drug, complicated intra-abdominal infections. What I missed out here is the cephalosporins, but we are all talking about NDR bugs. So if you have a severely sick intra-abdominal infection, maybe any one of these can be a choice, and which hospital acquired, the choice depends on the organism, and may consider cover for resistant enterococci, because the GNBs and the drugs generally would not cover enterococci. Enterococci and MRSA cover is almost similar, because the resistance is generally due to cell wall binding abnormalities, which cannot be overcome by the beta-lactam drugs. And where this just added, I'm not talking on funguses, but antifungal may be high on your empiric choices when it comes to dealing with intra-abdominal infections. UTI, GNBs, yeah, we do always, and so you can choose. We'll just come to the choice of agents. Enterococci only with a catheter associated. And one distinction should always be made, if is it a lower urinary tract or an upper urinary tract, because some of the drugs like nitrofurantoin is something we have renewed interest in, because there is almost no resistance reported to it, but it only works in lower urinary tract. It's not expected to work on the kidneys if they are infected. And that is what the IDSA guidelines also mention. Trimethoprim sulfamethoxazole and nitrofurantoin are uncomplicated lower urinary tract infection, even if they are due to ESBLE or a carbapenem resistant producing bug, you can use them. And fosfomycin is another agent you can use for lower urinary tract. Still the standard is that one dose, but there is a lot of interest in whether we should repeat the drug again. You do not know at what interval, for how many doses. And if it is a pyelonephritis, quinolone and aminoglycosides are good agent, even if it is carbapenem resistant. SSTI is the most complicated one and the most varied recommendation. What agents you choose? Always cover staph and streptococci first up, and anaerobes in certain circumstances, and some like diabetic infections could be polymicrobial. So the choices are huge. Mainly decided by the extent of infection, severity of illness. That is what most guidelines would mention. It is necrotizing, non-necrotizing, is it producing pus and not producing pus, and what is the depth of the involvement. Is it muscles, fascia, it's deep, and then you have the superficial skin structures being involved. And surgery is a very integral part of SSTI management, so that also influences the outcomes a lot. Now we come to the carbapenem resistance, which we are mainly dealing with, and it is defined as either resistance to any one of the carbapenems or the presence of a carbapenem enzyme. Even if the culture is showing sensitivity and you've done a molecular testing and you're growing a gene which is responsible for carbapenem elaboration, do not use a carbapenem in your therapy, even in the high dose extended infusion version. Do not do that. And this is one mechanism. Most commonly enterobacterials, it is generally due to beta-lactamase elaboration. So majority of the resistance in them is due to this. One catch here is that if you have a beta-lactam resistance due to beta-lactamases, the mortality is higher. And the infection passing on to the next patient is also high, because the plasmids can transmit from one to the other. So isolation is also important. So spread of the infection, at least with beta-lactamase isolation, that's a standing order. If they elaborate any one of them, they require isolation. And the other causes are binding site abnormalities, and this is common with Pseudomonas. So Pseudomonas is one bug which can have a lot of resistance, can kind of down-tune itself and can act as a chronic pathogen, and may have resistances of multiple pattern. And most interestingly, the resistance pattern can change even during therapy. So if you're treating a Pseudomonas, you have the culture sensitivity, you know the pattern of resistance. 1 week down the line, you see the patient is deteriorating. It will be the same Pseudomonas which has now acquired a different kind of resistance. So there it is said that you can send a repeat sample and now look at the sensitivity once again. Porine channel defects or outer membrane defects are also very common, and the presence of efflux marks, mainly for quinolones and for the tetracyclines. This is the usual cause for resistance. Now we come to the enterobacterials. The strategy for E. coli, Klebsiella, Enterobacter is basically a novel BLBLI. And for us, which is available, is ceftazidime avibactam. If you look at the dosing, by default it is high dose ceftazidime. 2 grams is equivalent in it, and we give it 8 hourly. it is active both against the KPC group A and OXA48, which is group D. We have aztreonam, which is active against MBLs, and if you are not sure whether there is an MBL present or not, or if you actually elaborate a carbapenemase gene which is showing MBL elaboration, then use them in combination and as co-infusion. So we generally give it aztreonam 2 gram IV 8 hourly with a Cas IV 2.5 8 hourly. This is only for enterobacterials. If Pseudomonas elaborates MBL, aztreonam may not work. So it's also specific. And meropenem veibarbactam, although not available, they are not interchangeable with Cas IV. They say veibarbactam is almost tailor-made for KPC. It's very good for that, but it is not going to act against OXA48. If you look at the dosing of meropenem in veibarbactam combination, it is 2 gram IV 8 hourly, meropenem equivalent, which is equivalent to high dose carbapenem therapy, whereas the cutoff points given by CLSI are generally for the 1 gram IV 8 hourly dose. So one way of looking at, even if you're not using veibarbactam and you find borderline carbapenem MICs, or you find resistance to ertapenem but not to meropenem and imipenem, you should switch over to the long infusion, which is 3 hours of meropenem, and high dose, which is 2 grams IV 8 hourly. Acinetobacter combination therapy is advised, and we should use ampicillin sulbactam in almost all patients. Something which you don't see too often, but the dose is almost 12 to 18 grams of ampicillin equivalent and 6 to 9 grams of sulbactam. Sulbactam is supposed to have independent antibacterial activities, and that is why it is used here in this combination. And even if the culture shows resistance, you should use this agent. That is what the IDSA says as one part of the therapy. And the other agents which we can pick up is minocycline or tigecycline, again on the higher dose. So minocycline 400 loading and 200 BD, tigecycline 200 loading and 100 BD. Colistin and polymyxins can be used, and I think this is the only place we should be using polymyxins in our ICU, only for Acinetobacter, because for other bugs we have better agents to use. And they recommend that if it is not the urinary tract, you should use polymyxin B because it has better pharmacokinetics, dosing is easier. And if it is a urinary tract involvement, you can use colistin. Cefidericol is another agent which is not available, but I heard some people have used it here in Mumbai from import. So it is one bug which is active against the metallobutyl-lactamases also. So MBL cover is also there, and it is one agent which is advised for resistant Pseudomonas or resistant Acinetobacter. Aminoglycosides is not mentioned, but generally there is some amount of sensitivity shown, and we have used nebulized aminoglycoside. Also, there is no role for inhaled antibiotic anymore as per the IDSA document, but you may consider using even the previous generation like gentamicin aminoglycoside also can be used as part of Acinetobacter, especially the carbapenem resistant ones. Pseudomonas, they have given this new name, difficult to treat, which is resistant to carbapenem, aztreonam, piptazole, ceftazidime, cefepime, cipro, levo, all the three classes which we have treated our Pseudomonas. And it is not just about beta-lactamases in Pseudomonas. So you may not find the enzymes elaborated by most of them. And the agents here are ceftolozane or tazobactam. I don't know if it is available here. We don't have access to it. But ceftolozane is almost tailor-made for Pseudomonas, so it may do better, and it has independent anti-Pseudomonal activity. It is not dependent on tazobactam for activity. You have Cas IV, which you can use, imipenem, cilastatin, relibactam, and cefidericol. For Pseudomonas producing MBLs, Cas IV and aztreonam, as I said, may not be as effective as it is for enterobacterials, and no role for nebulized antibiotics, because this is where probably there is largest data, cystic fibrosis, Pseudomonas, and a lot of inhaled agents, but they say may not be effective. Combination therapy is not necessary. So in my college days, we used to read Pseudomonas, you should always give 2 drugs. But that is not endorsed. Even for resistant Pseudomonas, that's a choice that you make. If we are trying to cover MBLs in these patients, maybe you can use colistin-based therapy. Always remember that tetracycline group of drugs do not have good anti-Pseudomonal activity. So maybe those should be avoided. And polymyxin aminoglycoside may have a place, and you can use the newer aminoglycosides also. MRSA agents, what do we have is Vanco for bloodstream infections and meningitis. That is where it is a preferred agent. Don't use anything else. Also because of the data, vancomycin is the first drug to come Now, teicoplanin came almost 30 years later, so it was very late in entry. And linezolid is as good as pneumonia, comparable to vanco. Daptomycin, high dose is an option. Again, this is one drug which is given here. We use the 10 milligram per kg body weight dose. And clindamycin, if at all you are using, it's only for SSTI. So do not use clindamycin as an MRSA cover anywhere else. It is not as great. In pneumonia, it may be given as an add-on agent for better outcomes. Rifampicin may be added for meningitis and pneumonia. And teicoplanin, they say, is less nephrotoxic. You can use it in other indications. It has good deep tissue penetration, so it can be used. The only problem is with both vanco and teico, therapeutic drug monitoring is advised. So only one drug where efficacy is related to the drug concentration is both of them. Loading dose may be considered when you are treating, considering drug resistance. And it's an area under the curve. It's a complicated way to find out what the concentration should be. So you take a post-administration 2-hour sample, and before the next dose you take one other sample, put them together, make a graph and find out what is the area under the curve. Stenotrophomonas is one of the agents in which there is an IDSA document, and so I included it. We grew one Stenotrophomonas this time from community, which we treated with cotrimoxazole, but it's something you can come across because of contaminated waters, respiratory solutions, or intubated patients. So pneumonia is not uncommon due to this. It was earlier clubbed as Pseudomonas, and it can elaborate both MBLs which are resistant to beta-lactam. So that is the main problem. So beta-lactam antibiotics may not work. Combination therapy is preferred, cotrimoxazole with either minocycline or tigecycline or levofloxacin, and Cas-Avi with aztreonam may also be considered, like we do in enterobacterials. And this is Enterobacter cloacae complex, inherently resistant to all cephalosporins, and this is due to AMC elaboration. And AMC is interesting because whenever you get Enterobacter, do not use cephalosporin, even if it is showing sensitivity in the blood culture reports or whichever culture report, because as soon as you expose these bugs to cephalosporins, they will start inducing AMP, and they will produce it in such a time that the next time you send the sample, it is showing resistance. So there is 3 bugs which the IDS has identified where you should not use cephalosporins. Enterobacter is one of them. And the other two are the Klebsiella aerogenes and Citrobacter frundi, where you should not use a cephalosporin. Enterococci, mostly nosocomial infections. Resistance to beta-lactams is a major concern, just like MRSA, and agents are same as for MRSA. The only problem is with vancomycin resistance. So linezolid is more preferred kind if you're using empirically. And if you're using an aminoglycoside, you use gentamicin or streptomycin. That is like tailored to only these two. And this synergistic activity is probably one of the most important documents on synergistic antibiotic activity, because inherently enterococci is generally resistant to aminoglycosides, but when you use them in combination, it has been shown to have a better outcome. ESBL, the only word is that if you think ESBL, and that is basically when you show ceftriaxone resistance, we do not do genetic testing or any phenotypic testing for ESBL. If that is the case, even if you are showing sensitivity to the BLIs like piptazo, don't use if the patient is severely sick. So carbapenem is the drug of choice because of better outcomes with the use of a carbapenem. So the overall approach is the choice of agent should be based on local prevalence, sensitivity pattern, and severity of illness. Higher dose and longer infusion of beta-lactam is one strategy which you can use. Duration of therapy is said to be similar, so you don't have to use a longer duration of therapy just because you're having a resistant bug. It is same as if it is sensitive. So a VAP can also be treated with 5 to 7 days of antibiotic therapy, just like community-acquired pneumonia. Combination therapy is preferred for certain organisms, and there is data to show better outcomes. And procalcitonin can be a guide to tailor therapy. So you may not use it to choose your initial agent or site, obviously it doesn't tell you, or maybe not to give an antibiotic or give an antibiotic. But it can definitely be used to cut down the duration of antibiotic along with the clinical wellness and whatever algorithms we have for these specific infections, how long the therapy should be. We expect a 50% decline in procal almost every 24 hours. And by the time it falls to 10% of its initial value or 20% of initial value, some people say, or an absolute value of less than 0.5, let's say, you can stop your therapy. So you have enough science to tell that I can stop my treatment. This has really helped us in cutting down our VAP antibiotic durations to a week. So this is some strategy you can say. So MDR bugs, the best would be what Madam said, that we have something in few hours telling us what bug, what gene, what kind of sensitivity pattern would be there. We are far away, but with other body fluids, we still have more data. And maybe with newer agents or more judicious use, we may have these agents to use for a long time. Okay, that's all I have to say.
Thank you, Dr. Rakesh Pariwal. That was a great talk. Now, I would like to request Dr. Mahendra to felicitate Dr. Rakesh Pariwal.
Welcome.
Now, to enlighten us about the correct use of ECMO, I would like to call Dr. Niranjan Panigrahi, who is working as senior consultant in critical care department, Apollo Hospital, Hyderabad. So, sir will talk about the ECMO, when or when not.
You have it connected. I'll just call the ID.
Yeah. Good afternoon. So, a little bit, we'll go from the world of antibiotics, the microorganism resistance and resistance pattern, to something which is lucrative, which is more rewarding basically. You start something, then you see your patient saturation from 40 to 60 to 90 to 100, your patient will get up, will start responding. So, that is the world of ECMO. So we'll see how exactly to place this modality. So my topic is ECMO, when to and when not to. That means how precisely to decide whether we are going to initiate ECMO or we are going to decline the call on ECMO. So okay, fine, no problem. So there are so much studies, so much research going on because of two reasons. One is it saves lives, and second is it gives money. And rather the second line is more important, why so much people are involved, or why the world is, or why at least the medical fraternity is so obsessed with the modality. In fact, the highest revenue generating service in your hospital, more than heart transplant, more than liver or lung transplant, also ECMO. So that is the other side of the story. Now we'll keep that thing away. We'll try to see scientifically, as much as correct, like how to select a patient, because it's a resource limiting country. It requires a lot of resources to initiate ECMO, manpower, money, the patient's emotion. So unless otherwise we do justice to ourselves, to our ethics, then probably at the end we will be proven wrong. We'll try how scientifically to place this modality, or till now what all the guidelines says will go. I think my good. Thank you so much. So I thought of making the situation a little lighter. Like as I told, a group of people, they will argue, okay, we need this patient to be connected to ECMO because they have their reason to say so. And the other group, again in the same hospital, okay, they may say, no, probably it's not needed or we can wait. They may have their own reason again. Okay. So today we'll try to see, okay, whose weightage is more, okay, whether to go for or not to go for. And if at all not to go for ECMO, then what is the plan B, plan C or alternate available with us? We'll try to understand there. So I will be talking to you. Of course, the usage of ECMO will be never completed without understanding a severe ARDS. I will not go into the pathophysiology of mild, moderate ARDS because like we don't deal with them, not because they are not sicker, but the ECMO people usually they don't deal with mild, moderate ARDS. Usually the sickest of the sickest patients, you will get a call. Then second thing is, we'll be talking about prone because that is the plan B, okay? Then what all plan C, plan D is available. Then indication of ECMO, okay, what all the scientific indications are there. Then probably indication and patient selection is not same. Unlike in other scientific modalities, in ECMO, not necessarily a patient is having an indication that you will go and start. There should be a criteria to select patient after indication. That means if you get 100 calls for ECMO, then the ECMO outcome criteria should be also fit. That means there should be an indication and of course there should be a good outcome or predictable outcome in those patients. Then we'll see what all modalities are there. Then timing, how to or when to place ECMO. Then of course, a little bit of the cost benefit analysis of the ECMO also will go into. So to start with a little bit of basics, two modalities, VA, VV, collecting from vein, ending in vein, VV, collecting from vein, ending in artery is VA, VV for respiratory problem, type 1 respiratory failure, VA for cardiac and combined respiratory problem. So specially MI cardiogenic shock, massive PE pulmonary embolism, or sometimes myocarditis, some other diseases. So we will not go into the technical details because the topic is precisely when to and when not to, or how scientifically to do a bedside decision whether to initiate or not to initiate the ECMO. Now, indication among the VV ECMO, the respiratory failure or in the type 1 respiratory failure patients, most common is again ALI, ARDS, of course no more ALI, then it's ARDS. It may be because of the aspiration pneumonia, asthma or contusion or some other problem, inhalation injury, whatever cause may be. Patient having refractory hypoxia or not responding to conventional therapy, or patient going into unexplained organ failure, secondary to type 1 respiratory failure are the candidate where we can think of ECMO. Not indication or not to initiate. Okay, indication is far away, but we'll see. But these are grossly, scientifically, all textbook they mention, these are the indications. Then coming to VA, so again, vein to artery, so the return cannula will go into either femoral or then jugular, most commonly the femoral vein, and the excess cannula, the return cannula will go into the artery, through the common iliac, the flow will go into the ascending aorta, then to descending aorta. So most common indications are cardiac arrest, post cardiac arrest immediately, that's ECPR. Then MI cardiogenic shock. In specific group of MI cardiogenic shock, of course, not in all cardiogenic shock secondary to MI. Post cardiac surgery patients, mostly if the patient is unable to come out of the bypass, then ECMO is the bridge to that modality. Then during transplant, invariably they will require, because the transplanted heart, it will take time to regain its function. So ECMO is a bridge to transplant. Post-heart transplant care, then cardiogenic shock. We'll go into the details. So I hope this city, anyone working in hospital, not necessarily in ICU, they would have encountered this kind of city. And we are taught that it has three parts: some non-recruitable, recruitable, and already opened alveoli, and the whatever modality is there available till now, the treatment strategy for ARDS is not to, we can't do anything to the lower 1/3. We need to save the upper 1/3. And that's what neuromuscular blocker, that's what proning, that's what low tidal ventilation, they all do their effect by protecting the upper third of the lung. That is what is the basic is taught to us. Now we'll go into the details, how the ECMO and why ECMO and how it's going to help. So this is the 2019 guideline, the ARDS updated guideline. Of course, there is one more guideline in 2023 as well, but I didn't get the picture from the 2023 guideline from American ATS, American Thoracic Society guideline. So I have put this picture. You can see here, there are basically 6 groups. The upper 2 are the prone, the 5th one is the prone, and 6th one is the ECMO. That's what at least the guideline says. That means when mild, moderate or severe, you can try other things. No need to call the ECMO physician, but at least when your prone is not working, when you feel your prone is probably failing, that is the time you need to call the ECMO physician. Now there lies the crux. Now who decides the the proning is actually working or failing? Is there any guideline for success or failure of proning? That is the topic of discussion today. We'll go into details. After second proning, who is the patient you will prone or whom you will not prone? We'll see scientifically what is the material available with us. So this is again the same guideline. So strong recommendation is for the proning. There is, of course, strong recommendation, but grade 2. Grade 1 is for proning and grade 2 is for ECMO. That means proning must be tried before ECMO is initiated. In fact, everything should be tried so that a patient should not go into such a costly modality or such a resource limiting modality. So we always tell, whenever we get a call for ECMO, I always ask, have you tried this, tried that, tried that? That means the thing is we want to make sure that you have tried every conservative modality before going to such an invasive or such a costly modality. Now, at least the guideline says, once you tried the ECMO, so tried the proning, then they have given some numbers when to decide whether to go for next proning or next ECMO. Let's see what the literature says. This is the PROSEVA trial. Basically, they told, okay, there is some benefit with 16 to 18 hour proning. We respect this trial. We try. So PROSEVA was conducted by Guren et al. Okay, the famous Italian pulmonologist, intensivist basically. They are the proponent of proning. There is one more guy from Italy. He is no other than Gattinoni. So basically, he is not a great believer of proning. So the reason may be whatever. He has done so many trials before. Proning supine 1, 2, so many trials, they didn't give result. Then Guren suddenly came and they published. Then they told there is a mortality benefit. And there was some difference in Guren and Gattinoni. So Gattinoni constantly, if you see his editorial, he always writes against proning till at least PROSEVA. Now, after PROSEVA, still he didn't stop reviewing the effect of proning. Now, he says, so how to decide the proning success or failure in terms of oxygenation? He says no. If you prone, probably 99 to 100% of patient will show oxygenation improvement. Second question, is it ventilation? That also he says no. Because near about 90 to 100% patient, again they may show a ventilation improvement. But is the outcome of ARDS 100% till now? It's no. That means there is a subset of patient who responds to proning so nicely, but they don't turn into outcome result. Now, he analyzed near about 4,000 patients retrospectively from 2011 till 2020 and published in a review article. So here he says, it's not only the oxygenation, not only the ventilation, which actually guides or actually should guide you to go for next proning. You need to see something else as well. That is nothing but you need to see the driving pressure and the plateau pressure as well. Now, in a patient, if uniformly 4 out of 4 parameters are improving once you do a prone, improvement in oxygenation, improvement in ventilation, plateau pressure decrease, driving pressure decrease, then probably he is the next candidate whom you should think of next proning. If you are not finding 4 out of 4, then probably lesser likely to respond to next proning. If you are finding 3 improvement and only, or 3 negative and only 1, suppose only oxygenation improvement you found and the ventilation and other things didn't improve, then probably this patient will not respond to the next episode of proning. Now, he has written a nice article on the predictability of the proning. Now, who is going to improve with the next proning? Whom you should think of stopping proning and think of the alternate therapy. So, here the game changes. Now, so the next research, whatever they are doing it right now, a prospective trial they are enrolling. So, not to comment on the proning. Proning is a well-defined, or it is like a gift, okay, without any invasive treatment we are getting the oxygenation benefit, but we need to be extra careful that not get biased by only oxygenation improvement or only ventilation improvement and you need to go to next proning. No, you need to see 4 out of 4 parameters. So then what we should do for those patients whom only 3, 2 or we don't get any improvement out of the 4? One thing is clear, when there is no improvement in oxygenation or carbon dioxide built up after proning, then we are at least clear that probably our proning is not working. It is a failed proning. So, but what about those patients, those who improvements or show improvement in oxygenation and ventilation, but no improvement in the driving pressure or the plateau pressure? Artificially, they may look like that probably they may respond, but ultimately that is the subset of patient who look like responding to proning, but the outcome, they don't turn into outcome. So, there lies the crux. That is the precise placement of ECMO. That is the set of patients when they may look like responding to proning, but ultimately we lose them. So, next. Then they put some theories or some predictors again, okay, some scoring. So, according to them, 4 out of 4, then probably 90% chance that next proning will be successful. If 4 negative, they have given some 10 to 15% chance that next proning will be successful. So, there lies how precisely we place our next modality in the management of the ARDS patient. Now, so this is the conclusion of that thing. So, there are some in general contraindication for the proning, like if a patient is in shock, acute bleeding, trauma and all those things, that is, I am not going into the details. And so, now, then comes next question is what is next left over there. So, if we are thinking ECMO, there are so many trials not favoring ECMO as well. Okay, initially some trial came, the 2009 or 2012 trial they came, they told it's having benefit. The 2016 trial, the Yulia told probably there is no great benefit. After a 10 long years of study, they told there is no benefit. But again, there are some recent, some small trials, again they are telling we need to revisit the way Yulia has conducted or the way they have done a crossover, some kind of manipulation they have done in their study. So now coming to the ECMO in ARDS, I'll finish BB first, then we'll go to the VA if at all I get the time. So what exactly it does? It gives the lung rest. Again, the upper third of the lung, which we intend to save in ARDS patient, it actually saves. Or if in theoretically term, if we say lung rest, actually ECMO is the only modality which gives the rest to the lung. If you can extubate, if you can ask the patient to do a spirometry without a ventilator on a ECMO. So now these are the trials, grossly, there are so many, but grossly 2009 is the first trial, the H1N1 trial where people saw some benefit. Then Caesar trial clearly showed a mortality benefit, but people lost their enthusiasm when the Yulia trial came. Yulia didn't show a great result. In fact, it told there is no difference in mortality between ECMO and a conservative group. So now the question here is to do or not to do. The intention behind giving these 3 trials is, I wanted to analyze what is their entry criteria. At least probably we can extrapolate those things, or we can take some message from here. We'll not go into the 2009 NGX trial. We'll start from Caesar trial. Now, Caesar trial, they kept their inclusion criteria as one is the Murray score. So, the Murray score more than 3. Any patient having a Murray of more than 3, that was their inclusion criteria, because that gave the mortality benefit. That is the reason worldwide people still use Murray score for indication, at least. I am not telling patient selection. It is for indication of the ECMO. If a patient on ventilator with probably the Caesar has taken 18 to 65 year, the middle age group, then potentially, of course, reversible respiratory pathology, and carbon dioxide whenever it is high and the pH is going less than 7.2, that was their entry criteria, and they showed some benefit. Out of all these 4 numbers, probably what we can use in bedside is the Murray score. Any patient Murray score more than 3, probably we can think, of course, after proning. Then I'm not going to the Murray score. There are 4 parameters basically: PO2, FiO2, chest X-ray, the PEEP, and the compliance is given. So you need to do continuous 2 times Murray score in a patient. That's what they say. If you are proning a patient, twice daily Murray score should be done if you want to give a escalation of the therapy. Now, Murray score at least more than 2 out of 3 scores. If it is crossing more than 3, then probably we can think of ECMO. Then outcome of the Caesar trial, they showed the benefit. I'm not going into the outcome details. Let's go into the EOLIA. Now, EOLIA criteria, if we see, now these guys, they included patients of very severe hypoxemia, PO2, FiO2 of less than 80 as a rescue measure. Then PO2, FiO2 of less than 50 immediately, within 3 hours they have to take. Hypercapnic respiratory failure, same pH less than 7.2, that was the near about that thing. Only thing they didn't include is the Murray. Okay. So now the question is, why we should or why is people still believe the Murray to be considered in the bedside for to decide the indication is because the Caesar took Murray as an entry criteria. They showed some benefit. That is the reason still people, including my center, we use Murray to show a indication for ECMO. Now, so there are some exclusion criteria as well. So now coming to the ELSO, let's see what ELSO says. ELSO still mentions Murray to be considered in indicating or in deciding the patient who requires ECMO. Then they, according to ELSO, so PO2 FiO2 of less than 50 and Murray of less than or 2 to 3, even less than 3 also they consider to think of ECMO. These are the indication of ECMO. So then again, hypercapnic or hypoxic respiratory failure in the same way for type 1 respiratory failure. Now the next question is, okay, so we got our patient who we have tried proning once, twice, probably as for the Gattinoni at least, we decided that this patient is not going to improve the next time, or we failed actually in the proning, and there is an indication also. The Murray is 3.3 and probably other criteria also failed. Now what? Should we go and start ECMO? No, that is the international guideline, but in India, we need to see other factors as well. The finance, the family, the emotion, and all those things. Now, what is needed here is, now here onwards, whatever I am going to tell you is the actual bedside decision-making process. We need to see how much outcome you are going to get from this patient if you are going for ECMO. Then who will tell? Till now, the ELSO is silent on outcome. Even other criteria also, they didn't speak about the outcome. Next, ECMO Society of India, what they have decided, they have mixed 2 things. Patients should have a clear indication and patients should have a clear outcome benefit. Then only you should go talk to the family that probably your patient, we should go and initiate ECMO. Now, let's see what are the outcome predictors are there. So there are so many predictors. Okay. So the first predictor in 2009, it's an Australian indication, Australian team basically, they were using this. This is a ECMO net scoring. Okay, it's an older thing, we're not going into this. But other 4 are being used variously in various parts of the country. Also mentions, if at all a prediction scoring should to be believed, they mention the RESP is the best prediction modality to be believed. But if we see receptor operative curve, then preset scoring, which came in 2015, is the best modality. The reason, we'll go into the details. So RESP, this is what we use in our center. Okay. So we need to see whether the patient is going to get benefited or not. Now, RESP, there is some difference between the RESP scoring and the other scoring. RESP takes pulmonary as well as extrapulmonary component into account. So there is age, there is immune status, mechanical ventilation days, then PaO2, FiO2. So all those things, then the cause of pneumonia. So it balances the pulmonary as well as extrapulmonary indication. That is the reason people still believe RESP is the ideal score to be used for the prediction or the outcome analysis in an ECMO patient. Now this point is very, very important. As you say, the patient will believe. If you say the RESP score is probably, I am finding this is in the range of -4, you can tell, okay, still there is a 40% possibility. -5, -6, probably they will not improve. Do not speak about ECMO also. Beyond +4, they may not require ECMO. So ideal ECMO requirement is always either it's a -4 to +4. Now in my center, we use the RESP score of -4 to +4 and Murray more than 3.2. This is the indication. Now other factors are also there, but these are the, you patient should have a clear indication, meeting the criteria and having the outcome benefit as well. At least the RESP score should be, it should not be below -4, it should not be above +4. Okay. These are the two scores we use, but again, there are still better scores available. Second, next comes is the latest is the preset scoring. Now, it's a UK-based scoring basically. They mentions that the probably we should not completely depend upon the pulmonary scores. They completely remove the pulmonary scores. According to them, the PS, mean arterial pressure, lactate level, hospital stay, pre-ECMO, ventilator days, and all those things should be considered as the outcome predictors and not at all the pulmonary thing. But again, they have their pitfalls as well. So if at all to select a outcome score out of these 5 scores, RESP also mentions at least across India people use the RESP score for prediction. So now preset scoring, again they classify score 1, 2, 3, mortality accordingly they divide. So you can tell your attendant that okay, now the ECMO we can start at least 50% outcome. If at all they are ready to believe, ready to come forward, we can start, or else we can stop there. Then everything is okay. Till now we understood outcome, we understood more than 50, indication is also there, but still there are something, okay, when, what is the time? So there is a clear like outcome to number of ventilator days pre-ECMO, there is a strong correlation. So if the pre-ECMO days on ventilator is more than 1 week, the outcome drastically goes down. It is proven in multiple studies. Even in COVID also the same thing happened. Whenever whoever started or tried to initiate ECMO after 10 days, 15 days, okay. I know across India, in ECMO Society of India at least, those who are putting their data, we analyze, we know this thing, outcome was never better when we tried after 7 days. So the dictum is, if at all to be started, so as much as possible we need to try to avoid ECMO to be used, but again, it should be tried not to delay it as well. So if you initiate early, probably some useless patients will get ECMO, which is a way costly, a way invasive procedure. If you delay, then probably even after giving the costly treatment also, you are not going to get a benefit. So as a treating team, as an intensivist, we need to be very, very clear, very, very precise when to say yes, when to say no. Now coming to in Apollo Hospital Jubilee Hills, probably every week I get 3 to 4 calls. Okay, along with me, Dr. Deepak is there, so we are a team. Now, he being very famous in Andhra, every call will come through him. So, 90% he only will screen. So, he will tell ki probably, oh, after 10 days on ventilator, no, we are not going to take. So, or sometimes they'll, in panic, they'll call. Yesterday got intubated, sir, saturation is this is we want. No, please you wait for 1 more day there. Okay. So, we need to be correct as ethically as possible. Rest the revenue, cost, benefit, other thing is for the marketing team. Then this is the about VV. Do I still have time for VA? 5 minutes only. Okay, we'll try. Now coming to, we are fortunate that at least this much of complicacy, this much of controversy is not there in VA. Okay, the indications are little simple. So and outcome is also much better in VA compared to the VV. The ECMO stay, ECMO run is also shorter. The cost of ECMO care is 1/3 of what VV ECMO charges. Now, let's see the indication. A patient comes to you with a chest pain, MI. So, you have eminent cardiologist who detect there is some coronary block, they know that thing, but patient is in shock. What they do usually? Usually the guideline says that they should not try the urgent PCI, what I think the cardiologists, they know better. So they want you to stabilize the patient. Then patient comes to ICU, we try to stabilize. Some get stabilizes, some do not. Those who do not, they simply pass, okay? We go to family and tell, now just go and pray to God, because that is the maximum what we can afford to you. But is it so? No, that's not true. It is only true if you don't have a ECMO program in your hospital. If you have, then you can offer something more. Now, MI cardiogenic shock, AHA guideline says, let's go into the AHA guideline, what it says. Now, shock is divided, the SCAI stage, okay, they divide SCAI, okay. So, the stage 3 and stage 4, stage A, B, C, A is at risk, B is the beginning of organ failure or hypoperfusion, C is with classic indication, D is deteriorating, that means patient is on high dose of vasopressors, E is end stage. So, we should not try in E, should not try in A, B also. So, C and D, SCAI stage C and D, there is a lot of research going on right now on the SCAI staging and how precisely VA ECMO to be placed. Recently, last month only one article came on Impella, the microaxial flow, okay, you would have seen. So, the either Impella or VA ECMO, where exactly to place, they are trying to. But at least as for the AHA guideline, whenever your patient is deteriorating or going from B to C or C to D cardiogenic shock, in spite of all conservative modalities, then either a mechanical circulatory support should be given. Now, it is very clearly proven that IABP is not going to helpful. The reason is IABP only can produce some 500 ml of cardiac output. ECMO can produce up to 6 liter, 7 liter, how much you want cardiac output. Impella, that again depends. Suppose the cheaper 25 lakhs, 30 lakhs is the 2.5 liter cardiac output. Suppose I have seen we started Impella 3, which costed 30 lakhs. When we wanted to augment to 3.5, because cardiologists felt that probably the cardiac output should be augmented. When we wanted to change it, they asked another 30 lakhs to be paid. So that's Impella is a way costly. At least ECMO at 5 to 6 lakhs, that is there in your hand. If at all you are okay with, you can start VA ECMO. So the indication in cardiogenic shock is in SCAI stage C, D, not in E, neither in A, B. We should select for these patients. Apart from the MI cardiogenic shock, because it's the most frequent admission in our hospital, other patients also coming to the pulmonary embolism. Now, what we do for massive pulmonary embolism? There are two things. They will be in shock, they will be on ventilator. Ideally, we put on some heparin. So then we wait for another 1 or 2 days, 3 days. Those who survive, those survive. Those who do not, do not. Now, what we can do? We simply can bypass the lung. So same thing, VA, place a cannula in the right atrium, place a cannula in the aorta, simply bypass. Anyway, the clot will lies within 2, 3, 4 days. So these are all very reversible conditions. Pulmonary embolism. Massive pulmonary embolism, they will nicely recover and go home within 3 to 5 days. Then comes the myocarditis, again viral myocarditis, same thing, 5 to 7 days is the overall. So last month only we sent a patient who presented to us with a viral myocarditis and profound shock. VA ECMO initiated. Then I think day 7 or day 8 we decathetered and patient went home. So there are things. Now coming to, apart from indication, even in the VA ECMO also there is scoring system. The score is SAVE, unlike -8 to +8. Here the score is -15 to +15. Again, we use from -5 to +5 if the SAVE score, then we advise ECMO. But again, we have Impella program as well. We have in-house Impella machine and all devices. So whenever a patient comes, okay, the ECMO team and cardiologist team, we sit and decide what to be offered. If patient is way affordable and the cardiac output requirement is only 2.5 augmentation, then we go for Impella. When we feel that probably there is a biventricular failure, there is a right side failure as well, Impella only can unload the left ventricle. A pipe will go into the LV, now it will push the blood into aorta. It has nothing to do with the right heart support. So when a patient is there in biventricular failure, global hypokinesia, probably a big no for Impella. It only will waste the money, so will not give any benefit. So now I want to skip these things. So these are the mechanism how ECMO helps with the vasodilator, without vasodilator. So now these are some of our patients. This is the patient who last month we discharged from VA ECMO. Then I want to skip so many things. Yeah. So ECMO is a costly, probably not only the costly, probably the costliest service in our hospital. I started with the line, it is more costly than heart transplant, liver and lung transplant as well. So it's because it is involved with a lot of money, a lot of litigations are involved, a lot of emotions are involved. If you give a little bit more hope, that guy will go and sell his land. Okay, so you need to be doubly sure you are doing justice for the patient. Okay, so it need to be precisely selected and scientifically placed where exactly it is indicated. Thank you.
Thank you, Dr. Niranjan. That was a wonderful talk. Now I would like to request Dr. Manoj to felicitate our speaker and chairperson.
Niranjan, very good talk. On the lighter note, when you received Dr. Deepak, lot of from Andhra Pradesh, suppose you feel that distance in Hyderabad to that patient is too high, you can consider Mumbai is a closer. And thank you, Niranjan. I will just do an inaugural function. I am honored and privileged to welcome our regional CEO, Mr. Santosh Marathe sir, and our Director of Medical Services, Dr. Ravi. Dr. Marathe sir always motivated us to do the clinical excellence in the critical care. And when we joined, actually there was some discussion to think about this Apollo critical care. And the day I thought that now everything is fixed and we are going to finalize that, that day we received the mail, sir, from you that you have thought of Apollo and moving to the greater opportunities. So without wasting time, I'll request Dr. Marathe sir and Dr. Ravi sir to light the lamp. I invite Dr. Narendra Patil, Dr. Gunadhar, Dr. Divya and Dr. Mahendra to be along with them for a lamp inauguration.
intensivist out here. ICU care almost occupies 25% of our volume activities at Apollo Navi Mumbai in particular. Very recently, Apollo has also launched a product which is known as Apollo Connect. So no longer the overall care delivery, which was within the confines of the hospital, has gone beyond the confines of the hospital now. So we are getting into a scenario where we are connecting with nursing, we are connecting with modulated care, which are IT enabled in terms of the overall activity, and that's the way to go. I think, and I'm very impressed by the overall itinerary list. I think within a particular day, you have tried to squeeze in almost 16 or 17 relevant topics, which covers most of the subdomain, including diagnostics, including cardiac presentation and respiratory presentation. So quite impressive discussion and quite impressive speaker list, I would say, in terms of this thing. So all the very best for the event, and thank you for coming in such a attendance. Thank you all.
So next I would like to call Dr. Achyut Rao Gongada to talk about very interesting topic, that is early warning sign. And chairing the talk would be Dr. Manoj and Dr. Pankaj Bhirud.
Good morning, everyone. And I thank the organizers of Apollo ICU Conclave, especially Dr. Akshay Chalani and the team, Dr. Gundar and others in the team, for giving me this opportunity. It's a nice concept, and probably if the Apollo corporate group and the ICU consultants agree, we can even think of conducting Apollo Conclave across the country, distributing it or circulating it to one hospital every year. The group of doctors and corporate also can think about this. So coming from my talk, so Dr. Niranjan had spoken about the most advanced surveys, and now I'm going to talk about very simple intervention that is going to help a lot of patients, increase the confidence of the family members, and decrease the negative outcomes like cardiac arrest or poor outcomes in the intensive care. So this simple intervention is early warning signs, and this will definitely help in identifying the sicker patients early and intervening early so that their clinical outcome is made much better than that would have happened without this intervention. So when we talk among ourselves, the clinicians or with the administration, it would be like we don't want any cardiac arrest on the wards, and identify the sick patients as soon as possible and get them onto the ICU, and then tell us simple methods to identify sick patients on the wards. So the nurses would come, and so how do we identify, is there any scientific way? And some things like, is this patient for ward or ICU? This is a question on the ER. And why is this stable patient admitted to ICU? Another question in the morning when you come for ICU rounds. And the other option is like ER should have let the primary consultant admit the patient on the ward and not in the ICU. So things like this, lots of communication interactions will be there. So if we ask one simple question, how is your patient? How do you answer? And the answer depends on the insight that particular medical person or nursing person has into the patient's condition, and also the scientific analysis that person can do. So you can all see there is a blast here, and then does this blast happen suddenly? We all know that it's a big no. They must have done a lot of groundwork before others could see this blast and its consequences. Okay, in medicine, again, nothing happens suddenly, and only that we don't know, or we haven't seen, or we were not able to see what has happened before that event. So nothing happens suddenly. This is one thing that everyone should understand. And then comes how to identify. So identifying deteriorating hospitalized patients prospectively and seeking to alter their clinical trajectory through increasing the clinical resources directed to them. This is the bottom line for medical, administrative, nursing, medical, all departments. And this is what we are going to deal with now. So there are multiple systems here, depending on the part of the world we are working. So rapid response team, critical care outreach team, medical emergency team. Rapid response system is an American system. Critical care outreach is a UK system. And medical emergency team originated in Australia, and even Europe also adopted that system. And what do they actually contain? It contains afferent component and afferent, so it's like a sensory component and motor component. And what do we do in sensory component? We recognize sick patient, and then the intervention part is intervene to get the patient better. And how do we recognize sick patients? Okay, so you look at the consciousness, you look at vital signs, you look at urine output, you look at the pain scores, and if you're fortunate enough and you have access to blood gases, you look at blood gases. And these parameters would help you in identifying the sicker patients and directing or putting more concentration on them and deciding on where to treat the patient, which part of the hospital. Okay, and then these parameters like bradycardia, systolic blood pressure, oxygen saturation less than 90, respiratory rate less than 6, Glasgow Coma Scale dropping by 2 points, or onset of coma, all these individual parameters, they increase the mortality by 6.8-fold. So on their own, if it is single, that is 6.8-fold increase in mortality. And then, so you can depend on a single parameter or criteria using multiple parameters, okay? And the single parameters, so if it is at the extremes, definitely give you an intimation or information about the patient's status. But you cannot always depend on a single parameter because of the physiological variability that you can see. And if you take multiple parameters criteria, you can definitely make it more informative, more standardized, and more scientific. So for multiple parameters, you have early warning scores, and then national early warning score or modified early warning scores, and then SOFA and Q-SOFA. These are all some of the methods that we have using multiple parameters. So multiple parameters, you have early warning scores, and here we have 6 parameters. We'll discuss this later in detail. And then SOFA score, again, you are monitoring 6 organ systems. And there is scoring system. And then you have Q-SOFA, which is very simple, and you have only 3 parameters. And this is more like for basic nurse level assessment of the patients. But they have shown to be beneficial at every level. And comparing to all these things like QSOFA and early warning scores, there was a RCT with 13 studies included and about 4 lakh patients. And 6 of those studies reported ICU admission, and all those studies commented on the mortality. And the news, they have demonstrated better sensitivity towards prediction of ICU admission and mortality, though they are less sensitive, less specific for both these parameters. So if you want to definitely pick up patients who require ICU admission or who are at increased risk of mortality, definitely the new scores or early warning scores would be much better. And it is based on the principle that clinical deterioration can be seen through changes in multiple physiological measurements as well as a large change within a single variable. So you're taking care of both a single parameter with a large change and multiple parameters with mild or moderate or severe changes. So who should be included in the rapid response team? The team members are, as a team, they should have ability to diagnose the clinical problem and ability to initiate the therapy, and they should have ability to decide when the patient is to be transferred to higher level of care. And then it can be a physician-led system or a non-physician-led system, or it can be left with the primary team itself. And obviously we understand that the primary team taking care of or looking for or waiting for the physiological deterioration, because it's a single team taking care of some limited number of patients. It's not an entire the hospital system. It won't be an entire hospital system, and there may be difficulties in reaching them, and for them reaching the patient may be difficult. So there will be time delays in identification and initiation of treatment and transfer of the patient to higher level of care. And physician-led service, definitely all those things like identification, initiation, and decisions on transfer, they're promptly done if it is led by a physician. But the difficulty would be the cost. So you have to, money is involved here. So if you have to involve a physician all the time taking care of emergency or early warning signs, then it can be expensive, and probably there should be some system between these two extremes. And how are the rapid response team activated? So the most of the activation or the stimulus for activation is objective, and they also have kept subjective criteria. The subjective criteria being staff member getting worried about the patient. So here comes the gut feeling of the nurse or the doctor involved or the family members involved, and they alert the system. So we'll look into the details, what are the activation criteria. And this, we have to provide frequent reminders to the staff about the activation. So what are the points where they should activate the system? And also educating the staff, the medical and nursing staff, about the activation. And it has to be displayed in stickers and boards, identification badges. So the activation should be quick, and there should not be any delay because they don't know or they don't understand how to activate the system. And then comes various criteria. I know it's not very clear. So the staff member worried about the patient, and then any patient that you are seriously worried about that does not fit to the above criteria. So there are criteria, and if it is not fitting and the patient is, the staff member is worried, then they don't have to hesitate for activation of the rapid response teams. And triggering, the triggering should be available round the clock, 24 hours. And there should be a response. Once it is triggered, there should be a response within 15 minutes. And it should direct patient examination and assessment by the team members, and should be no negative consequences. should not be like, okay, why did you activate? If this patient looks fine, why are you so much worried? That kind of response should not be there. And the response can be reactive. That means you get a call and you act. And or proactive or prospective, that you are worried about a patient, that this particular patient may go wrong at any point. So you warn the nurses, you let me know, or let the emergency warning team know that some particular parameter is not doing good, and alert them or trigger them. And also feedback loop is very, very important. So feedback loop, what does it do? It collects the data and tries to improve the system to maximize the patient safety. And it is done at two levels, at patient level and at administrative level. At patient level, the data is reviewed and the clinical strategies are we try to improve. And at administrative level, the resources are coordinated to ensure that adequate staffing, equipment, and training of the entire system is maintained, right? So this feedback loop is important so that the system runs and improves and not deteriorate over time. Over time, we start something, but over time, we pay less attention, and 3-4 months, the system goes weak. And again, unless there is another major episode, we don't revise or monitor the system. That should not be the case here. So what are the goals of intervention? The intervention goals are identifying the sick patient, communicate the change in the patient status, and provide effective and timely interventions, and avoid delays in ICU transfer. So basically all these early warning signs, that is a track and trigger. So you track the sick patients and trigger the stimulus. Then increase the frequency of patients' observations for low score patients. And then urgent intervention by rapid response team or medical emergency team, and transfer the patient to ICU. So usually the model for rapid response teams, the hospital patients outside the ICU, we look at the clinical stability, and majority of them are stable. But there can be acute clinical decompensation, which can be quick or with some premonitory information. The rare and quick clinical deterioration would be seen in ventricular defibrillations and arrhythmias, acute stroke, and massive aspiration. And the fourth one would be massive pulmonary thromboembolism. So these 4 conditions, they may not give much warning, much time, and the patient may deteriorate rapidly, and we end up announcing code blue for patients on the wards. But the remaining patients, majority, they more than 80%, they give warning signs of their physiological instability. So what can be the outcomes? So early treatment and recovery, or interventions rather, early and appropriate ICU transfer, or delayed ICU transfer, which could be because of a delay in identification, and cardiac arrest if the patient is not attended immediately and transferred to ICU setup. They can land in cardiac arrest, and if they land in cardiac arrest, more than 80% they have mortality within the first 24 hours. And the delays could be because of nursing delay in physician response, or failure to act on the signs of clinical deterioration. So this is how the patient's condition would be, and let's go a little detail into the early warning signs. So what are the parameters that we monitor in early warning signs? So respiratory rate, oxygen saturations, temperature, systolic blood pressure, heart rate, and consciousness on IFU scale. And there is color coding given as well for the extremes. If the scoring high, red color is given, amber and white. So we look at all the 6 parameters, and this is actually it is called National Early Warning Score in the United Kingdom, because they started implementing, initially suggested by Royal College of Physicians in 2012, and they implemented it, and they have seen very good results in terms of identification of patients, and it was initially in certain trusts they started, and later on it was extended to the entire country when they call it National Early Warning Scores. And then this is the data collection sheet suggested by the Royal College of Physicians. We'll wait for 1 minute. Yeah, I think audio is back. Yeah, right. So this is a patient data collection sheet or a monitoring sheet. And what do we do in our hospital? We started implementing this system in 2018. So prior to that, we opened our hospital in 2015, and prior to that, I used to go on rounds as head of intensive care. Morning at around 11ish, I used to go on rounds, speak to the nurses. Yeah, speak to the nurses and ask them if there are any sick patients used to attend. And then but I was getting the information about the patients, but the system was not really geared up to follow up the patients. So then we looked at the possible systems available, and this early warning scores was one of the good and easily usable system. So we formed a team then, including the nursing superintendent, intensive care team, and the medical superintendent. So we call it early warning science team, ICU, nursing superintendent, medical superintendent, and a senior nurse with ICU experience. They collect the data. They're called day supervisors. And also a nurse supervisor will be there in our hospital during the night as well. And we collect the data from the early warning science scores, special instructions given by the treating doctors, and all the post-op ICU care patients who are transferred from ICU, at least for the first 24 hours, they will be on this list. And we maintain 2 registers, one for non-cardiac patients and one for cardiac sciences. And during the day and in the night, the consultant, the nurse supervisor, we take rounds. And if the patients are less severe, less sick scores, we just eyeball the patients. And if the patients have higher scores, we do a detailed examination, action plan, and we document that, so that there is follow-up on the same patient for the next day and next shift as well. So this is how we educate our nurses. We have boards on the wards. So with the detailed information on the early warning scores and what to do if the scores are higher. And then instructions on the board itself, so that even a newcomer to the system, they can understand what to do without much of hesitation and confusion. And this is a data collection sheet of how one of our patients got the data collected. So, and this is a page from a register. So we collect data twice, in the morning and in the night. And yeah, you can see at the right extreme, the nurse signs, the DMO, ward DMO signs, and that is brought to the ICU consultant. They also sign. And if you look at, so the early warning scores, you can see that 2, 1, the score of 1 are also incorporated, because there are multiple reasons for and including patients with lower scores also into the register. I'll let you know. So again, you can see one patient with a score of 5 on the wards. And that is actually admitted under intensive care. So that was the reason, probably it was done most appropriately. So initial data collection, some of the registers were missing when we tried to collect data. Initially, the monthly triggers, the number of patients on the registers were something like this, about 15 to 60. And then 22, again in 50s and 60s per month. And then in 23, this number 3 is the time when we incorporated our post-ICU care patients also into the early warning scores register. So the number has gone up drastically. So this data is, once the patients were reviewed, monthly data about patient getting transferred to the ICUs. So you can see about 26 patients in January 24, and then 23 patients in Feb, and another 25 patients who were moved to the ICU out of about 300, 350 patients who were monitored on the wards, average numbers. So, and again, 20s. So about out of 300, 20 to 25 patients, they're transferred to ICUs, and if the patient was not monitored, we would have missed them and patient would have landed in cardiac arrest situation. So what are the benefits of this system? So sick patients are monitored more frequently, and it generates a sense of alertness among the ward nurses. Patients are monitored by seniors in the nursing ladder, so not just the junior. And then patients are put on track and trigger list, and minimal to no cardiac arrests on our wards now. And the confidence levels of the patients and the family members increases because more frequent vigilance on the patient's vital signs. So, and difficulties and problems, yes, it's not a fully adopted system yet. There are areas to be improved. And the cost issues. The cost is definitely an issue because the intensive care consultant seeing the patient, and that is sometimes obviously that attracts a consultation fee of the intensive care services, and the patients may not be happy because they don't know the importance of it, and then the primary treating teams may not be happy, or the admin may ask why this patient had a consult when they were on the wards. So this is one thing. So we don't enter consults for patients who were eyeballed. Only those who were detailedly examined and documented, then consultation is entered. And as I said, too many patients on the list, because there is confidence that on this system that if the patient is on the list, they will be monitored better on the ward. So the primary treating doctors, they ask for entering the patients on the early warning scores register, right? So even when the actual guidelines say that they're not to be entered into the system, so because of this gut feelings, more number of patients are entered into the register and asked for follow-up. And because of this, the threshold is also decreased. So the way forward would be, there should be a group level policy for early warning scores, I mean, in Apollo or any other hospital, and to include early warning scores related parameters in the quality parameters, and admin decisions on the cost aspects, which patient should be especially if it is a cash patient, what should be the cost. And need for post-ICU care rounds for 2 to 3 days at least, so that patients' deterioration, if at all they deteriorate, is identified early and brought back to the ICU. And we have Code Blue committee in every hospital in Apollo, all Apollo hospitals, and even EWS also should be included, and the data should be analyzed periodically. So this inclusion of this data and analysis would definitely, that follow-up and maintenance of quality would be ensured. So in summary, so rapid response team or early, in our hospital we call it early warning signs, as I said. So it should assess the patients and trigger a response, then afferent limb that gets activated. You act on the situation, stabilize the patient, or follow up the patient for some more time, transfer the patient to ICU, and treat him for better outcomes. So definitely this helps in identifying deteriorating patients timely and treating them effectively. So thank you very much for patient listening. This is one of our patients who got discharged after 70 days of ICU care, and this patient also underwent ECMO. I'm not saying that we are competition to Niranjan here, but we also run ECMO program in our ICU at Vizag. Thank you very much for this opportunity.
Thank you,
Dr.
sir.
Achyut.
That was a great talk. Now I am requesting Dr. Manoj to felicitate Dr. Achyut.
Just before that, thank you, Dr. Achyut. Very nicely covered all the things required. Regarding the EWS, we have also in Apollo Hospital recently we have launched specialized DOSI beds where the EWS parameters are monitored at the central unit, and the nurse monitoring there. If she recognizes any parameters are fluctuating, then they call the nurse in the ward or the RMO, and the RMO will have a look at the patient, and if anything required, the met call or anything is activated and the patient is being taken care there or can be shifted to the ICU accordingly.
So actually DOSI beds, it's a ICU at bedside on the wards actually. So the patient is monitored with a sensor on the patient's body, and it is connected to a router in the room, patient's room, and there is a central monitoring unit which is displayed in the nursing station. So the nurse, they don't have to go to the patient if this sensor is there on the patient's body. So they can see the parameters and alert, because then there is an alarm system in the monitor. So it will flash light, but we don't have audio signals as of now because it will be disturbing for other patients. So that is enhanced monitoring system that we have in Apollo, some of the Apollo hospitals, and fortunately we also have, and that is being initiated, and we take the help of DOSI monitoring system as well in our early warning signs. So that is a complementary system to enhance the patient safety, which is implemented in Apollo. Yeah. Any more questions? Thank you.
I am requesting chairperson to be on the stage only for the next talk. Now, to update our knowledge on the traumatic brain injury, I would like to call Dr. Ranjit Unnikrishnan, who is the head of Department of Critical Care, Apollo Hospital, Kochi. Over to you, Dr. Ranjit Unnikrishnan.
In 2 minutes, I just need to connect this. Can I just close this? Keep it over this. Okay. Just connect this to. This one. It's email. Am I there? Why is it not going? Okay. Good afternoon, everybody. Thank you, Dr. Akshay, for actually letting me talk here. Actually, it's very, a very interesting and very exciting thing to see the Apollo, the intellect It's actually new to the Apollo ecosystem. So I know that, of course, the critical care department in different Apollos is itself a huge resource which we probably underutilize. So let me start with this Hippocratean quotation, actually, which is very profound and very deep, which stands true even now. Of course, we've seen people who just walk and then die in the ICU after they're admitted with moderate, what you call like a GCS of say 10, mildly confused. They may be talking, and then you suddenly see them not doing very well, and you've seen people with GCS of around say 4 or 5 who have struggled a lot, actually coming back to you after many months and doing reasonably okay. So that is one fundamental thing that we need to be thinking about when you're actually treating traumatic brain injury. Sorry. So it's a big problem. We know it is actually kind of an epidemic when you consider polytrauma and TBI. It's profound economic and social impact. There's a propensity towards the lower income group for that to happen, and that actually is also biasing the treatment, and they may in a way affect the outcomes also. So, neuroprotection has always been elusive. There are a lot of medications which hardly really has made any big difference, and so we are left with secondary brain damage prevention and management. Now, anything less than 15, 14 to 9 is moderate, and now 8 and less is severe. That is a recent change in the GCS way of looking at a severe to moderate TBI. This, of course, this is fundamentally, that is a primary. The primary hit is mechanical. The secondary hit is either perfusive or it's metabolic. So basically, there's an acute response to that, and even there's a chronic response producing, significant cognitive and other effects. Again, we know that TBI is a systemic disease. Like almost everything is a lot of cross-talking everywhere. So it's actually a systemic inflammatory condition. There is a breakage of the blood-brain barrier. There is actually the polymorphonucleus get into the parenchyma. They recruit microglia and astrocytes. They are basically macrophages, the microglia of the brain. So basically, it's a two-way actually. It actually can initiate a systemic response and a coagulatory response also. So cirrus is there, multi-organ dysfunction is there. It actually produces clotting dysfunction also. As we've been mentioning multiple times, all these things actually can be procoagulant. At the same time, it can consume, so then it can end up in a anticoagulant state. On the same side, when you say procoagulant, there is an antifibrinolytic situation also happening, so the body needs to produce both things. So I think it's a very fine balance that happens, even in liver dysfunction, as I was mentioning the earlier talks. I'm sorry for the cough that I'm having. So this is another thing that we need to know when you look at any brain thing. See, this is a CPP, that is a cerebral perfusion pressure. It's not only the MAP or the ICP, I mean, so it's an actual difference between the MAP and the ICP. So what it means is that a large CPP, for a large MAP, for the cerebral perfusion pressure, the cerebral blood flow doesn't change much. So you can see the cerebral blood flow is almost flattish, or kind of flattish for a large, from around 50 to say 100. This may change according to the patient's conditions like their pre-existing vascular tone, hypertension, etc. But this is one fundamental thing which we look at, which is the basis of a lot of neurocritical care, hemodynamic management. I mean, like most of the organ, brain doesn't actually, the brain's perfusion pressure doesn't really depend on the MAP and the CVP or the venous pressure. It depends on the MAP as well as the ICP, because you know that the autoregulation happens predominantly at the pile arterioles here, and the venous regulation happens because of the ICP's presence at the venules before they enter the large veins. So this, of course, you can understand that as the pressure is increasing, the vessel is constricting. So this is basically primarily a myogenic thing that happens, and there are other things which actually helps it. But after a point, if you still continue to increase the pressure, it will just dilate. Means there will be a lot of increasing blood flow, which can increase the ICP also. And if you actually you reduce the pressures beyond a point, the vessel collapses and you end up in ischemia. So this is the safe zone of CPP. So this is another picture which actually mentions that. So you can see that these are the pile vessels, the venules which are entering the CSF space, and actually the CSF pressure increases, they get constricted here, means here. This is the ICP part of the brain. So if it constricts here, then probably this pressure hardly matters. That is why ICP becomes the restricting pressure of the cerebral perfusion. Again, this is important for ventilation also, because even when you have an extremely high PEEP, like you're putting 18 and 20 with a high ICP, it is possible because many times that is not reflected into the system because of the collapse of the bridging veins. That is one theory that has been proposed. I'm saying that it's not contraindicated, which we'll come into. This is the ways of auto-regulation here. Predominantly myogenic, there are perivascular nerves, there is endothelial factors, metabolic factors, of course, the most important being carbon dioxide. You can see that there is almost a linear relationship between the cerebral blood flow and the partial pressure of carbon dioxide, which is we are utilizing when you kind of ventilate them, hyperventilate them to maintain ICP. So this is another picture which shows the whole the way cerebral blood flow is managed. Why it is important here for any neurocritical discussion is because if you can manipulate your stroke volume, mind you that many of your patients with severe TBI could be having cardiac dysfunction because of stress, etc. And if you're not really looking into that part, an inotrope would actually increase your cerebral blood flow. So basically looking at the whole of hemodynamics is very important to actually improve the cerebral blood flow. The cerebral vascular resistance also is one of the important things in vasospasm and stroke, and hydrocephalus and other things are important to be drained to reduce the ICP. So the tissue edema is what we will be predominantly reducing by using hyperosmolar therapy in reducing ICP. So this is how generally this is the determinants of cerebral blood flow. So the initial resuscitation targets of TBI management, moderate to severe TBI management is a map of say 80 or a systolic blood pressure of around 110. Basically, this two numbers has come from the Brain Trauma Foundation recommendations in the fourth edition. So 16 is the last recommendation. It has not been revised after that. There are multiple other guidelines which has come up. The other things are keeping the saturation above 90%. It's not the target, but at least 90%, so that hypoxia is prevented. And to maintain a ETCO of around 35, HbF more than 7. If it's really in the ICU in the long run, whether it is more than 7 or whether it is 8 to 9 is a bit controversial because there are gray areas where the decision has not exactly happened. Anticoagulant reversal, of course, is the initial important thing to be done because the patient is already on an anticoagulant. Unless you reverse it, you could actually, the bleeds could extend. So this is another graph showing the U-shaped curve of systolic blood pressure and mortality in severe TBI. You can see that around, say, 120, 130 range is the best survival that you could get. The mortality goes up either way. The next part is urgent imaging and neurosurgical intervention. This patient, of course, you know what to do. He goes to theater, basically getting the fundamentals. His resuscitation will be done mostly in the theater. One thing you have to be aware of at such situation is the blunt cerebrovascular injuries, which actually are caused by injury to the carotids as well as the vertebral arteries due to intense, shear movements that the neck and the head has. This could be initially totally missed because shadowed by the TBI. But if you get things like new onset focal neurological deficits and all, which are not correlating with the initial scans, probably should be thinking of blunt cerebrovascular injuries, which has to be picked up by a CT angiogram. So the timing and requirement for that is depending on how much you suspect it. This is the other images. Of course, we don't have to discuss everything. EDH has to be drained unless it's very small. Mostly it will anyway enlarge in size. Contusions if the sinuses are involved or the bone flap is elevated. SDH, of course, if more than 10 millimeters and there's a more than 5 millimeter midline shift. Diffuse axonals, etc., probably doesn't require a surgical intervention. In the ICU, the next important question is whether the patient, of course, everybody goes on for complete neuromonitoring and the entire ICU management as usual. But the question would be whether the patient requires an ICP to be ICP monitoring to be done. So that is one thing. Especially all severe TBIs, the recommendation is to go for ICP. Anybody with a GCS for less than 9, the recommendation is the international recommendations is to go for ICP monitoring. Whether that can be extended to moderate TBIs, that depends on the patient is already, you need to sedate them, you need to paralyze them, you need to be like they have other comorbidities. Probably when in doubt, it's better to have an ICP monitoring done. This has not exactly been, validated in large clinical trials. This is the best trip is a South American trial, Ecuador and Bolivian trial. It's a significant number of patients where they could not really, they actually tried between, frequent clinical imaging versus ICP, where they could not really, show a difference between the outcome of these two limbs. So basically, this has not been translated into outcomes, but as you know, that is a different discussion. General recommendation is to go for ICP monitoring. Repeat imaging, usually after 6 hours, or any urgent imaging when there is a fall in your scores. Fluids, U volume is a target. You don't kind of hydrate like old times and kind of try to increase the cerebral perfusion. So U volume is a target. Saline is the usual drug. Hypotonic solutions, including RL, are not really recommended. Albumin is not recommended as part of the SAFE trial. It's a very old trial, but subset analysis, albumin is generally not recommended in acute TBI. Unless there's other reasons for doing it, it's not a resuscitation fluid. Again, I talked about the SBP. This is systolic blood pressure, something like 100, 120 with a MAP of around 80. And the usual hemoglobin target is around 8 to 9. There are multiple trials which have attempted to actually, differentiate between 7 to 10. But the subset analysis have actually shown benefit when they're using a HbF around 9. So basically, the recent recommendations are to go by a bit higher, more than 7, not more than 10, maybe 8 or 9 would be an appropriate HB target. Meanwhile, ICP management with an ultrasound is not very easy. You could actually detect that there is an increased ICP by an optic nerve sheath diameter. Most of you probably would be doing this already because there's a lot of postgraduate interest in ultrasound related things. So basically anything more than 6, around 3 millimeters posterior to the papilla, the fundus is actually suggestive of raised ICP, like you can see here. Meanwhile, if you can have a look at your, the brain ultrasound, you could actually find out very interesting things which could actually help you in your management. They actually have given blood flow parameters as targets also, like if you use a diastolic velocity of more than 20 centimeters or a pulsatility index of less than 1.4, this could actually be targets of looking at the cerebral blood flow without significant raised ICP. This is just to mention how TCD looks like. It is a low resistance waveform with a sharp peak but decelerating slow downslope, and there's a significant diastole. So the diastole is this thick, means this is a diastolic velocity. So you should have a significantly good diastolic velocity with a slow downslope. This is how in TCD generally, this is a MC which has been actually insinuated, and you can see the color. So you're looking at the waveform predominantly, and then if you're interested, you could look at the velocities also. And the pulsatility index is something like the pulse pressure that of the brain that you're looking at against the mean velocity. So that shows you about the distal vascular resistance. Once the pulsatility increases, basically it means that your distal vascular resistance is increasing. It could be due to any reason. So that is why it is important to get a basal, snapshots, and otherwise you will not be knowing whether it's a basal shot or that the ICP is actually producing the distal resistance. So it is not a bad idea to start with the transcranial Doppler. This is how a waveform worsens when the ICP raises. You can see this is a normal, good-looking, low-resistant forms. These are sharp forms with high peak velocities, with reducing diastolic velocities. And here you can see very peak sharp velocities with the diastolic reversal of flow. These are all very, very doable things, and the learning curve is not that great. The same thing you can see here. Only there is significantly high ICP. There is only the peak systolic thing, and this is a cerebrovascular arrest. There is no flow in the brain. This is not exactly in line with an ICP, but this actually helps you to identify what is happening in the brain vis-a-vis the blood flow, which probably is the most important thing. We're not really looking at the flow, the pressure. We're not looking at the ICP. We want to see whether the blood is flowing on both sides. These are about the MCAs. The posterior circulation, you're not talking about the posterior circulation. Coagulopathy, you already discussed, it has to be corrected. If it's drug-induced, there could be some consumption-related, coagulopathy also when the brain is, full of phospholipids and, procoagulants. The general target of INR is 1.4. You could use, multi-factor PCC, plasma, cryo. Even the direct-acting, the newer anticoagulants also. This is the practical way of looking at it because, the exact antidotes are costly, not easily available. Dabigatran is dialysable, so if you could dialyze in between a TBA, you need to be looking at that. Platelets, always we have problem with platelet. The main issue with platelet is the numbers, like 75,000 or lakh that you have to keep. And the other issue is, so there's a reason for platelet number to be less, that is probably not going to be easily corrected. Like there's an immune-related thrombocytopenia. It is not easy to get corrected unless you're going to hit the immune side of it with an IVIG or whatever you have at that point of time. So the number said to be 75,000 to 1 lakh, but to maintain that would be a problem. Now, what if the patient is on antiplatelet agent? So most of the data in most of the situations have not really advocated giving platelets because of, especially with clopidogrel, because of the long effect of the drug. But there are some data that says that if there's a surgery that you want to do, of course, or if there's a deterioration, you could try with the platelet transfusion. Factor 7 is not recommended. Even spontaneous IC bleed we have seen trials which are negative. The DVT pump should be initiated as early as possible. Chemoprophylaxis with drug prophylaxis with heparin or low molecular weight heparin as early as possible. It could be second day if it's very stable, or after maybe a couple of days as the surgeon is getting more confident about non-expansion of lesions. Tranexamic acid, of course, we know from the CRASH 3 trial, it is useful for polytrauma, and it should be used for all severe TBAs. Not exactly severe TBA. If it's severe TBA alone, there is no data as that it can improve because it's already pretty bad. Moderate TBAs, there is data. So basically, practical thing is to use tranexamic acid as in general. Seizure, there are two kinds of seizures that could happen. One is an early seizure. That means in the first week, that is a concussion seizures, and what you call that, because of the trauma that is happening. They're generally not, they can complicate the course of the illness because that increases the oxygen requirement, increases the ICP. So basically it can complicate the course, it can increase the ventilator days, but that may not really convert into poor outcomes. And you can see that 20%, 30%, it's very common in severe TBAs. And The prophylaxis, the indication is a GCS of less than 11. There's cortical involvement, there's a depressed skull, or there is subdural hematoma. All these things, anywhere where cortex is actually really irritable, obviously you have to be giving a prophylaxis because it can reduce the early occurrence of early seizures. So early seizures can be reduced by giving prophylaxis. So levetiracetam or phenytoin. The levetiracetam is generally the preferred drug. The data is not very great, but the trial from the subarachnoid hemorrhage, which showed phenytoin causing reduced cognition in long term and all, actually is we have an inclination towards using levetiracetam. It is efficacious and probably the preferred drug now. That is for the early seizure prevention. Late seizure prevention, that is after the first to second week, is probably not exactly, has a different pathophysiology. It could end up in post-traumatic epilepsy, and it has to be dealt with by experts. And the point is, almost 20% of severe TBIs are in non-convulsive seizures. So there is a reason that you don't really understand why the patient is not wakening up. Intermittent EEGs or continuous EEGs as per your situation is warranted. Glucose, nothing new or nothing different. This is, you don't want hypoglycemia. That is the first thing. You never want hypoglycemia. Hyperglycemia is not good. We all know that. But basically, the idea is to maintain something like a reasonable sugar level. Temperature management, neurological insult. We all know that you should be avoiding fever. You should target normothermia. Antipyretics is the first line. Paracetamol infusions. If you have cooling devices with loops and all, they probably will help you in maintaining normothermia, which is not very common in our place. Or you can use surface cooling. Induced hypothermia has no real role in prophylaxis. That is, if you want to protect the brain with using a lower temperature, it's not recommended and it is harmful. If the patient is already hypothermic without doing anything, there is non-induced hypothermia. In such situations, we are not sure whether they should be warmed or not. Generally, those patients could, even though it looks like there's a hypothermia, those patients do worse. There are many ICP, many ways of looking at the ICP. Most commonly, it's an intraparenchymal, or you do a ventricular stoma with an EVD. This is a Codman intraparenchymal device. This is an EVD of when you're actually looking at a CPEP. There are two ways. You have to make sure that the map is measured with the pressure transfer to the ABP at the level of the tragus. That is a foramen of Monro, where actually the EVD is also zeroed. The transducers should be, both transducers has to be zeroed in a supine position when you're doing it at the level of tragus. That's a foramen of Monro level. Otherwise, you could actually significantly differ. Around 20 millimeters of mercury difference in CPP could happen. So this has to be done in supine. So you know these are the waveforms. This is how it generally in ICP waveform should look like when you look closely. When you see that the P2 is actually, the P1 is the systolic waveform of the arterial thing, is a dichrotic notch reflection. So this is something that is kind of a compliance that is reflected, P2. So P2 cannot be higher than P1. When it actually becomes less compliant, you get something like a curved ICPs. ICP waveforms. These are the other waveforms. These are the Lundberg's type A waveforms, which are very long, like 5 to 20 minutes. They are they actually have produced very high ICPs of around 50-60 millimeters. And these are less common, less aggressive ones, like say 20 millimeters, 25 millimeters. They are the type B, and these are the normal Lundberg C waveforms. The relevance of this is unclear. This is catastrophic, and this is an indication for intervening. Now, the ICP tier-based management, all patients, head up, intubation if required, temperature management, oxygen management, etc. Analgesia to a comfortable level of RAS of -2, if in the level 2. Drainage of CSF, we have to have a drainage, CSF drainage point at this level. An EVD has to be inside, and ICP has to be monitored, and you have to drain as required. There are two ways of draining an EVD. One is a continuous drain, like you put an EVD, you set a value, and you just continuously drain for many hours, so that the ICP just comes down. Or you can actually transduce it, and you can intermittently drain it. So the next year actually, after an inter-tier CT may be required to rule out whether it's any correctable thing. And here the sodium target is around 145 to 50. This is around 150 to 160 higher targets. You can use a neuromuscular blockade at this point. And here at the tier 2, actually the sedation targets are much deeper. They had to be -5. And CPP, you could target, the usual CPP target, as we mentioned, is 60 to 70. You could target a CPP of more than 70 here. The only problem with targeting more than 70 CPP is you don't know whether the patient is anymore auto-regulating. So that could immediately translate into hyperemia and raised ICP. For that, actually, the test of auto-regulations that are available. And the next level is a tier 3, where actually you do decompressive craniectomy, the secondary decompressive craniectomy, which means that you're doing a craniectomy only to reduce the ICP in a diffuse injury, not for exactly a lesion. And barbiturate coma as well as hypothermia. The hyperosmolar therapies, 3% saline is the usually preferred one. The data is towards 3% saline, not very high-grade data. The ease of use, the ease of measuring the numbers, and mannitol is the next choice. Here the target is around 155. So here the target of osmolarity is 320. You have to check for a bolus in the initial in the ED, you don't have to use a CVC, but in the ICU, you have to be having a central venous catheter. You could use boluses as required. If the patient is hypernatremic, you have to be careful about bringing down the sodium. You have to be wary about the occurrence of diabetes insipidus, central DI, because it's quite common in severe TBI because of loss of the hypothalamic injury. So in those situations, you have to manage the volume status also. This is one ongoing trial, sugar or salt trial, with the randomizing severe TBIs with mannitol and hypertonic saline. They're giving boluses of 20 ml, 20% mannitol or 3% saline till you get an sodium of 155 or an osmolality of 320, 330, and seeing whether that is which limb is going to do well. They are looking at the 6 months outcome scale. This could give us better information. Impending herniation, we know that close monitoring has to pick up an impending herniation, brief hypoventilation, around 30 PCO2, boluses of hypertonic fluids, rising MAP if it's not already, you know that in a usually auto-regulated person, the MAP increases significantly when the ICP increases. If somebody is in shock and the patient has a raised ICP or a bad brain, that is very bad news. Their outcomes have to be maybe very bad. So the ultimate thing is to see whether there's an imaging requirement leading to a neurosurgical intervention. This you already mentioned. Lower ICPs, -2 RAS is fine. Higher ICPs, you want deep sedation, plus minus neuromuscular blockade, Venta-Propofol is the. Now ventilation, of course, is a very detailed topic in acute TBI brain injury, but the general consensus now in the last 4 or 5 years, what we are seeing is everything that you could do with a normal person could be done because it's a salvage. In a salvage situation, even proning is okay. Recruitment maneuvers are okay. If you believe in recruitment maneuvers and you really want to do some kind of maneuver, it's not contraindicated. So even ECMO is okay if you are ready to run it without heparin, or in cannulation if you are going to use less heparin. Only thing is if you actually doing an ECMO in a patient with TBI, you have to be wary about the sudden shifts in carbon dioxide which can produce sudden severe vasoconstriction and all. Other than that, the general, I don't think you can read this. This only means that these are the myths and these are the targets. The messages, it doesn't change much. All these things, high PEEP is okay, because if generally we have seen that higher PEEP doesn't immediately relate into higher ICPs. If an ICP measurement, that's pretty good. We cannot overdo it because after a point we know that the intrathoracic pressure start affecting the ICP and the outflow. So basically none is contraindicated, that is the whole message. Now coming to multimodal monitoring, beyond ICPs, what all could be monitored? I said about this is a driving pressure CPP, and local blood flow, if you could use a TCD, the brain tissue oxygenation, either you put a needle into the brain called Lycox, which can actually sense the oxygen, or you can use something like NIRS, which are kind of the external non-invasive counterparts, probably inferior in TBI, not recommended right now. Microdialysis, where you put catheters and see what is happening in the milieu. You look at the glucose level or the pyruvate lactate ratio, glutamate and all, which can help you in say whether the patient, the organ is getting enough oxygen to metabolize, and EEG. These are all multimodal monitoring, which can be mixed and matched according to the availability. The current data evidence is pretty lacking at this point of time. If you look at large trials, there are centers which are very kind of fond of this, as it probably happens in the initial part of any new intervention. So these are the kind of targets when you're using all these modalities. So any CPP of less than 50 is going to be critical. Any oxygen or tissue oxygen of less than 15 is going to be critical. Lactate pyruvate of more than 40 is critical, and blood glucose, brain glucose of less than 0.5 is critical. So these all values could help you in deciding whether this patient needs extreme therapies or salvage therapies. That is the whole point. As you mentioned, this is NIRS, and two ways of looking at brain oxygenation. And another concept that has come up is the test for autoregulation. Autoregulation usually can be tested by looking at the difference in the MAP and the CBF, that's the cerebral blood flow. Basically, if the MAP is increasing and you have a corresponding increase in CBF, probably they're not autoregulated. When you increase a MAP, you're expecting the CBF to not increase anyway. It can decrease also, but it cannot increase. So this is something called a pressure reactivity index, where MAP and IAP are actually graphed against each other. You can see this kind of a linear relation for increasing IAP, ABP and ICP is not good autoregulation. This is how it usually looks like. There are many ways of looking at autoregulation. To look at autoregulation, you should have a way of looking at the cerebral blood flow. One simple way of looking at autoregulation being maintained is to give a MAP challenge. You increase the MAP by 10 by increasing the noradrenaline dosage. It will be done on the bedside when doing this, of course. And whatever you have measurements you have at a TCD, you can use for CBF, and you can look at the ICP. And after 10-20 minutes of 10 minutes of increase, you can see how it is responding. We don't expect an increase in ICP when you increase a MAP. That is happening, your autoregulation is not present. If that is present, that is autoregulation is present and there is no increase in ICP, then there is a case for increasing a CPP beyond 70 if you think that the patient's tissue oxygenation is not met. So that is the importance of knowing this. So this is a Seattle, the couple of years back, a Seattle consensus statement, which is probably the largest statement of treatment of TBI, severe TBI. So this is the tier 1, which we already mentioned. So they look at two things, ICP versus tissue oxygenation, and they actually have made a kind of a column like this. Here actually you have a raised, there's a raised ICP, but your PTB is normal. In type D, you have a raised ICP with low PbTO2, which is brain oxygenation. And this is the algorithm they are given. This looks pretty colorful and complex. So what they're trying to do is, the idea is if you have a raised ICP, you need to reduce it down. And if you actually have a low PTBO2, you could try increasing the cerebral perfusion by increasing PCO2. There is no increase in ICP, like you have it here. This ICP looks normal. The PTBO2 is high. Here you could probably go for a bit of hypoventilating with some hypercapnia because it vasodilates. Looking at the ICP, here actually you have a raised ICP and the PTB is normal. So here probably you have to go with the ICP related steps that you could manage, and here you could probably look at the MAP challenge and see whether there's an autoperfusion, the autoregulation is maintained, and you could try with some increased CPP. So this is basically some fine manipulations which can be added to the ICP management if you have an additional brain oxygenation. But there are 3 trials that is happening now recently in the 2-3 years where they combine multimodalities, especially brain oxygenation and ICP, and the OxyTC is the French trial. You can see there's absolutely no difference in the survival after randomization. So in large trials, these are not really met with good outcomes, but that have not taken out the enthusiasm in select centers, which are very hard proponents of this. The salvage therapy, barbiturate coma, definitely it can reduce cerebral metabolism, cerebral blood flow, it reduces IC. We all seen that in multiple situations. Only thing is it's a very, kind of a very potent drug, so it can reduce the metabolism of the entire system, it can produce even immune paralysis. So basically it has to be used judiciously unless you have an EEG, continuous EEG. It's extremely difficult to use because once you achieve a burst suppression, if you continue to use that, there's no additional benefit but definite harm. So basically you have to have if you really want to do coma in the proper way, you have to have a continuous EEG or at least intermittent EEGs if you can't afford a continuous EEG. And the endpoint is actually reduced ICP. So if you actually give a test dose of barbiturates and you get a target, give a target time, if you're not getting a reduced ICP, it should not be continued, because then continuation doesn't help, but it definitely harms. There's no doubt about it. Hypotension is the commonest immediate concern, which has to be. Obviously, you'll be having one stack of vasopressors, vasoactive agents, and other stack of AEDs and all these things when you're doing this. Now, secondary decompression, which I was talking about, means we actually want to decompress just because the patient has refractory ICP, not for a primary neurosurgical reason. This has been obviously reduces ICP, there's no doubt about that. There are 2 trials, NEGM DECRA and Rescue ICP. This is in NEGM 2011. Actually, they were very aggressive. They just went in, if the ICP was more than 20 for 15 minutes continuously, they just went in and did bilateral bifrontal hemicranectomy. This is a pretty old, everybody probably would know. But you look at the standard, this is a dead, and this part is the the poor outcome, this being black being dead. So there is no difference in this to 6 months and 12 months. It did not really improve mortality. So this was probably thought of as a negative trial. But rescue ICP, significantly, you can see the surgical group. This is not that aggressive. This is actually when there's a refractory ICP management failed. This is a tier 3 actually. So this looked better than this because the surgical group outcome, the mortality was significantly less. You can see that in 6 and 12 months continuation. But the contention was that the severe, disability part significantly increased. So probably that's a corollary of what we're doing. But at 12 months, there is a secondary analysis has probably shown that there is some favorable outcome. So considering rescue ICP's, the results, we know that it can properly done, it can prevent death, it can increase in survival, but you have to, at a cost of, a lot of things which you have to manage. Other thing is, induce hypothermia for reducing ICP. There are 2 trials again, Eurotherm and the Polar trial, both are negative trials. You can see there is significantly increased mortality in the hypothermia limb in the Eurotherm, the earliest study, as this also is showing almost similar mortality, similar outcome variables, that's a Glasgow outcome scale, as well as mildly increased mortality. Yeah. This is the extended outcome scale that is usually being used. Based on which all these studies are done. So basically, you can see that dead is number one in the scale, and very excellent recovery is 8. So anything like this, 4 is a cutoff where up beyond which basically the patient is called dependent. So again, let's finish by saying that 87% of the TBI deaths are due to withdrawal in the ICU, and 50% of them are because of, in the first 72 hours, from the central TBI data. So probably there is a lot of pessimism in severe TBIs. So probably it will be more gentle in deciding that they could have a long, meaningful life also. So thank you.
Thank you, sir. That was a great talk. Now I would like to request Dr. Pallavi to come on the stage and facilitate our speaker as well as judges.
Velocity of slippers. Away.
So as we all know, with the help of ultrasound, we can diagnose many conditions. That was more accurately and quickly. So can we use it as new stethoscope? To answer this question, I would like to call Dr. Bharanidharan, who is working as senior consultant in Apollo Hospital, Trichy. And the chairing the talk would be Dr. Anjali Palvia and Dr. Resham Kukreja. Over to you, sir.
Namaste. Good afternoon to everyone. I think it's getting late. A very good morning to everyone who are gathered here, my seniors, juniors, experts, chairpersons, and a very big thank to Dr. Akshay sir for giving me this opportunity. I think we'll have to wait for a few more minutes. Okay. It's making noise. It's making noise. Stand a little behind. A very good morning. So my topic for the day will be ultrasound in ICU, a new stethoscope. So as we all know, the ultrasound has progressed from the radiology department, cardiology department to the ICU department, and it will be time that the ultrasound will reach the bedside and even the ward side in future. So my topic is actually a vast topic. So covering it in half an hour, I am going to rush through the topic. Pardon if for the speed. So this is the first ultrasound device, diagnostic ultrasound device. It was used in 1959 by Sir Ian Donald. So as time passed, we have come to this. This is the handheld point of care device. So coming back to ultrasound in critical care, we have progressed from what was belonging to the radiologist and cardiologist to the intensivist, and to be able to do investigations by the bedside to give a rapid decision and for timely intervention. So you won't be surprised. There's a study called this ICU sound protocol. So here, for about 125 patients who were admitted to the intensive care department from the emergency, they did point of care ultrasound on admission. So what they found was 25% of the patients had a change in diagnosis. So this is not to put down the clinical examination, the physical examination, but the addition of a point of care ultrasound to the physical examination definitely helps in improving the rapidity of diagnosis. So there are some other randomized controlled trials where they have done bedside focus during ward emergencies, where you can see without focus the immediate diagnosis has arrived only in 80% of patients, with focus it's 94%, and the initiation of treatment, it's also very rapid with focus. Similarly, there are several studies where they have found out that early initiation of focus has resulted in a dramatic improved outcome compared with physical examination alone. So coming to the basic physics of ultrasound. Excuse me. Okay, so it's coming there, it's okay. So if you see here, frequency of sound, which is, thank you. If you see here, the frequency of sound which is less than 16 hertz are called infrasound. They are not heard by human beings, and which is more than 20,000 or 20k hertz is also not heard by humans. So whichever the frequency more than 20,000 hertz are called ultrasound. So the medical ultrasound, it uses a frequency between 3 to 12 megahertz. And we know the basic physics, wavelength is inversely proportional to frequency. That is, as the frequency increases, the wavelength decreases. So a probe which is emitting high frequency will have a comparatively lower wavelength compared to the one which emits a low frequency. And higher frequency ultrasonic probes will give a high resolution and a low depth of penetration. The opposite happens with the low frequency probes. So coming to the lung ultrasound. So this is a curvilinear probe, and we have the linear probe. We can use both the probes for lung ultrasound machines. And regarding the position of the patient, there are basically widely used protocol is called as the blue protocol, otherwise called the bedside lung ultrasound in emergency. Here the patient is put in supine position, and you are going to place both your hands on the anterior side of the chest with your thumbs overlapping, and the hand should be placed just below the clavicle. The midpoint of each palm is taken as the upper blue point and the lower blue point. You can see it here. This is the upper blue point, this is the lower blue point, and you draw a line laterally to this lower blue point, and that should intersect with the posterior axillary line. So that point is called as the Plapp's point. So you basically put your probe on these 3 areas on both sides of the lung. So that will, you can get a comprehensive examination of the lungs. So for a detailed lung examination, you divide the chest into 6 areas. This is the sternal border, this is the anterior axillary, this is the posterior axillary line, this is the midline of the posterior side. And along the nipple, a line is drawn, horizontal line is drawn. So in each hemithorax is divided into 6 areas, 6 zones, and totally you have 12 zones. And lung scoring was given based on the imaging we get. We'll go into the detail now. So this is a landmark study. So here for COVID-19 patients, they did this lung ultrasound scoring in these patients. What they found out was they included 1,462 patients, and if the severity of the lung ultrasound score was high, so out of 36, so basically there is 12 zones, and each zone is given a score of 0 to 3, so maximum score is 36. So out of 36, if they have a high score that is more than 17, there is a high probability of a COVID pneumonia, so which had a positive predictive value of 97%, sensitivity of 93%. That is, these patients turned out to be COVID positive. So this is basically your lung ultrasound in a nutshell. So you can see here, this is a normal aerated lung here. You can see there is a line here. Sorry for the poor imaging. There is one more parallel line here. So at equidistance, parallel lines will be here. These are called A lines. So normally your lung ultrasound will not produce any image of the lung architecture. Whatever we get with the normal lung is an artifacts. So these lines are called A lines or artifactual lines. So once fluid starts getting accumulated in the lung, you start getting B lines. So if the number of B lines are less than 3, these are termed as physiological or non-pathological. So they can be normally present. Once the number of B lines increases, if it is more than 3, it will be like this. So in case of a severe pneumonia, so the stage progresses like this, and it will end up in a dense consolidation or hepatization, you can see here. So as the lung aeration decreases, your severity of the lung ultrasound picture worsens. You can see here, this is the normal lung ultrasound. So this is where you have kept the ultrasound probe. This is the skin superficial structures. You can see the pleural line here, and these are the A lines at equidistance. So suppose if the distance from here to here is 2 mm, the same distance will be present here also. These lines are basically because of an artifact called reverberation artifact. So next coming to the physiological B lines. You can see here, there are only 2 B lines here, and A line is present in between the 2 B lines, and it is less than 3 in number. So this is called physiological B lines. So this will be followed by interstitial edema. There are a number of B lines, significantly increased number of B lines are present here. So as it worsens, this leads to alveolar edema. You can see a ground glassing pattern here. There are no A lines. There are multiple B lines here, so that this gives an image of an ground glassing appearance. This is present in alveolar edema. This is specific for severe pulmonary edema as well as in severe ARDS patients. In patients with pneumonia of dense consolidation, you can see this pattern here, also called as hepatization. Here you can see the liver image, and here you can see the consolidated lung image. So a collapse will also look like the same, the only difference being a dynamic air bronchogram. Here you can see the air spaces which will increase with inspiration and collapse with expiration. I'll put the image later. So the basic pathophysiology with B lines is, these are the alveoli. These are the alveoli, and in between the alveoli you will have the interlobular septa. So those are the first place to get fluid accumulated inside the lungs. So once the fluids get accumulated inside the lung, the ultrasound rays which were getting reflected from the pleural line starts to enter the lung parenchyma. So those lines are interpreted as the B lines. So now coming to the pleural effusion. So this is a right hypochondrial view. You can see this is the liver, this is the diaphragm, and you can see a hypoechoic shadow region, because basically fluids and bloods, they are hypoechoic. They are seen as black images. Yeah. So here you can see this is a fluid, but you can see particulate matter within the fluid. These are supposed to be exudative effusion. Here you can see the collapsed lung which is floating inside the pleural effusion. This is called jellyfish sign. This is plankton sign. These signs are very specific actually for effusion. So there is a trial which is ongoing, that is the Octopus trial. They are doing it to compare the CT scan along with chest X-ray and lung ultrasound score for the diagnosis of pneumonia. So this study will get completed by 2024, I think. So by then we'll have a clear set of guidelines if it turns out to be significantly positive. Again, here in another study, in patients who are admitted with dyspnea and ultrasound, if they do a serial ultrasound examinations, point of care ultrasound examination of the lung at every second hourly interval, what they have found out is the severity of dyspnea drastically decreased in those patients who have been examined with point of care ultrasound, especially patients with acute heart failure. So congestive cardiac failure patients, if they were serially examined, what they found is they have received increased doses of diuretics and they have been better. So again, this is similarly, this is a meta-analysis. They have included 7 RCTs and 6 observation studies into a total of 5,393 patients. Here also, patients presenting with acute dyspnea, the point of care ultrasound here, it has significantly decreased the time to diagnosis, time to treatment, and higher rate of receiving appropriate treatment, decreased stay in ICU. But the difference in mortality is not significant here. So now coming to the deep vein thrombosis. So for diagnosing deep vein thrombosis, the probe we'll need is the high frequency or linear probe. So the patient's leg is positioned in this way, flexed and abducted. Normally what we see with veins in ultrasound machine is, here you can see this is the femoral artery and this is the femoral vein. As we compress the thigh, the femoral veins get completely collapsed and you are able to augment the pulsatility of the femoral artery. This is normally seen. But what we see in DVTs is, here you can see a floating thrombus here inside the vein. And again here you can see, as we try to compress this thigh, this is the artery which is giving pulsations. Even the artery is getting compressed, whereas the vein is not compressed. So the non-compressible vein is also a sign of DVT. Next, color flow Doppler. You can see a thrombus is sitting here inside the vessel. This is the artery which is giving a pulsatile flow, and the vein which is not giving a very good flow. The color flow is definitely decreased, and color flow is absent in this part where there is a thrombus present. So for examination of DVT, for the purpose of simplification, so ideally the whole leg has to be examined to rule out the DVT for 100%. But for simplification, there are 2 methods of examination. But first is a 2-point examination, next is 3-point examination. In case of 2-point examination, the probe is put only in 2 places. One is 1 centimeter above and below the saphenofemoral junction. That is where the saphenous vein joins your common femoral vein, just above and below that part. And at the popliteal vein, just trace it below the knee till the tributaries join them. At the 2 places, if you see, and if you rule out any DVT present, you can rule out any major DVTs. The 3-point examination, in addition to these 2 areas, we are supposed to measure it 1 centimeter above and below the common vein formation. That is the superficial and deep vein, femoral vein joins to form the common femoral vein. So just at the junction, 1 centimeter above and below also, if we examine, that is the 3-point examination. So these examinations are simple to do by the bedside, but these are not 100% specific or sensitive. So coming to the echo. So echo basically we have 4 main weaves. So the parasternal long axis, parasternal short axis, the apical 4-chamber, 5-chamber, and the subxiphoid weave. So first is the parasternal long axis weave. Here the probe, you have the phased array probe. The probe is kept at the 4th intercostal space with the probe marker. This is the probe marker what you have here. Okay. This is oriented towards your right shoulder. So once you keep the probe here, the image what you see is like this. You will see this is the left ventricle, this is the left atrium. What you see here is the mitral valve, this is the aortic valve, and the left ventricular outflow tract is here, and this is the right ventricle. So with this view, we will be able to appreciate the aortic diameter. So whether there is an increase in size of the aortic diameter, the left atrium size, and the a preliminary measure of left ventricular contractility can also be done in this view by measuring the left ventricular diameter during systole and diastole, and fractional shortening can be calculated. Fractional shortening is basically calculated by subtracting the systolic minus subtracting the systolic diameter from the diastolic diameter and dividing it by the diastolic diameter. Next is the parasternal short axis view. Here the probe is kept in the same position, 4th intercostal space, and the probe is rotated 90 degree so that the probe marker, which was initially in the pointing towards the right shoulder, has moved to the left shoulder. We have rotated it 90 degree. With this, there are basically 3 weaves. The first view you will see will be the mitral valve view. You can see this is the mitral valve which is opening and closing here, and the LV contractility can also be seen here. This is the right ventricle. So you can see the mitral valve opening and closing. With this we can calculate the area of mitral valve here. So this is the papillary muscles we can see here. This is at the level of papillary muscles. With this we can calculate the fractional area change. Freeze the image at this point and measure the area of the left ventricle along the endocardium during systole and diastole, and we will get the fractional area change. This is at the level of aortic valve. So how do we get these images? Just sliding the probe towards the apex, we see here, and just tilting the probe towards the right shoulder, we will get this image. Here you can see what we see in the center. This is the aortic valve. This is called the Mercedes-Benz sign here, because the tricuspid valve we can see. If it is absent, then it is most probably a bicuspid valve. This is the right atrium, this is the left atrium, the intra-atrial septum is here, this is the tricuspid valve and the right ventricle, this is the right ventricular outflow tract here. Next, coming to the apical 4-chamber view. Here the probe is kept, by 2 methods you can keep the probe here. One is just trace from the parasternal short axis, you will get a view. Just trace the heart along the border and you will arrive at the apex, or you can feel for the apical impulse and then keep your probe there with the probe marker towards 3 o'clock position. You are supposed to get an elliptical view of the left ventricle. Then only you can see you can measure an adequate LV contractility, LV ejection fraction. So you can see the 4 chambers here, LA, RA, LV, RV. You can see the valves are fully opening and closing. So with eyeballing, so the LV contractility ejection fraction can be measured by eyeballing as well as by accurate calculations. So what eyeballing means is, just see all the walls of the left ventricle. If everything is approximating or coming towards the center during systole, then as long as the eyeballing is concerned, this patient has got an adequate LV contractility. With the same position, you just tilt the echo probe with the tail moving downward. You will get a apical 5-chamber view. So apart from these 4 chambers, you will get the left ventricular outflow tract here. You see the aortic valve here. So what is the use of this view is, if you place the Doppler image and keep the Doppler gate here, from here it will come. So you will be able to measure the left ventricular outflow tract, velocity time integral, from which you can calculate the stroke volume and cardiac output. This is definitely useful for a hemodynamic assessment of patients. Next is the subxiphoid view. Subxiphoid view is the probe is kept in the subxiphoid region with the probe marker oriented towards the right side. You can see the 4 chambers here. This is the easiest of all the views. In case of patients who are obese or if there is a subcutaneous emphysema or you are not able to get a good window of the echo image, this is the easiest to do. So this point of care ultrasound regarding echocardiogram for cardiac ultrasound. So for diagnosing the type of shock, what they found out in this study is it has got a pooled sensitivity of 80% for each type of shock. That is for either it is obstructive or cardiogenic or distributive, whatever the type of shock may be. The sensitivity is around 80% and it is more than 90% specific. So next is eFast. With eFast, you can use 2 types of probe. A phased array can be used or a curvilinear can be used. Both are actually a low frequency probe, so you can see deeper images. So the views basically are the right upper quadrant, left upper quadrant, subxiphoid and the pelvic view. In eFast, they have extended it to involve the anterior chest for the lungs. You can see here the right upper quadrant. The right upper quadrant, you're supposed to place the probe in the mid-axillary line at the 10th intercostal space in the right side. So the probe marker should be oriented cranially. What you see is the liver and the kidney and the Morrison's pouch, which is the liver and kidney are approximating close to each other. So there is no fluid in the Morrison's pouch. Once fluid collects, the liver and kidney will be separated like this. And you can see the diaphragm here and the lung here. If there is any fluid which gets collected in the pleural space, you will be able to see the fluid here. So this is the left upper quadrant. The probe is placed in the left upper quadrant, that is in the posterior axillary line, because here to visualize the spleen is situated more posteriorly, so you need to go to the posterior axillary line at the 8th intercostal space with the probe marker oriented cranially. So here also what you see is the spleen here and the kidney here. There is no fluid here, and here you can see fluid. So compared to the hepatorenal pouch or Morrison's pouch, here the fluid usually collects around the spleen, not between the spleen and the kidney usually. This is the pelvic view. The probe is kept in the pelvic view. Both longitudinal and the transverse sections can be seen. So this is the longitudinal view. The bladder, prostate is seen, and this is the bladder. Uterus is seen for female patients. So once fluid gets collected, you can see hypoechoic regions will be seen. This is the normal image actually. This is a subxiphoid view. This is mainly used for diagnosing any pericardial effusion if it is present. So in case of pericardial effusion, what you see is, if it is significant enough, there should be at least one chamber change in one chamber dimension. There should be a collapse of at least one chamber, either the atrium. Usually the atriums are the first one to get collapsed. Or the maximum thickness of pericardial effusion should be at least more than 2 centimeters. Next is the fluid responsiveness by POCUS. So how do you measure fluid responsiveness? So initially fluid responsiveness was measured by giving fluid challenges, but they were found to be harmful that we increase the organ congestion in that way. So nowadays we are using IVC assessment by ultrasound and LVOT. These are the 2 commonly used measures for assessing fluid responsiveness. First is IVC. So for measuring the inferior vena cava diameter, we place the probe in the subxiphoid region and measure the IVC diameter at 2 centimeters from the junction of IVC with the right atrium. So you can see here, these are the values of IVC diameter and the collapsibility and the respective CVP here. But what they found out was, in spontaneously breathing patients, their depth of respiration varies. Some patients will have deep inspiration, some patients may not have deep inspiration. So depending on the change in intrathoracic pressure they produce, the collapsibility of IVC varies in each patient. So to standardize that, now they have restricted their recommendation to use IVC variation only in mechanically ventilated patients with a tidal volume of at least 8 ml per kg. So here the diameter is measured during the maximum and the minimum diameter is measured. Compared to spontaneously breathing patients who are mechanically ventilated, they'll have the IVC collapsibility only during during expiration. So if the distensibility index, if it is more than 18%, that predicts volume responsiveness in those patients. Even in these patients, if the tidal volume is kept low, or if there is any valvular pathology, or if there is any spontaneous breathing effort present in the patient, or the lungs are hyperinflated, you can get false values. And more specific one is LVOT, VTI, and this is the left ventricular outflow tract velocity time integral. So here also, this is also very similar to your IVC assessment. Here also the patient should be completely paralyzed and mechanically ventilated with a tidal volume of at least more than 8 ml per kg to get a good specific and sensitive result. You can see here we got a 5-chamber weave here, both the left atrium, right atrium, left ventricle, right ventricle. This is the left ventricular outflow tract and the aortic valve. The Doppler gate is kept in the left ventricular outflow tract. Before keeping the Doppler gate, place the color Doppler to see if you get a good image of the blood flow here, the blue color, because the blood is flowing away from this area, so you'll get a blue color in the left ventricular outflow tract. If you place the gate here, you can see here the negative deflection Doppler waves can be seen, and the Doppler wave is traced to measure the velocity time integral. So if the VTI, if more than 10%, that is this VTI change is measured. So during inspiration, your velocity time integral will increase, and during expiration it will decrease. This is because of the difference in the blood flow during venous sorry, this is because of the difference in the venous return during inspiration and expiration. You will get a difference in Doppler waveform during inspiration and expiration in case of patients who are fluid responsive. So if the variation is more than 10%, then the patient is supposed to be fluid responsive. So we know we have been measuring fluid responsiveness with IVC measurements. So what if the patient's IVC is more than 2 centimeters and there is no variability? We know that the patient is definitely not fluid depleted. So should we diurese the patient or not? So the recent thing in ultrasound, point of care ultrasound in critical care is VEXUS. VEXUS is venous excess by ultrasound. So what is the purpose of this? The purpose of this VEXUS is to see whether there is any real organ congestion. In spite of the full IVC, your organs could be congested or non-congested, especially in patients with right heart failure. Your IVC tend to be dilated. It will be usually be more than 2 centimeters, your IVC will be, and collapsibility will also be not there because the right heart is failed, right atrium is dilated, right atrial pressures are high, CVP is high, so the IVC will also be completely dilated. So there won't be any collapsibility, IVC will be distended. So whether these patients have an organ congestion, or should we diurese the patient or continue with the fluid maintenance at least? So to answer these questions, they have devised this VEXUS protocol. So what do they do in VEXUS is, it's a 4-step protocol to assess the severity of congestion here. So first is your IVC is measured. If the IVC is less than 2 centimeter, you know there is no organ congestion. So we can stop the VEXUS protocol there itself and go ahead with the fluid administration. No need for diuresis. So if the IVC is more than 2 centimeter, then we'll go to step 2. Step 2 is placing the hepatic vein Doppler. That is, place the ultrasound probe in the right hypochondrium and place your Doppler gate in the hepatic veins. Basically 3 hepatic veins are there, right, middle and left. The middle and right is easy to measure, whereas the left is obscured by your stomach gas. So you place the Doppler gate in the hepatic veins. You can see these are the Doppler waveforms here. You will get a negative waveform here because the blood is flowing towards the IVC here. The hepatic vein usually drains into the IVC, so you will get a negative Doppler waveform here because it is flowing away from your probe. So during systole there is a deeper deflection followed by a diastolic deflection and a positive deflection. This is seen normally. So here a score of 1 is given. And in case of mild congestion, what you see here is systolic waveform decreases in amplitude. The negative deflection decreases, and with the increase in severity, the systolic becomes completely positive. There is no systolic flow, venous flow in case of severe organ congestion. The same happens in all 3 organs. So next we will proceed to the portal vein. So for getting the portal vein also, we need to place the probe in the right hypochondrium. And once we place a color Doppler, you will be able to see blood flowing towards your probe. That is, red color vessels will be seen. And when you place the Doppler here, you can see there are no waveforms. There is uniform flow. This is normally seen. Once the waveform appears, this is mild congestion. When sharp deflections are seen, this is severe congestion. Similarly, in renal vein, it is very difficult to differentiate between your interlobar renal veins and renal arteries. Once you place a color Doppler, both veins and arteries will be overlapping. So when you place a Doppler gate in that area, what you see here, arterial waveform will also be seen and venous waveforms will also. What you see in the negative deflection is the venous waveform. So we need to concentrate only on this thing. So once there is mild congestion, there is almost uniform flow here. Only during systole there is a mild increase in the flow. What happens is there is an intermittent flow. Once there is mild congestion, it becomes an intermittent flow, and with severe congestion, your systolic flow stops. So based on these things, the severity of congestion is measured in all 3 organs. The grading system is, if the IVC is less than 2 cm, it is grade 0. You know the Vexus score is 0. You can go ahead with the fluid administration in those patients and no need for diuresis. If it is grade 1, the IVC is more than 2 and a combo of normal or mild congestion, it is grade 2 when it is more than 2 cm and there is 1 severe congestion, that is 1 organ shows severe congestion. It is grade 3 if the IVC is more than 2 cm and severe congestion is present in at least 2 organs. So what they found out is grade 3, it actually correlates very well with severe acute kidney injuries. So once you get grade 3, you can go ahead with aggressive diuresis in these patients, and that is proven to be beneficial in recovering acute kidney injury patients. So this is various protocols which are used by the bedside in patients with shock and dyspnea. This is the false protocol. That is fluid administration limited by lung sonogram. So lung ultrasound and cardiac ultrasound are measured in a stepwise pattern to rule out causes of the shock and to limit fluid administration by ruling out any pulmonary edema or volume overload. So first here is a simple cardiac ultrasound is done first to rule out obstructive shock. That will rule out any right ventricular dilatation that could be because of the pulmonary thromboembolism, or pericardial tamponade can also be ruled out. Next is ruling out cardiogenic shock. The blue protocol is done to rule out pneumothorax. Next, coming to blue protocol, if there is any pulmonary edema, we know it is cardiogenic shock. Then fluid administration is given and look for again lungs if there is any signs of fluid overload. If it is not fluid overload, we can continue with the fluid resuscitation. And if the fluid resuscitation does not improve BP, we know it is because of septic shock. And further fluid resuscitation is going to end up the patient with the B profile in the lung. This is your rush protocol. Basically, the capacitance vessels and the chambers in the body is divided into pump, tank, and pipes. Pumps are basically your heart and the chambers. The tank is basically your major vessels and third spaces. The pipes are the vessels here. So it's a stepwise examination of all areas to rule out the causes of shock here. Next is the blue protocol. The blue protocol is again the bedside lung ultrasound in emergency. They have devised a protocol where there is a stepwise examination to rule out all the causes of hypoxia. When you follow this, this has got a sensitivity of more than 90%. We can rule out all causes of dyspnea. So this is the trial which is ongoing. So VEXUS guided management in patients with septic shock after resuscitation phase, that is post resuscitation. We know the patient's volume is going to be filled up. So do we need to further resuscitate the patient or maintain the patient with fluid or to start diuresis? So decide on that. They have devised this VEXUS guided fluid management. So the trial is ongoing. So this is published in CHEST. You can see the prospective evaluation of venous excess ultrasound, that is VEXUS for estimation of venous congestion. What they found out was 81 patients who had a VEXUS grade of 2 and 3, that is at least one organ was severely congested. They closely correlated with the increased right atrial pressure and the mean pulmonary arterial pressure. So now the point of care ultrasound is not anymore restricted to the critical care physicians or the emergency physicians. It has expanded into other broader specialties, including, you can see here, orthopedic emergency diagnosis for identifying effusions, fractures and all. They have started using point of care ultrasound, and for gastrointestinal pathologies also they have started using ultrasound. So it is only time which will tell the answer that the point of care ultrasound is going to be used across all specialties, even in the ward side. So for the purpose of simplification, I have restricted my presentation to mainly cardiorespiratory part of POCUS. So now we know that POCUS, it has got many great advantages, like easy portability. It can be used in bedside in any part of the hospital. There is no radiation exposure, and images can be recorded and can be reproduced whenever it is needed. And it has got a comparatively steep learning curve compared to other modalities of diagnosis and intervention. At the same time, it has got its own limitations. Like, a POCUS device has got its own limitation. It cannot be compared to the conventional ultrasound machine, which has got a greater clarity and it can give better images. Also, the interventionist, the intensivist, whoever is doing the ultrasound, has also got his own limitations. You cannot replace a cardiologist performing a complete echo for diagnosing the regional wall motion abnormalities. So we need to know those limitations. Always, a POCUS examination is advantageous when it is accompanied by proper clinical examination. Thank you.
Thank you, Dr. Bhajiran. That was a great talk. Now I would like to call Dr. Ramya Mule to felicitate Dr. Bhajiran, and I'm requesting chairperson to be on stage only for our next one. So artificial intelligence is the emerging concept in the critical care nowadays. So I would like to call Dr. Bharat Jigasi to talk about predictive analysis through artificial intelligence in critical care. Over to you, Dr. Bharat.
कसं काय अच्छा यहाँ पे नहीं वहाँ पे आना
Yeah, hi, good afternoon, everyone. So we are running late almost by 1 hour 15 minutes, and in the interest of time and hunger pranks, I have reviewed my slides and would like to cover up the time and finish as early as possible. I know the lunch has been waiting and even I am hungry. So welcome to the world of artificial intelligence. And as the introduction was, it's an emerging trend in the critical care. I would rather say it's already emerged and we are living with it, and we also been practicing without realizing that this is an artificial intelligence what we are doing as of now. So in this presentation, we'll delve into the various varieties, and we'll see what exactly the terminologies and concept of artificial intelligence is, and what all we can do, and we'll just uncover the journey how the artificial intelligence works. So be prepared to be amazed by the power of artificial intelligence, and in the end of it, we would like to clear it out. It's not, we shouldn't be worried about it. We should be happy. Is there to help us out, not to replace us. So when it comes to the next point, what exactly the artificial intelligence means. So artificial intelligence is actually a simulation of human intelligence by the machines that are programmed to think and learn like humans. So what we do is we simulate the machines, we make the machines learn and make them think or train them think as we all do. So it's all dependent on us how we train them and what all we do for them. So it encompasses various technologies and various terminologies. So what most common is the machine learning, deep learning, natural language processing, and the computer vision. So these are the different varieties how we train the machine, and depending on these kind of trainings, it also the output is also dependent. So output could be in the form of looking predictive value, or coming out with the idea what is to be done. Different kind of analysis could be seen, and this is how the artificial intelligence is helpful in the varied environment. It could be the healthcare, finance, and transportation, and more. So let's look into the machine learning, what exactly the machine learning does. So machine learning is the backbone of the AI. So whenever we talk of AI, when I was trained in AI, the main thing was about the language and also the machine learning. So machine learning is a key component, is a backbone, and it's actually, this is the way we make the machine learn. So this could be the other varied types. Is the supervised machine learning, unsupervised machine learning, or reinforcement of the machine learning. So it can recognize the patterns, can make predictions, and also make the automated decision. That is a reinforcement according to the inputs what we are given to the machine. So natural language processing is another type of the learning, that is communicating with the machines, how we communicate with the machines. So it enables to understand and interpret and interact with the human language, and it also analyzes the text and speech. When whatever text has been given, what is the speech, like as we've been using in these days, Alexa, Siri, those are the kind of the artificial intelligence. So they analyze the language, they analyze the inputs, and according to the output is being given. So it enables a task, it analyzes your sentiments as well. If it's an advanced one, so it gives the emotional output as well. So by processing vast amount of textual data, and the machine learning, machine language processing empowers to comprehend and generate human feelings and human language, and it could also communicate in a better way. So what bot we've been using in the many of the websites or on the banks, so those are actually the natural language processing. So whenever there's an input, they will come out with an output. So they also understand your language, whether you're very aggressive, whether you're emotionally down, and accordingly the output is. So deep learning is a subset of the machine learning, and that utilizes neural networks. So this is very important. So apart from the machine learning, what is more important in the artificial intelligence is about the neural networks. So how we create the neural networks. So this is lots of data has been implicated. So there's something called as datanomics. These days we also conduct the datathons. So lots of information is being fed, and according to that information, the machine itself develops a neural networks, whatever the machine you have given, and it analyzes depending on the data, and it comes out with the output. So there is something called as neural network, which is also very important, and these neural networks are actually what we are talking the artificial intelligence. So they come out with the output. Computer vision is another important. This is also we've been practicing in a vehicle. So we all have those 360-degree visions. So this is what the output is. So by analyzing images and videos, the output has been given. So moment we are very close to the wall, whenever we're taking a reverse, it will give you the alarm. Moment we are very close, the alarm will change. Same is if there's some sensor is on, ADAS is on, so we go in the straight line. So they analyzes as per the images and as per the programming. So this is what we've been practicing, and this is what the different terminology is all, and this is how we could be used in artificial intelligence. So as I told you, is there, we already been practicing, is there in everyday life. Now we'll come into the critical care, how it works in the critical care, because importance in the critical care is the decision making and timely decision making. So sometimes we realize it's late. I mean, I realize something is gone with the patient when there's already in hypotension. So can artificial intelligence be fit in and it tells us, yeah, this patient is due for the hypotension, this patient is due for the renal failure, this, I mean, for the output to go down, that means there's an emerging renal failure coming in. This is going to help us so that our decisions are preemptive and we intake. So this is what the role of AI is in the critical care, helping the clinicians to make better and more personalized decision rather than to wait for the science to come in. So it helps us before the science and boosting workflow and reducing the healthcare expenditures as well, because there will be reduced costs. So how it works is there's a pre-game changer funding, which that's a basic research. The research is to the feasibility. We realize, yeah, this research is going to work, and then there's a technology development and demonstration of the technology, and the system comes in and the system is launched and operates. So this is how artificial intelligence works. So I'm taking one simple example to make you understand what all spoke about machine learning, deep learning, natural language processing, vision compatibility. So we'll look into the sepsis. Why I've taken, because a common disease and it's one of the most common cause of the mortality in the ICU. And it has a varied and best treatment strategy remains uncertain. So this is what the treatment of the sepsis could be: fluids, vasopressors, enteral feeding, insulin, deep sedation. So we exactly don't know what exactly work in this scenario when the patient is already in a shock. Even though we have treated the infection, but the syndromic approach has syndrome has already been taken place, and syndromic approach in these patients will take in. So what we'll do is, what machine does is we feed all these kinds of data in the machine. So what was the age, what was the sex, what was the height of the patient, weight of the patient. So whatever is available with you, you just feed it to the machine without realizing machine is going to have its own neural network and take it. So suppose there was an unsupervised version. There was a supervised version. So I have also told the machine this patient was in sepsis and this patient was septic shock. So machine will build a model which will be a predictive model, and according to the predictive model, because as we have fed in, that is called a supervised technique, machine will realize, yeah, this is a sepsis, and it will tell you, yeah, this is a sepsis. For example, this has been studied, so I've taken this into account. So this is a supervised version. So this was the X-ray which had the pacemaker, and pacemaker was put up in the box, and machine was told this is a pacemaker. So we put up varied X-rays across it. So there were 113 such X-rays which are put across it. So you can see pacemakers are at the different areas. And machine was always told this is a pacemaker, this is a pacemaker, this is a pacemaker. So type A, type C, different kind of machines came. So eventually there is a validation which happens, and there was 94% accuracy was achieved. So whenever this X-rays goes in, machine will tell you, yeah, there was a pacemaker inside. So same is true with the sepsis. So it has to predict the outcomes, it has to predict the mortality, length of stay, then deterioration, cardiac arrest, whether the AKI is going to come in. So those are the various parameters what we fit in, and according to it tells us, okay, yeah, this is going to be a septic model. Now it comes to the unsupervised learning. So what is unsupervised learning? It's a discovery subclass where I haven't fed the data. I have just fed the data. In the end, patient's outcome came in. So group is unsorted and information is given on the pattern. So machine generates a pattern, and on the base of pattern, so there's a data without labels, unsupervised learning, and output is being seen. So these are the different variant of the patients which have been fed. So machine will divide, this was phenotype 1, this was phenotype 2, this patient did well, this patient did not do well in certain condition, and as per the modeling, it will tell you this is a phenotype 1 and phenotype 2. So this will not tell you about the disease, but it will tell about the phenotype of the patient, which could be helpful in the response to the disease. So you would know, yeah, this is a phenotype patient, this might respond differently to the same kind of a disease as compared to the other patient. Same is true with the ARDS, and same is also true with the hypertensive. So phenotypes are coming in a big way because this is an advantage of the machine learning, because it cannot be identified with the one category of the patient, with the one set of the patient, requires a different lots of data to define define what phenotype patient belongs to, and machine learning is helping us, and that will also help us to judge the response of the treatment or the patient's behavior in the particular disease. Reinforcement learning is something different. Reinforcement learning is we provide the learning to the machine. A virtual agent is trained to learn an optimal set of rules. So I will tell the machine, if the septic patients came in, I have to give a fluid bolus, I have to give an antibiotic, I have to do procalcitonin. If procalcitonin is more than this, this is what the value is. If less than this, I have to stop. So we have to have some certain set of rules, and medical decision is actually what we take as a reinforcement. So what we actually practice is, state is a patient condition, physician intervenes, and reward would be the mortality benefit, and it all revolves around the patient. So there's a decision A which was taken in certain patient, there was decision B taken in certain patient, decision C. So what machine will tell you for this respective patient, maybe the decision B will work, and decision B is the best decision and is the optimal decision. So this is what is going to help us in the varied scenario. It could be the unsupervised way, supervised way, or the reinforcement technique. So optimizing fluid and vasopressors, optimizing sedation in certain cases, maybe the mechanical ventilation, heparin dosing and insulin, this is all machine will tell you how does it work. So software for decision support is a medical device. This is what we are looking into. And AI powered clinical decision will of course improve the outcome, will improve the length of stay and also the mortality across the areas. But there are ethical considerations. As I told you, we are feeding the data. So data needs to be very much refined. If I feed a biased data, you will get the biased outcome. So this is where the ethical consideration is very much important in these sets of scenario. So the future is physician plus engineers plus machine. It's going to help us. It's not, doctors won't be replaced by the artificial intelligence. We are going to work in tandem along with the engineers and the machines, and they are going to help us in coming out with a diagnosis and improve our patient's outcome. So collaboration between healthcare workers and AI is what is we are looking at the future. It will optimize the care and also the treatment, and the road ahead is to the inner workings of the AI. AI is not just a technology, it's a catalyst for the innovation and progress, and by embracing AI responsibly, we can shape a future where machine and human can collaborate and work responsibly for the benefit of the patient. So in conclusion, we need not be worried about the AI, we should be happy it's there to help us out and to work along with us to have the brighter future ahead, so that our work hours goes down, our work-life balance is better, and even the patient outcome is good. Thank you very much. Thank you very much.
Definitely covered up on a lot of time, and we can hurry up for lunch. For our generation, I think we are daily amazed by what AI is doing for us, and you showed us one more aspect of what AI can be used and how it can be used in critical care. We didn't know this.
Yeah, we already been using it. There have been many sonography machines, and whatever we do, it's quite a lot of AI. Even the cars, as I said, it's just we have to realize this is AI and this is helping us. This is not going to replace us. Yeah. Thank you very much.
Thank you, Bharat sir, for such a great talk. I would like to call Dr. Akshay to participate as well. Now I'm requesting everybody to take a break and join us for a lunch.
Mic is not working. Mic is not working.
Critical Care Medicine, Hyderabad Apollo, will make the situation easy for us by talking about how to deal with the ethical dilemmas in end-of-life care. And to moderate the session, I would like to call Dr. Ajay Kukreja, Dr. Saurabh Kothari, and Dr. Nilesh Bantiya. Over to you, sir.
I think many of us know Dr. K. Deepak. He is a senior consultant and a professor of general medicine at Apollo Health City, Hyderabad. We can start the session.
Respected chairpersons, thank you for the introduction. And dear organizing team, Akshay sir, Gunadhar sir, Bagul bhai, Shodip, thank you for the opportunity, and the special thanks for keeping my session immediately post lunch, and especially the topic on end of life. Thank you, Akshay sir. Okay. So I will not make it much more complicated. I'll just go through 7 or 8 stories which we commonly face in our general ICU journey, and I'll try to see how we need to solve it with an evidence, maybe with a legal background in the India especially. And at the end of the day, maybe we'll have 2 or 3 take-home messages. How much is my time? 30 minutes is. So I promise to complete in 25 minutes. You can stop it at 25 minutes. I'll just go through a real story. So this is my story. My mother, who was an IAS officer at that time, so in fact I diagnosed her as having a PSP. You all know primary supranuclear palsy doesn't have a definitive treatment. She was a well-known poet at that time, also as a lawyer. Unfortunately, she rapidly deteriorated, and it was a quite emotional moment for me. Ultimately, I think we had to sign a DNR with a hospital team, even though I'm in hospital personnel, but I need to do the proceedings. At that time, my mother, she was my patient as well. She was the one who actually reassured me rather than I reassuring herself. Okay. So the reason I kept it in the first place, this scenario is these emotions, guilt, helplessness, your frustration, fear, you cannot quantify these things. Okay, you may have an Apache score, you may have a SOFA score, or maybe the recipe scores in the morning, what Niranjan was telling, but these qualitative aspects you can never quantify. So you need to understand that your patient or your caregivers, the families of your patients are undergoing through these emotions. So whenever you are trying to judge them or making a fun of them in the coffee rooms, so try to remember that they are the persons who are suffering through this. So once you actually experience these things, the way you look at the things will be different. Okay. So just imagine this, all of you. Imagine yourself as a patient, you're confined in an unknown place without any knowledge of what persons who are being taken care of. You cannot see them, you cannot talk to them, you have something in your mouth, some plastic tube, you're being poked with the needles, they're taking daily blood from you. And you know that you have an end-of-life situation where you cannot get out of also, okay? And you can't see your wife, you can't see your son or daughter. So what is this place? Any one of you? So there are 2 places which can be in the similar way. One is a prison and second one is an intensive care unit. So remember that for a naive patient, may not be a well-educated patient, both of them will be same, especially when you have an end-of-life care situation. So whenever you're trying to understand their situation, you need to understand from that standpoint of view. Okay. So unless until you have that empathy, you cannot take care of the situations. So what is a good death? Do you have something you all plan, right? I'm sure that you plan your baby's birth in a boutique, like baths and all of it, isn't it? So can you plan a death as well? Are you supposed? How many of you have seen this movie? Hands up, Patch Adams. Anyone? You identify this actor, Robin Williams, right? He's one of the most famous actors. I urge you to see this movie, Patch Adams, one of the most, close movie to my heart. Okay. In that one, in the end, he will say this. Okay. Why can't we treat the death as the same way as the birth as well? Okay. Maybe with an amount of humor as well. There's nothing wrong with it, isn't it? So you have a good death as well. You need to plan your death. Unfortunately, many people cannot get it. Maybe you have a trauma, you don't know, you can't plan it. As long as you have that situation in your hand, you need to plan that as well. And when someone is planning it methodically, you need to appreciate their level of understanding and maturity. So what is good death? So these are various components of good death. Effective communication. you need to be at your place of comfort. Okay, for example, you may be admitted in a high 5-star corporate hospital. That may not make a difference for your 80-year-old grandmother. She need to be with her grandkids, maybe see them when she's in the last stages of the life. At the same time, she should, I'm like, just because she's uneducated, you should not neglect her autonomy. And when you very clearly know that there's no point in prolonging her life with the unnecessary suffering, you cannot prolong the quality of the life, you should not do that, okay? And she should be able to meet her family and the friends as she requires. And ultimately, she should have the right to terminate her life at this point of time, at any point, especially when there is no prognosis. And remember that this is different from a euthanasia. There's a very common mistake people do it, and in fact that is being done in the legal aspect also. So euthanasia is a different one. It's a very bad term actually. Just like a medical futility, which is a very disappointing term. So you need to remember that euthanasia, physician-assisted suicide and medical assistance in a death are illegal in India. Okay, but that doesn't make everything impossible. So remember this in a first story, 5 minutes or over. So first story, 50-year-old gentleman, emergency for hollow viscous perforation, initial improvement but extensive bowel gangrene. And after 2 weeks, he continues to be comatose, very high vasopressor requirement and continuous renal replacement therapy. Is this a hopeless situation? We all know that is a hopeless situation, isn't it? Best way to assess the hopeless situation is just ask yourself, what is your gut feeling? Okay, and the family obviously is anguished. Repeated counseling, we have been telling them the bad prognosis, they understood it, but unfortunately they are on the verge of the financial collapse as well. So as a treating consultant, what would be your step? Which step would you do? You don't want to take the responsibility, ask them to sign the LAMA and go to a smaller setup? Do you want to do? Many of us do it, right? Second point, you in the night, middle of the night, you will tell your junior to stop the narrate, maybe convert into a normal saline. Would you do that? Or do you want to don't want to take any chance, complete support till the end, till the ultimate occurs? Or do you want to have a consensus with the family and the other treating teams and slowly de-escalate in a proper fashion? What is your option? D. So very correct. Okay. So the whole point is understanding this. But unfortunately in this scenario, like every regular scenarios, this patient was told that it's illegal in the Indian scenario to remove the support, which we have also, in fact I also told many of the times, hospital doesn't allow it and you need to take them LAMA. Where do they take? They can't take it now. Second point is you need to understand that they'll be very confused on the way if something happens to their father, lifelong guilt will be there, okay? And then in that emotion, they started quarreling with the hospital team, they started blaming the treating team. At this point of time, second opinion from a senior was sought who's experienced in the ethical aspects. So what did they do? They had a proper conversation this time, okay? This was an open conversation. You need to remember that communication in itself is a therapy. Just like your nutrition is a therapy, the proper communication allays your anxiety, it improves your overall well-being as well. So they spoken to them properly, they gave all the options. Then the most important thing is they asked the patient's relatives what would the patient would have wanted in this scenario, okay? Then once the detailed discussion was taken, then they sought the opinion of the other non-treating teams as well, so that there will be a neutrality. Then there was a documentation of the de-escalation, then gradually the de-escalation was done. Okay, so the family was so grateful because they need not see the patient suffering. They know that it's a hopeless situation. The finances, obviously there is no pointless collapse of it, and ultimately the situation was solved. Is it a better way of handling the things? So what is the principle applied here? You all know the basic principle. There are 4 principles: autonomy, beneficence, non-maleficence, and distributive justice. So in this one, except financial distress, which should never make you take the decision here, okay? Rest of all the autonomy, other principles of the ethics were applied here, okay? Every time when you face a conflict, you should apply all the 4 principles of the ethics. Coming to a brief thing, it's a pathetic state of end-of-life care in India. We are the least ranked among the 80 countries. And in fact, there's a huge alarming frequency of LAMAs, okay? What does that tell you? Even handicaps, both the handicaps tell the same thing. What does that tell you? It tells you the attitude of not wanting to take the responsibility, maybe because of lot of other factors, legal factors, government factors. So this come up to a proper definitions by the ICMR. I think no need to explain this, but only thing you need to understand, you should have a clear definition in your mind. You should not get confused with what is withholding and what is withdrawal, okay? And euthanasia is a completely different one. It's only approved in certain countries. So physician-assisted suicide, each of the these definitions are self-explanatory, but the proper definition makes you identify the proper situation of the patient. And this diagram basically tells you palliative care and end-of-life care is a continuum, okay? As you can see there, it starts simultaneously with the curative care, this care, okay? So it will not stop or it will not start later part. And end-of-life care is the continuum, and your job doesn't stop when the patient has expired. You need to continue with the bereavement support as well. So what are the main problems why we have a bad situation arising of end-of-life care is because most of us cannot recognize the dying process, okay? Maybe because of advanced technologies, you have an ECMO, after that you have some other therapies. So you don't want to accept the losing patient. At the same time, we are not trained in a proper medical ethics, and we have a lot of fear of law, okay? How many of you have gone to the courts? Okay. Akshay sir has the rank, first rank. So unfortunately, we also, it's a very bad experience. Unfortunately, no doctor should suffer it, the way they treat the doctors there. So it basically creates a kind of fear monger among us. And how many of us are properly trained in the communications? Hardly, right? We do communicate, but it's not a proper one. And obviously there's a fear of death as well. Once there's a fear of death, everything will go on a safe side, okay? So as we see, we can have various ethical dilemmas, whether to withhold or withdraw the medical intervention, or DNR status, DNI status, do not intubate status. Do we need to turn off the ICD, defibrillator at the end, because it keeps on giving recurrent shocks? How many of you, we all have seen that status, no? So people keep on giving that shocks from the defibrillator, they don't just die. And maybe ventilation, whether we can remove the ventilation already when the patient is kept in the ER. It's a very common dilemma we face. Withholding is always easy than the withdrawing, isn't it? Once the patient is put on an tube, to remove it is a different one. Whereas not to put is a much more simpler decision. And ultimately, disagreements, all of them happen. So there may be patient factors, physician factors, environmental factors. So coming to the second story, 88-year-old gentleman, very educated guy, repeated weaning failure, has been going in a different hospital. He came to you, he is already vexed. Okay, he kept on being disconnected, weaned again, being connected to the ventilator. And he had a end-stage heart failure. There is no prognosis, already metastatic malignancy. His very clear consciousness, he clearly written to you, sir, please remove my tracheostomy tube. Next time when I deteriorate, don't connect to the ventilator. What would you do? How many of you actually remove it and not connect? The brave guys. Yes, sir was there, sir was there. Okay, so there are various options, okay, just like the safer options and the daring options. The worst thing among thing is sending the patient on a llama, okay, that basically tells you you're ruthless and you don't want to take care of the patient or responsibility. And the other things. So the fourth one, as I told you, is proper following the principles of the ethics. Here what was done, initially obviously there's a worry of the legal liability, but it was allayed. There was a reasonable time which was another 4 weeks was spent on this person, because this is a new hospital, they want to try newer modes, Nava mode, all those XYZ modes, okay. Unfortunately the patient was insisting, he is much more clearer than the treating team. So ultimately there was a clear documentation following the ISCCM guidelines, okay. You will be going through it, and ultimately the removal, when the patient was deteriorating, the ventilator was not connected. And but not connecting doesn't mean that you're not taking care of the patient. You're taking care in the palliative aspect, okay. You're decreasing the air hunger with certain medicines, you're taking care of the secretions, you're making him as comfortable as possible. Ultimately the patient had a peaceful end, and the family was much more grateful because you didn't put them in the spot, okay. You were not a coward where you escaped from the situation. So we have, the ultimate point is withdrawal and withholding permissible in Indian law? Are you sure about this? It is permissible and you have a legal standing as well. So next time, don't worry about it. And you have various judgments which are supporting you, okay, right from the famous Aruna Shanbag, and there are other major judgments which will definitely help you. And both are same for all practical purposes. If you have any doubt about the withholding and withdrawing, remember that both are same, okay. You have various things which are hampering yours, like various policies. As I told you, this is a very bad thing. Like lama, the percentage of lama in Indian ICUs is hugely alarming. It's, I think, one of the worst in the almost all the nations with the proper ICU care. So foregoing of life support is also not common. It has been very well established in the European countries and abroad. So unfortunately, our data is sparse. So this is the next time when you face this situation, this is the pathway you need to see. Okay, what is the pathway? You need to first establish the decision-making capacity of the patient and status of terminal illness. Okay, once you do that, once you are satisfied as a treating team, then you need to involve a primary medical board. Primary medical board is from the in-hospital. Okay, whereas you can have a reasonable experience with people. Once they are satisfied, then you need to inform the family. Ultimately, secondary medical board is nominated by the magistrate. Okay, you can have a fixed empanel like your brain death patients. If all of them are safe, and the opinion should be given within 48 hours, the secondary medical board. Okay, once we do that, you can document it, give a copy to the magistrate, and safely you can do the needful. Okay, so next time please follow this process. So this is an Indian ICCM statement as well. We all know the end of life process. Each step is extremely important. So I think another question is, the good end of life communication should include all except. What is the one which is not correct? Anyone? With minimal discussion. Anywhere if you find those things, obviously we MCQs will know that will be the answer. Okay, so as I told you, basic principles of end of life communication, you should master it. Okay. The third scenario, young female returned from UK with a metastatic hematological malignancy, already brought in cardiac arrest to the ER. The husband is a highly educated person. He knows about DNAR. He has a very clear idea. But in there already ER they are resuscitated. Now he wants to ask about DNR. Do you practice? What do you do in this situation? Do you practice DNR? With a legal standing, not in a subtle way, back of the this one. So you can be very clear that DNR is allowed in the India. Okay, it's as long as you document correctly, as long as you follow it. Okay, so you have various guidelines to support it. There is a pathway where the simple summary of the pathway is you should be clear about the non-resolvability of the status. Like this patient should not come back, as well as the competency of the patient or the hierarchy of the surrogate decision maker should be very clear here. So how to document DNR? You have fixed formats, like AIMS has a fixed format, each institute has its own fixed format. But if you don't know, you can always document in your case sheet clearly also. Okay, who can sign? If you have a relatives, definitely they can sign, but if they don't have it, you can also document. Okay, but always try to involve a non-treating team senior doctor as well, just to preserve that neutrality. Okay, so now that we this negotiated till now, another bouncer you want, another 2, 3? So husband has asked DNR, but brother came suddenly from US. Okay, he wants to salvage it. Is it common or not? Yes. So what do you do with this treating doctor? The patient is before you. How many of you go ahead or not? I think I'm interviewing chairpersons more.
Brother is saying he wants to continue, we need to continue.
Yeah. So there are two things involved here. One is a shared decision maker. In the sense, always you should keep all the attendants together, try to get a consensus here. Okay, that is most important one. Second point which is important is hierarchy of the decision making. Yes, so you all have the Transplantation Act, no, 1994 Act. It clearly says that if you have a spouse decision comes as the first one. Okay, even if it may be a live-in girlfriend also. Okay, second one is the sons or daughters. in a serial order, the hierarchy, next parents, next siblings, and if they don't have, some other relatives. Whenever you have a conflict here, you should follow this hierarchy. Okay? So we all know about these ethics. Last two scenarios. Metastatic malignancy comes to the ER with shortness of breath in the night. ER guy, obviously they want to be on safe side and admit to the ICU, but patient insists that I already signed the documents, I want to be in the room. What do? Will you admit to ICU or room? Yeah. So as long as you are clear in the documentation, you are clear in your thought process, you can do that, because as we see in the initial place of dying is extremely important. They should be comfortable. There are a couple of indications where ICU's admission is important, where you can't control the symptoms. You need an excessive control, or maybe when you are planning for an organ donation. Apart from it, the first option is reasonably important. Last option, or maybe last but one, end-stage heart failure. She wants to go home. She is trying to quarrel with you. Again, you want to take a sign lama. Obviously, we know the first question I leaked the answer. You are not going to sign the lama. So quality of dying is extremely important. You should not leave the patient here. What you can do is you can try to arrange the same competent caregivers at the home. Home care helps you in this fashion. Maybe a smaller hospital with better visitation rights can help you at the maybe near their house. So should not leave the patient. Okay, everyone should go like this, not like the first jail prison. Okay, last scenario. So about the advanced medical directive. How many of you are familiar with the advanced medical directive? So have you written your advanced medical directive? You have written, yeah. You are much more advanced than us then. Okay, so it is much more popular and almost established in the abroad. Okay, so this is the situation where the patient is incompetent, but some family comes with a copy of AMD. First thing you should be aware of is AMD is approved and legal in the India. Okay, as long as it's followed. How do you do it? You do it with a witness, okay, with a judicial magistrate, and you'll be giving a copy both to the district magistrate there and maybe to your surrogate. As long as you have that valid document, obviously once you are not competent enough, that decision will be followed, should be followed. Okay. Second important point is, what is the other decision taken by you? You should have a slight liberal attitude towards the visitation rights. Okay, that goes a long way in solving many of the conflicts. As I told you, it's legal. This I think we already discussed. Legal aspect I will not be going ahead, but the recent summary by Mani sir and other team, they please go through that recent publication, I think last month or so. It was very well good summary, position statement. I think ISCM is taking the lead here along with the IAP and Indian Academy of Neurology. You have various position statements. So ultimately, you need to remember these things. Autonomy is the extremely important one. Okay. As long as you're competent enough, you should give respect to the adult patient. Withdrawal and withholding both are same, don't have any conflict. Whenever you face with the situation of removing the tube, you should not have a conflict, you're not doing anything wrong. Okay, you have a same legal standing. Most important thing is, don't think that lama is safe for you. You have seen the cases, no, that dengue case from Delhi, where even if you send the patient lama thinking that you're over smart, you can be cornered and you can be sued in the legal court. Okay, and active euthanasia is not lawful if you are thinking of doing extra good Samaritan work. And pain relief, symptom control, and the palliative care is the most important one. Okay, always try to be in the place and try to in the shoes of the caregivers. Try to understand them, and don't try to escape from these scenarios. Try to solve them. Talk to your seniors. Then you will be solving the next scenarios better. And always keep updated about the present law status. Okay, newer judgments and all. And when you have a conflict, follow always the 4 principles of your ethics. And sometimes the small drop of kindness, no, it goes a long way. And see this movie. I really urge you. Same movie, Patch Adams. Thank you. If you have any doubts, please. Don't tell me how many of you will remove the tube.
So really wonderful talk, Dr. Deepak. Thanks a lot. This is a topic that is should be there in majority of the national conferences, because it's something that many of us just ignore. So in MRCP, there are 5 stations, and out of them, 1 20-minute station is all about this. So it has a major role in foreign countries.
I request the chairpersons to please stay for the next talk also. Next is acute kidney injury is a commonly encountered condition in the ICU. And to deal with many methods for RRT are available. As intensivists, we should use them wisely. So to give more information about it, I would like to call Dr. Mona Lisa Mishra.
प्रेजेंटेशन पेन ड्राइव में है कहाँ पे ईमेल कर देते हैं सर Hendrix underscore NM NM ApolloHospitals.com.
Good afternoon, everyone. I really thank Dr. Akshay and the entire team of Apollo Navi Mumbai for having me. I'm Dr. Mona Lisa. I'm working as a consultant intensivist in Apollo Hospitals, Calcutta. And today I'll be talking about acute kidney injury in ICU, a very important topic. So basically, to define what is acute kidney injury, anything that is happening acutely is which is developing over a period of hours to days, resulting in decline in GFR and accumulation of some metabolic waste products is acute kidney injury. So the definition is the same. How do you exactly define it in terms of serum creatinine and urine output? If there is an increase in serum creatinine of 0.3 in less than 48 hours and serum creatinine of more than 1.5 times of baseline, which has occurred in prior 7 days, and in terms of urine output, if urine output is less than 0.5 ml per kg per hour for 6 hours, that's acute kidney injury according to the KDIGO definition. So in terms of staging of AKI, it has been divided into stage 1, 2 and 3, and in that you talk about serum creatinine and urine output. So if urine output has been less for more than 6 hours, then more than 12 hours, and now less than 0.3 ml per kg per hour for more than 24 hours, then it becomes stage 3 of AKI. And as we all know, as the staging increases, the morbidity and mortality of the patient increases. So there are some problems with this current definition of AKI. As we know, we are relying on the creatinine and urine output. So creatinine measurement actually can have a lot of pitfalls. For instance, a lot of drugs which we use in ICU that can actually interfere with the secretion of creatinine, and also which can reduce the production of creatinine. Also, obesity and other confounding factors can come in the way of measuring the creatinine values and thus misguiding us in diagnosing acute kidney injury. So to overcome this, now we have these biomarkers which have come into play, and we use these biomarkers sometimes to predict AKI, because the increase in biomarkers is actually faster than the increase in creatinine. So which are these biomarkers? I'll just tell you briefly. They can actually be divided into the biomarkers which are used for defining the glomerular filtration and tubular injury, or it could be the various mechanisms which are involved in AKI. So if it is glomerular filtration biomarker, which is cystatin C, which is commonly used. Similarly, injury biomarkers like NGAL, which is commonly used. So a little bit about them. Cystatin C is like a predictive biomarker, and it outperforms serum creatinine in emergency department, and it can actually predict AKI 24 to 48 hours before the serum creatinine actually rises. Similarly, you have IL-18 also. It's also predictive, and it is elevated within 12 hours of injury, and it's an early predictive marker of AKI after cardiac surgery. Similarly, we use NGAL also, which is diagnostic, predictive as well as prognostic, and it can predict AKI occurrence 72 hours before ICU admission. So these biomarkers are definitely more reliable as compared to serum creatinine and urine output, but definitely they are more costly, so we have to judiciously use them. We can also divide it in terms of what exactly they are going to depict. For instance, if there is decrease in GFR, it can be depicted by increase in cystatin C. Similarly, decreased tubular function by furosemide stress test and fractional excretion of sodium, and there are other injury markers as well. Now coming to different types of AKI. AKI can be pre-renal. Pre-renal could be because of hypovolemia, like for instance, it could be because of absolute volume loss secondary to any hemorrhage or GI loss, or it could be effective volume loss secondary to cirrhosis or sepsis. It could be also because of disordered autoregulation secondary to drug intake like NSAIDs and AC inhibitors and ARBs. So we have to be careful about the drugs the patient is on when the patient is in ICU. Similarly, there can be renal causes of AKI as well, for instance vasculitis and glomerulonephritis and all these things, and then post-renal AKI. So these are the various types of AKI one must be aware of when you are dealing with a patient of acute kidney injury in ICU. Recognized risk factors are these. So anybody who is an elderly individual, has a lot of comorbidities, had previous episodes of AKI, dementic, other comorbidities like heart failure, liver disease, has a higher chances of developing AKI. So what investigations will you send in a person who has AKI? So you can either send urea, electrolytes, creatinine, bicarbonate, full blood count, LDH. Everything actually has a significance. If you are suspecting hemolytic uremic syndrome, you send LDH. If you are suspecting hepatorenal syndrome, you send liver function test. Then if you are suspecting myeloma, send calcium phosphorus levels. Similarly, ultrasound scan if you are suspecting post-renal AKI. So all these initial investigations are useful in diagnosing the cause of AKI. So just a quick overview of the workup. So these are the basic tests which we usually do in patients of AKI. You send a full blood count with differential urine dipstick test, urine microscopy, renal ultrasound, and to whenever you're suspecting glomerulonephritis, you can send this panel. Whenever you're suspecting interstitial nephritis, you can check eosinophil count, eosinophiluria. Then abdominal compartment syndrome, you can actually measure the intravesical pressure. Then if you're suspecting TTP-HUS, you can actually look for fragmented RBCs, LDH. So this is a usual workup for AKI which we do in our patients depending upon the clinical suspicion. So quick interplay between AKI, acute kidney disease and CKD. So up to 7 days we can actually define according to the KDIGO criteria, stage 3, stage 2, stage 1, and between 7 to 90 days actually it becomes acute kidney disease, and if it progresses it becomes chronic kidney disease after 90 days. How do you prevent or treat it? So this, according to the KDIGO guidelines, you immediately, if you're suspecting AKI and the patient is already a high risk of AKI and not progressed yet to stage 1, you're supposed to discontinue all the nephrotoxic drugs. You have to ensure proper volume status. So hydrate your patient properly, give IV hydration, do functional hemodynamic monitoring. Patient might have underlying hypotension, patient might be hypovolumic. You have to correct the volume status of the patient, measure the serum creatinine level, urine output, avoid hyperglycemia because hyperglycemia is also nephrotoxic. So KDIGO guidelines says that you have to maintain serum glucose at a very tight control, and avoid radioactive agents unless it's a radio contrast agents unless it's a life-threatening emergency, and non-invasive diagnostic workup should be done. Consider invasive diagnostic workup as well when the stage 1 AKI is progressing to stage 2 AKI. Check for the changes in drug dosing. Sometimes we forget to modify your antibiotic doses according to the change in the renal function. So you have to modify your antibiotic doses as well. And if there is an urgent need of RRT, then we have to go for renal replacement therapy. So management of AKI, so if there is sepsis, then of course do the sepsis 6, and if there are any toxins, then try to avoid nephrotoxic drugs, optimize the volume status and the hemodynamic status of the patient, and prevent harm by treating complications and identify the cause of AKI and manage it. So basically identify all these risk factors which are present in your patient in an ICU. They might be on a lot of nephrotoxic drugs, older age, low GFR, diabetes, hypertension, cardiac failure, liver failure. All these are the risk factors of putting a patient in risk for clinical AKI, and there can be superadded infection and sepsis which might be contributing to AKI as well. So in this case, early identification of sepsis, treatment of sepsis, optimizing your volume status, remove all nephrotoxic drugs, optimize your blood pressure, maintain euvolumia, all this is extremely important, and that's how you prevent. And if you have complications of AKI, you have to manage accordingly. For instance, hyperkalemia, we all know the management of hyperkalemia, I'm not going to the detail of it, and then acidosis and all, then pulmonary edema, we have to manage the complications of AKI accordingly. What is the indications of renal replacement therapy in AKI? We all know this. If somebody is having fluid overload which is resistant to diuretics, hyperkalemia, severe metabolic acidosis, rapidly climbing urea creatinine, symptoms of uremia like encephalopathy, pericarditis, bleeding, nausea, all these are urgent indications of renal replacement therapy. Of course, if somebody is having a dialysable drug or toxin which is actually harming somebody, then we have to go for RRT. Now, when you're talking about RRT, I'll come to the next part of my topic, that what should we go for, SLED or CRRT. So first of all, we should know that around 40% of patients in ICU actually develop AKI, and they're in some sort of multi-organ dysfunction syndrome. And RRT is required oftenly for more than 50% of these kind of patients. And severe AKI requiring RRT actually is associated with high mortality and morbidity, and it actually increases the cost of the treatment, and of course it is increases the complexity of the illness as well. So clinical decision making regarding RRT is not very standardized. So when you talk about renal replacement therapy in ICU, first we should be aware of what is the mechanism of solute removal and what is the treatment duration. So depending on the mechanism of solute removal, we have three types of mechanisms. One is your diffusion, that is basically what dialysis is based on, and then convection, that is ultrafiltration. So I'll tell you the difference between the two. And then there is of course the combination of these two, that is convection plus diffusion. And depending on the treatment duration, of course, we have a short duration, that is your intermittent hemodialysis, then we have SLED, and then we have CRRT. Depending upon the duration of dialysis, we can choose the modality of RRT. So mechanism of solute removal, we all know there are three types of mechanisms we talk about when you're talking about solute removal by RRT. One is diffusion. Diffusion is nothing but when the solutes are moving from a higher concentration to a lower concentration area through a semi-permeable membrane. So this is a movement of solutes from higher to lower concentration area, and it can be of two types basically: ordinary diffusion and forced diffusion. Ordinary diffusion when there is random movement of the solutes, which is usually seen in peritoneal dialysis, and forced diffusion when there is external force that is actually applied, for instance in case of hemodialysis. So smaller weight molecules, actually it is very good for removing by diffusion, and the kind of mechanisms which actually diffusion is used by hemodialysis, by SLED, by CVVHD, and by peritoneal dialysis. These are predominantly diffusion based therapies. So then comes convection. So convection is when the solutes are moving with water. That is called usually solvent drag. So a process in which the solute is moving along with the movement of water between the two compartments in response to a pressure gradient without the change in concentration of the solute during the transfer. This is usually called as solvent drag. So this hemofiltration is actually based on this convention technique only. So the blood is pumped through the extracorporeal system, which incorporates a semi-permeable membrane, and the hydrostatic pressure is created on the blood side of the filter that drives the plasma water across the filter. It's actually useful for small and medium sized molecules, that is less than 50,000 Daltons. They are dragged along across the membrane with water. So the CVVH, CVVHDF, SLED hemofiltration, and SCUF are the convection based modalities which actually use hemofiltration, and the ultrafiltrate is then discarded and a replacement fluid is actually given so that the desired fluid balance is maintained. So these are the two main mechanisms we need to be aware of. And what is ultrafiltration? When there is movement of fluid between the compartments that is caused by pressure gradient, and ultrafiltration and convection both will involve movement of water across the membrane due to the pressure gradient. Ultrafiltration refers to the movement of plasma water, while the convection refers to the movement of the solutes with the plasma water. So, the other thing is a hemodiafiltration, which actually combines filtration and dialysis, and it has actually used the benefit of both the techniques and may be useful in clearance of small solutes. And then lastly comes SCUF, which is actually slow continuous ultrafiltration that removes only plasma water in patients without significant electrolytes and acid-base abnormalities. So when you want to remove only water and you're not concerned about any electrolyte abnormalities, you can use SCUF. So now the next part is based on the duration. So based on duration, you can have intermittent hemodialysis or you can have continuous hemodialysis. So continuous CRRT, either it can be CVVH, CVVHT, CVVHTF, or SCUF or PD, or it can be something hybrid in between also, which is SLED. So intermittent hemodialysis, we all know, obviously it uses a higher flow rate, and higher flow rate will lead to rapid fall in plasma osmolarity. It causes rapid correction of acidosis and electrolyte abnormalities, rapid correction of fluid overload. Everything is basically rapid. So your dialysable drugs are also removed rapidly. Anticoagulation exposure is also minimal. It is relatively inexpensive, and it is only suitable for patients if the patient is having a stable blood pressure, which most of your ICU patients will not have, right? So intermittent hemodialysis is good for an outpatient, it's good for an inpatient, and some of your ICU patients, but not many of them. And flexible timing is there, so it allows for mobility and transport of the patients. In acute setting, for acute correction of metabolic acidosis, hyperkalemia, fluid overload, and toxin removal, this is an excellent therapy. There is no doubt about it. If you come to CRRT, so you have CVVH, that is hemofiltration, there is hemodialysis, and there is hemodiafiltration also. So it is definitely more expensive. It requires a more continuous therapy as compared to intermittent therapy. It also requires continuous anticoagulation, so patient is exposed to a higher dose of anticoagulation. It is superior for patients with hemodynamic instability, sepsis patients, head injury patients, but larger RCTs which have compared these two therapies actually have not shown major differences in survival. So what are the advantages of it? It actually maintains hemodynamic stability. It is a 24-hour support. It actually removes your fluid and waste, and basically it requires teamwork between the CRRT nurses and the doctors, and elimination of septic mediators as well. So the advantages is that it obviously maintains hemodynamic stability, it prevents the surges in ICP, it helps in effective clearance of middle molecules, and it is useful in removal of immunomodulatory substances, and it permits adequate nutritional support also. It is better for a steady state if you want to achieve in most of the ICU patients. But intermittent hemodialysis is more practical, it is of less cost, and it can be done in multiple patients per day. It is easier to mobilize the patients in between the treatment. It is definitely less expensive as compared to CRRT. Fewer bleeding complications because lesser exposure to anticoagulation is there, lesser filter clotting is there, and superior solute clearance is also there, more rapid removal of toxins because of higher flow. So what you have to see is what kind of patients it will be suiting more. For instance, if it's a hemodynamically unstable patient, go for CRRT. If it's an acute liver failure patient or acute brain injury patient, septic shock patient, you can go for CRRT. But anybody who is having a higher bleeding risk, you cannot give too much of anticoagulation, then probably you have to go for intermittent hemodialysis. Acute treatment of hyperkalemia, metabolic acidosis, or any sort of poisoning where you want to remove the poison quickly, or tumor lysis syndrome where you want to treat the electrolytes going all haywire, intermittent hemodialysis is better. So we all know what are the different treatments now. You have CRRT and you have intermittent hemodialysis. But there is something which is there in between, actually combines the benefits of both, and it could be called SLED, it could be prolonged intermittent renal replacement therapy or hybrid technique. So we'll talk a little bit about that. So as we all know that CRRT is more highly intense and low efficiency, and intermittent hemodialysis more low intensity and highly efficiency. So if you see SLED, it is actually a hybrid of both, and it has some good qualities of both. And basically CRRT is better for hemodynamic stability and a steady state, and SLED is actually more towards CRRT. So let's see what are the advantages of SLED. So what is SLED? SLED is sustained low efficiency dialysis, as the name suggests. It's sustained, so it is for more period of time, but it is not continuous. It is low efficiency, means it has low dialysate flow rate and low blood flow rate also. And the mechanism which is used here is diffusion. How is it performed? With your intermittent hemodialysis machine, and the blood flow rate is usually set at 200 ml per minute, and the dialysate flow rate is usually 100 to 200 ml per minute. The time required is around 6 to 12 hours, around 6 to 8 hours, which we usually use, and the days you can use all 6 days. So SLED is basically a hybrid therapy. The main advantage is that in terms of intensity and duration, intermittent sessions and larger hours, you can use it with low efficiency and lower blood pump speed. It runs 8 to 12 hours a day. It can be done daily. There's a lot of flexibility around the machine also and around the patient also. You can mobilize the patient. You can take the patient for various radiological things. The patient needs a scan or something. Dialysate flow rate is usually 200 to 300 ml per minute, which is for shorter duration. And it aims to combine the logistic and cost advantages of IHT, as well as it actually helps in maintaining the cardiovascular stability of CRRT. So we can say it is like best of both worlds. So the major advantages is flexibility again, less labor intensive, less anticoagulation, lesser cost, a similar adequacy and hemodynamics, requires less training to start it up, and the solute and fluid removal is slower than intermittent hemodialysis but faster than CRRT. And all the meta-analysis have actually showed that SLED outcomes are similar to CRRTs. So which form of RRT should we use? No single technique has been shown better to other, and decision completely depends upon the patient. So what do you want to remove from plasma? How is the hemodynamic status of the patient? What are your available resources in your ICU? What is your clinical expertise? What are the clinical considerations you need to have in mind? So basically keep these things in mind before choosing a modality of RRT. So what you want to remove from plasma, in terms of that, if you want to remove smaller molecule, then dialysis is a better option for you. If you want to remove middle molecules, filtration will be better than dialysis. And if you want to remove lower weight molecules, and filtration again will be better than dialysis, and if you want to remove water, then filtration will be better than dialysis. So that's the first thing. Patient's cardiovascular status, we already discussed that CRRT definitely causes more hemodynamic stability, and it is a preferred option. And availability of resources also, you need to have a CRRT machine in your hospital to do CRRT. It is more labor intensive, it is more costly, it is more expensive than intermittent hemodialysis and SLED. So availability is also very important, and clinicians' experience is also very important. Okay, so in terms of, again, coming back to modalities of RRT to be chosen, if it's a patient of acute brain injury, sepsis patient with hemodynamic instability, go for CRRT. But if the main thing is you want to remove, you want to cause rapid correction of acidosis, electrolytes, fluid overload, go for intermittent hemodialysis. So we'll come back to the guidelines. Basically, what do the guidelines say? So the choice of RRT depends upon the availability of the source in your facility, whatever experience and expertise your team has. And it also recommends that, use CRRT or SLED more than intermittent hemodialysis for patients who are hemodynamically unstable. Use intermittent hemodialysis for the patients who are hyperkalemic and are having cardiac arrhythmias, probably because of that. And use intermittent hemodialysis or SLED over CRRT for rapid correction of metabolic acidosis, and use CRRT over SLED or intermittent hemodialysis for raised ICT. And again, use CRRT, SLED or intermittent hemodialysis over PD for hypercatabolic patients, which are most of your ICU patients. So this is what basically your guideline says, which actually makes quite a lot of sense also when we put this into clinical perspective daily. So, so SLED versus CRRT versus IHD, it's an ongoing debate. Theoretical benefits are there for both. You have a patient, suited for both. At least 7 RCTs and 3 meta-analyses have not demonstrated any difference in outcomes. Every population is different, every subpopulation is different, so you have to choose your modality accordingly. So hybrid therapy, is it an answer for ICU where you do not have a CRRT machine? Yes. So it provides more flexibility in terms of duration, intensity, and the major advantage is obviously reduced cost, and it is more flexible, and lesser need of anticoagulation is there. It's definitely safer in terms of your lesser use of anticoagulation, and also it is safer because it is more hemodynamic. It maintains hemodynamic stability more compared to the intermittent hemodialysis patient. So a small study actually showed slightly higher acidosis and lower BP, but this was a very small study. But rest all the studies have actually not shown any difference in outcomes when you are comparing CRRT versus SLED. So we are coming to the end of the presentation now. So if it's a CRRT, the advantages, hemodynamically unstable patients will cause more, it will actually be beneficial for them, and patients who are at high risk of raised ICT. But of course, the advantages are these. The disadvantages are that there's lesser clearance of toxins, there is prolonged anticoagulation need, the patient is immobilized for a longer period of time, and of course, there is increased in cost. So these are the disadvantages of CRRT. And it comes to SLED, it is definitely a slower volume and solute removal, maintains hemodynamic stability, allows for downtime for other things like diagnostic and therapeutic procedures, and of course there is also little slower clearance of toxins and technically more complex and demanding. So before I end the presentation, I'll just ask 2 questions just to make sure that everybody has listened to what I have discussed. So there's a 68-year-old lady who has been admitted to ICU with biliary sepsis and developed stage 3 AKI. Urine output is around 15 to 30 ml per hour. So, and the creatinine is 2.5. So these are the investigations. She is on low dose of NORAD and mechanically ventilated with FiO2 of 40% and PEEP of 8. And cumulative fluid balance is 7. What is the most appropriate management strategy? So should we start RRT at this stage? Yes or no? Yes. What is the urgent indication of RRT here?
Positive fluid balance, which is stage 3
But all stage 3 patients should have dialysis or RRT? So do we have any 4 urgent indications of RRT, which is hyperkalemia, fluid overload, which is resistant to diuretics, and uremic encephalopathy? So any of those symptoms present here? So option A is not right? So management of fluid balance is the strongest indication of RRT. Is it so?
Yes, because fluid balance is 7.
So can you not give furosemide here and try to maintain a negative balance and see, does it become an indication of renal replacement therapy, or you can still give diuretics and manage the fluid balance? So all the 4 indications of urgent dialysis is not present here. So based on her vasopressor requirement, she will benefit from high volume hemofiltration. Is that correct? No. RRT is indicated if she requires a procedure that requires intravenous contrast. Not necessarily, right? Only when she develops anything complication related to the contrast, then only she'll require. So the answer here is response to furosemide may help you determine renal prognosis. So you can give a high dose furosemide and see how she's responding. So stage of AKI is not an indication for RRT. Let it be stage 1, stage 2, stage 3. RRT is not indicated in stage 3. Fluid overload can be addressed with diuretics or RRT. So if they do not respond to diuretics, then you go for renal replacement therapy. And also the choice of RRT is more not dependent on just vasopressor requirement. The IV contrast administration is not an indication for RRT. So detecting the worsening of AKI, you can actually do a furosemide stress test. You can give high dose of furosemide and monitor the urine output. If the urine output is less than 200 ml in the next 2 hours, then there is a strong indication that the patient might require renal replacement therapy. So the correct answer here is furosemide may help in determining the renal prognosis. Next question. A 45-year-old man is presenting in the ICU with acute kidney injury. Potassium is 7.2 and refractory to medical management. So obviously you have to start renal replacement therapy. His background of alcoholic cirrhosis and has abnormal liver function test, but his clotting is normal. He has to be started on CRRT. So what is your best anticoagulation strategy? I know I've not covered anticoagulation today, but just for, what is your best anticoagulation strategy here? I think it is unfractionated heparin because he has abnormal liver functions, so we'll stay away from regional central anticoagulation. Okay, thank you so much, guys. Thank you for your patient listening.
I would like to call Dr. Sudeep Sen to felicitate the speaker and the chairpersons.
Thank you, Dr. Sudeep, and thank you, Dr. Nilesh. I request Dr. Ashwini to just hand over to Dr. Saurabh Kothari.
As you all know, there are many controversies when it comes to ventilatory setting of ARDS, and I'm sure the next talk will help clearing in those. So without further delay, I would like to call Dr. Sameer Jog, HOD of Critical Care Medicine, Deennath Mangeshkar, Pune. And the moderators for the talk will be Dr. Sudeep Sen, Dr. Sanjay Thakur, and Dr. Chaitanya Kulkarni.
Hello. Thank you for calling non-Apollo speaker in the Apollo conclave. This is the first disclaimer, and the second disclaimer, I am from a poor hospital or poor charitable trust hospital ICU and may not be very fluent with a corporate rich ICU settings. So these are two my disclaimers. Let's see whether you like our discussion on how I ventilate ARDS or not. So let's start with the case summary. We have seen such hundreds of patients in last 2 years back in COVID, but this is not a COVID case. 40-year-old male, weight of 60 kilogram, no past medical history, admitted in emergency room following 3 days of fever, cough, progressive breathlessness, desaturating at around 86%, hydration status normal, blood pressure, heart rate, ECG, echocardiography, everything looks normal on admission. On 6 liters of oxygen, his blood gas is showing. Blood gas is showing hypoxia with some CO2 retention. Blood results are unremarkable with leukopenia, with thrombocytopenia, and AST more than ALT, and X-ray shows this. So this is possibly viral pneumonitis, which is worsening with hypoxia with respiratory failure. But one word of caution before labeling everybody who's requiring oxygen having a scenario like viral pneumonitis as a labeling as wrongly ARDS, you have to differentiate these 10 diseases which are not actually ARDS, and you have specific diagnosis for them, and for which you have to do battery of tests like HRCT, echocardiography, blood test, lung biopsy, many things. So don't label everybody who has got bilateral non-homogeneous opacities with some infection in the chest as ARDS. Because if you diagnose these conditions like heart failure with preserved ejection fraction, the treatment is completely different. So this is important first step for before starting your ventilation. Causes of ARDS, you know, pneumonia, aspiration, sepsis, severe trauma, and shock being the most common one. So I won't be repeating them. Till today, we follow the Berlin definition, and the new definition is ensuing in next 1 or 2 years. But till that time, this is the definition which all of us agree and practice. It's primarily based on timing within 7 days of acute onset of illness of lung. Chest imaging shows bilateral opacities which cannot be explained by effusion, collapse, and nodules. This is very important. Chest imaging doesn't mean chest X-ray. It can be ultrasound examination. It can be CT scan as well. So chest imaging doesn't mean only X-ray. And origin of edema cannot be fully explained by fluid overload or hydrostatic edema or cardiac dysfunction. You have to have something else for this. And depending upon oxygenation, there are 3 varieties, on severity 3 varieties, mild, moderate, and severe, where PF ratio is from 300 to 200, 200 to 100, and below 100. And this is important to diagnose begin with because the mortality is different. If you diagnose somebody with mild ARDS, the mortality is 27, expected mortality. And if you diagnose somebody with severe ARDS with PF ratio below 100, the expected mortality is somewhere around 50%. And this is a rough scheme where published in JAMA almost 10 years back, where as the PF ratio worsens from mild to moderate, from 300 to 100, initial modalities are always HFNO, NIV, then moderate ARDS. Around 150, these therapies stop, and most of us intubate the patients at this point of time. And then if the patient is not improving, we apply one of these therapies step by step. We already had a discussion on prone and ECMO by my colleague from Hyderabad. So going back to case, we started ceftriaxone, azithromycin, and oseltamivir based upon our local infection department guideline. Non-invasive ventilation was started because patient was becoming tachypneic on 6 liters of oxygen with CPAP of 7 and pressure support of 8. Patient developed severe agitation secondary to claustrophobia and possibly hypoxia, and the clinical situation worsened. One important point I would like to quote here is steroid in ARDS in non-COVID. This is important. In non-COVID ARDS, steroid has got no role. You may debate with me. I'm ready to debate till my death or your death, but steroid has no role in ARDS, in non-COVID ARDS especially, right? At any stage of ARDS, in early first 3 days, next 4 days, next 7 days, 7 to 14 days, 14 to 28 days, there is no role of steroid in ARDS, provided there is no compelling indication of giving steroid for something else which is a comorbid condition. For example, patient has got COPD and has got worsened hypoxia and because of chest infection, and now PF ratio is below 100. So he has got COPD, lung pneumonia, and you have diagnosed ARDS. Obviously, he will need steroid because you are giving steroid not for ARDS, but giving steroid for his primary disease, which is COPD. Same is true about asthma, same is true about eosinophilic pneumonia, same is true about somebody landing with lupus lung, somebody landing with interstitial lung disease. So everywhere the steroid is a treatment. But per se, if you are diagnosing ARDS, let's say because of pancreatitis, let's say because of polytrauma, then steroid has got no role. Same is true about pharmacotherapy of ARDS. There is no pharmacotherapy of ARDS. And lot many drugs have come and gone in last 50 years in the literature. And currently, there is one drug which is so-called paracrine or endocrine hormone, which is being given for ARDS. I don't know how hormone will help or treat ARDS, but it's all gimmick, or I would say it's false selling of medication, but there is no drug therapy for ARDS. Remember this. You have to treat the primary cause. If the primary cause is infection, treat with antimicrobials. If primary cause is viral pneumonitis, treat with antiviral with some caution, because antivirals are not very strong effective therapy. If primary cause is because of polytrauma, you have to treat the polytrauma. So there is no primary drug treatment for ARDS at all. Coming back to ventilation strategy, NIV and ARDS, till date, there has been more than 100 studies published. A good 10 to 11 RCTs has been published on NIV in hypoxic respiratory failure or ARDS. But the data is quite conflicting. And this is the beauty of modern science. When we say that we really don't know the answer, we with conviction said we really don't know the answer. And that's why we are not dragged to Supreme Court for false claims, right? We never do false claims. So for example, NIV, we really don't know whether NIV is effective therapy for ARDS, because there are some trials which have shown NIV can avoid intubation and have got better outcomes, whereas some trials have shown NIV, in fact, worsens the outcome because patients are unnecessarily stretched upon NIV and they are intubated when the terminal stage comes. So unnecessary time is spent on NIV. So till date, we really don't know whether to ventilate patient with NIV, but by and large, people believe that if your PF ratio is above 150 and patient is tachypneic with distress, use NIV, but if PF ratio is below 150, it's prudent to avoid NIV in these patients. So if you apply NIV, for like our case of PF ratio somewhere around 150, we applied NIV as I said, but be vigilant, and there are multiple caveats for discontinuing NIV or switching from NIV to invasive mechanical ventilation. So there are many issues. Scores, for example, there are score called ROX index or Hackor index, where these are the scores which are readily available on a Medicalc or any other device, where it will guide you when to intubate the patient. But the thumb rule simply is if the patient remains persistently distressed on NIV or HFNO, and if the PF ratio is below 150, it is prudent to intubate the patient rather than pulling on HFNO or NIV. This is the thumb rule. But of course, the COVID was exception to this, and with other colleagues in Pune, we performed this Picasso study which got published in Indian Journal of Critical Care Medicine. As all of you know, in the COVID time, we were pressed with non-availability of ventilator, non-availability of ICU beds, non-availability of workforce also. So a lot of patients were treated with HFNO and NIV who actually merit mechanical ventilation. So this was the aim of our doing study, and we did study 1200 patients of COVID ARDS who had PF ratio below 100. So ideally in non-COVID situation, all of them would have intubated and mechanically ventilated. But since the availability of mechanical ventilation, ICU bed, sedative drugs in fact, and adequate manpower was not available, these patients were dragged on or pulled on NIV or HFNO. To our surprise, we could show that only 63% of them required invasive mechanical ventilation. In non-COVID situation, all 100% would have required intubation, right? Need of IMV was significantly lower in HFNO group, it is statistical significance, and 28-day mortality was 44% in HFNO group, and NIV was little higher mortality. So but today it's very difficult to extrapolate these numbers to non-COVID situations, because today there is no dearth of sedative drugs, paralytic drug, oxygen, manpower. So we cannot extrapolate the COVID to non-COVID. But the moral of the story is, from PF ratio 150 to 100, there is still debate. If the patient looks stable if the patient is not having distress, not retaining CO2, single organ failure, you can still think of continuing NIV or HFNO. So when to say no to HFNO or NIV? Extreme hemodynamic instability, reduced level of consciousness, PF ratio below 100 today, and severe respiratory acidosis because of CO2 retention. If these are there, then obviously don't continue your HFNO or NIV. Always intubate this patient preemptively. About 2-3 slides on HFNO. After publication of Florali study in 2015, HFNO became quite popular, and we were the first center in our country to buy HFNO and started HFNO after the Florali study published within 3 months. So we have huge data before COVID actually struck us. Almost 4 years we were using HFNO before COVID struck us. And then COVID, all of you know, HFNO became the most popular device system in the country. Just to recapitulate how HFNO works, HFNO, it improves ventilation perfusion mismatch. It reduces respiratory drive because it gives the flow somewhere around 50 to 60 liters. It reduces work of breathing. It produces some amount of PEEP effect, not exactly like invasive mechanical ventilation or NIV, but it produces some amount of PEEP effect. There is efficient CO2 tolerance, and most importantly, there is no claustrophobia and excellent patient tolerance and acceptance for this. So I think these are the two things which make HFNO more popular and more effective. But we don't practice popular medicine, or we don't practice individual medicine. We make our decision making based on randomized control study or good quality studies. And this is the Florali study which showed that HFNO as compared to standard oxygen therapy and third component as compared to non-invasive mechanical ventilation is definitely better treatment, better in terms of two questions. One is 28-day intubation rate. In 28-day intubation rate, if you see the numbers, 38, 47, 50, these are the patients who got intubation at day 28 on these devices, HFNO, standard oxygen therapy and NIV. So the numbers, you can obviously make it, but it did not reach the statistical significance. Though the part A or question A of Florali study was negative, means HFNO cannot avoid invasive mechanical ventilation, statistically significant numbers, but our personal experience, HFNO definitely in some patients, chosen selectively, can avoid mechanical ventilation. But the more important part of the study, this Florali study, is if the patient has got PF ratio below 200, that's what we are interested. Patient in whom PF ratio is above 200 rarely require respiratory support. They are usually done with oxygen, nebulization, every other thing. So if patient PF ratio is below 200, what happens to these two comparisons? Then the statistical significance definitely achieved, and need for intubation is definitely less with HFNO, 34%, 52% and 58%, and which also showed the improvement in mortality as well in the Florali study. And especially this is very important in India, I believe, because once you tube the patient, the risk of invasive mechanical, risk of ventilator associated pneumonia always looms around. So there is no ICU in the India which can claim that we have got a VAP rate as compared to any French ICU or Belgian ICU or Dutch ICU. If there is there, please tell me. I'm ready to serve there, right? So Indian ICU VAP rate is almost everywhere the same, whether it is a private hospital, corporate hospital, government hospital, charitable trust hospital, 1-star hospital or 7-star hospital. The VAP rate is more or less the same. So if the VAP rate is so much high as compared to Western population, why not first place, why to tube the patient? If you have got a good access or good modality to treat the patient with not tubing the patient. So that's how HFNO makes my life comfortable and my patient's life and pocket also comfortable, because one single episode of VAP is going to spend few more lakhs for him or her. So HFNO I would definitely propose for the patients in whom PF ratio is somewhere around 150, even a little less with more caution. I won't be provocative that use HFNO for all patients, but if PF ratio is around 150 or maybe 125 to 150 and patient has got single organ failure, always give chance to HFNO. Many of your patients will avoid invasive mechanical ventilation. So coming back to case, we tried NIV, we tried with this, but ABG did not improve. I specifically avoided HFNO in my case because NIV is more commonly practiced, I believe, before COVID, but after COVID, I think NIV and HFNO are more or less same practiced in many units in the country. So once you intubate, what is your mode of ventilation? Volume triggered, pressure triggered, or any other mode? Usually for ARDS, hypoxic respiratory failure, when we intubate the patient, it's better to keep the patient on volume control ventilation, because the lung mechanics which are studied like resistance, compliance, plateau pressure, everything is well measured with volume control ventilations. And which is the commonest setting for volume control ventilation for our patients? mostly we start with 8 ml per kilogram of predicted body weight, which is not dependent on actual weight, but it is dependent on the length of the patient, right? And then quickly reduce the tidal volume from 8 to 6 ml per kg. Why not to start immediately at 6 ml per kg? Because there is a risk of hypoventilation and CO2 retention and rapid rise of CO2 in first few hours. So always start with 8 ml and next do ABG and then switch to 6 ml per kilogram. Respiratory rate, 25 is usually commonly practiced respiratory rate in large clinical trials. PEEP, when somebody requires invasive mechanical ventilation after failure of NIV or HFNO, the PEEP requirement is usually around 8 to 10. It is very unlikely that you intubate the patient and patient's oxygenation is well maintained on PEEP of 5 or PEEP of 6. It's very, very unlikely. So start with PEEP of around 9 to 10, flow of 40 liters per minute and I ratio of 1:2. This is the standard setting of invasive mechanical ventilation when I put my patient on volume control ventilation. Okay, let's see what happened to our patient. Tidal volume as per his predicted body weight was 395, around 400 ml, RR26, PEEP 10. FiO2 initially kept 1, but then gradually reduced to 0.7 to 0.6, depending upon the PF ratio and ARDSNet PF ratio and PEEP table. I ratio was kept 1:2. At this point of time, you must be aware that the patient will get killed not because by the disease, but also by doctor. So once patient come to hospital, there are 4 Ds which play the role: doctor, drug, disease and destiny. Unfortunately, for the relatives, it's only doctor and drug, because when they say I have paid so much of lakhs rupees, still the patient worsened. So only doctor and drugs are responsible. They will always neglect that there is drug and destiny also there, but the disease and destiny always there in every issue. But a ventilator is a therapy, but at the same time, it will create harm to every single patient if you don't apply your buttons correctly. So this is what you should remember when you start your mechanical ventilation. There are possibly 5 types of trauma or injuries which you can impart to your patient while ventilating ARDS patients, which are little difficult to ventilate. Barotrauma, which is because of higher pressures. Volutrauma because of higher tidal volumes. Atelic trauma because of cycling opening and closing, means higher the respiratory rate, higher the trauma. Biotrauma is something which is cytokines release just somebody on positive pressure ventilation. So this is a little unknown which you cannot control, because everybody has to be on positive pressure ventilation when intubated, so which is unavoidable. And ergotrauma is power injury, means the number of times tidal volume is delivered to the lung. Higher the flow, higher the PEEP and higher the plateau pressure, they will impart higher energy from mechanical ventilator to lung, and the energy induced trauma to lung will be higher. So these 5 types of trauma you must remember, out of which biotrauma is completely unavoidable, because once you put on positive pressure ventilation, is bound to occur. List 4 can be minimized with appropriate setting of mechanical ventilation, and let's see what they are. Once you tube the patient, whether you should use paralysis or neuromuscular paralysis or not, again the world is divided. In 2010, Lawrence Papazian published a study showed that neuromuscular paralysis for first 48 hours with cis-atracheurium showed some benefit in outcome as well as reduction in mortality. But in 2019, American study compared paralysis versus no paralysis and only deeper sedation, showed that there is no difference in mortality, and mortality almost 40% in both groups. So today the card is open, but to me, practically it is simple and probably prudent to paralyze the patient if you are ventilating severe ARDS, because you want to understand what is lung mechanics, what is compliance, what is plateau pressure, how much amount of PEEP you want to dial, and you want to put the line, you want to keep the patient in prone position after a few hours. So for which neuroparalysis is beneficial definitely, at least in first 24 to 48 hours. Then control ventilator asynchrony. With prone position, obviously we put the patient in neuroparalysis. It is very unlikely that patient is in prone position like this and he is moving his hands and is allowed to put the tube in prone position. So it's not possible. Okay, so 12 hours after what happened? pH dropped, PCO2 55, PO2 84, PF ratio 140, lactate around normal. These are the settings on the right hand side, which PEEP of 10, FiO2 of 0.6, plateau of 26. So we are at 6 ml per kg of predicted body weight, perfectly tidal volume, plateau pressure below 30, FiO2 is 0.6, which is acceptable, PEEP is just 10, not more than that. But my PF ratio is around 140. What will you do? Wait for 3-4 days, because everything you have done for this patient, and ARD is not going to get recovered in the next 1 or 2 days, so it will take 3, 4, 5, 6 sweet own time. Or you accept this and go to your device which is in your pocket, or do something else for your patient. The PF ratio is 140, and that's the crux. You must prone this patient as early as possible. Just because the ProSeva study got published in 2013, which clearly showed that if you prone the patient early in first 36 hours of onset of ARDS, there is significant mortality difference. So every single patient whose PF ratio is below 150 and requirement of PEEP around 8 to 10 should get a chance with prone ventilation, irrespective of any other condition. Unless there is a strong contraindication for prone position, for example, complex pelvic fracture, complex spine surgery. These are the few contraindications where you should not prone the patient. So prone is not at all a rescue therapy today. Prone is definitely a standard of care if your PF ratio is below 150 and your PEEP requirement is around 8 to 10. Every single patient should receive prone therapy in your ICU, irrespective of every other thing. Because there is a mortality benefit for this. In patients who were treated in supine position, the mortality was 32% in patients with moderate to severe ARDS in Claude Guerin's ProSeva study, whereas in prone position, the mortality was just 16%. And surprisingly, in prone position, the reversal of septic shock was almost 24 hours earlier in a similar kind of patients. So prone position also improves your hemodynamic state as well. So somebody has got wrong bias that patient has on norepinephrine, patient is on vasopressin, has got shock, so should not be prone, not at all. If the patient has got septic shock, it is more the reason you should prone the patient, because ProSeva has showed that the reversal of shock is earlier in prone position. Why do we prone? For these physiological reasons. Reduction of intrapulmonary shunt improves lung mechanic, reduces ventilator-induced lung injury, it reduces biotrauma as well, it has been very well shown, and hemodynamic benefit obviously, as I said. So we prone this patient for almost 16 hours. And after prone position, the PF ratio marginally improved. 97 became 112, PCO2 53 to marginally reduced, plateau pressure from 31 to 29. So just in the morning, my colleague from Hyderabad showed you that after first prone position, if the four numbers, means oxygenation, CO2 retention or respiratory acidosis, plateau pressure and driving pressure are not significantly improved, there is a possibility that this patient is prone non-responder. But this is all afterthought or post hoc analysis. There is no study which has shown that if you follow this pathway, the outcome is better. So this is just a post hoc analysis, right? So we really don't know who is prone non-responder at present, but there is a worthwhile to give prone at least 2 to 3 prone trials to patients unless you are worsening hypoxia despite prone position, worsening CO2 retention, worsening plateau pressure or worsening driving pressure. In our patient, there is hardly any improvement, but there is no worsening also. So I think it is worthwhile to continue prone. Additionally, ECMO is very costly for us, so we don't push the patient quickly to ECMO as well. Then one practical thing. At 6 a.m., most of the time, complications always occur at around 5:30 a.m. to 7:30 a.m. in the morning in all ICUs on the world, right? And there is a physiological reason because our diurnal clock runs like that. And that's why our vigilance is little less. Our staff is tired by doing night shift. And that's what, and during the sponging, what is this shown? ETCO2 graph. This is disconnection of ventilator. This is disconnection. But after disconnection, the saturation is still okay. Blood pressure is okay. Heart rate is okay. For the first 1 or 2 minutes, nothing happens because oxygenation is reasonably well maintained. But after 1 or 2 minutes, there is a dramatic hula hoop goes in the ICU, and this is typically 6 a.m. problem in the ICU. So what do we do that? Patient is already on mechanical ventilator requiring PEEP of 10 and sudden desaturation to 60% or 59%. What do we do? Obviously, we do everything, like we do X-ray, we do blood gas, we do quick echo finding, because all our residents are now very well versed with echo. So they may not auscultate Korotkov sound for blood pressure, but they are very good in echocardiography as well at present. This is the sad situation of our ICU, but this is true. So they are very well versed in echocardiography, and they say that there is no RV dysfunction, the lung ultrasound looks same as done in the last night. There is no LV dysfunction, no global dysfunction, no TR, no MR, nothing. So echo don't show anything. So what do we do? This is nothing but a severe de-recruitment of the lung because of sudden disconnection of your ventilator. And it takes time for lung to get inflated again, and this has to be done very quickly. And thus a recruitment maneuver usually helps in this position. So what is definition of recruitment maneuver? It's a dynamic process of opening previously collapsed alveolar units by increasing transpulmonary pressure and then keeping them open at a lower than that needed for opening. All of you are from Apollo, so the simple understanding is the recruitment maneuver, how corporate hospital does is recruit at higher salary, and next 2 to 3 years keep them there in calculating inflation. This means a lower salary and keep it recruited. That's exactly recruitment maneuver of the lung is. Open the lung at a higher pressure and then keep it open at a little lower pressure, because we never apply PEEP of 30 or 40, which we do apply during recruitment maneuver. So for recruitment maneuver, we apply PEEP of around 30 to 35 centimeters of water for transiently 45 to 50 seconds, right? And that's how we inflate the lung quickly. And then we gradually reduce the PEEP to say 11, 12, 13 centimeters of water. So lung opening pressure is 40 and keeping the lung open pressure is around 12 to 13 centimeters of water. So that's what exactly recruitment maneuver is. So people thought, shall we use recruitment to all patients periodically, whether this will help or not? But it is flip side, means there is significant hemodynamic instability occurs with the PEEP of 35 to 40. Possibility of pneumothorax is high, ventilators, lung injury with non-recruiters. If the lung is not recruitable at all, you unnecessarily break open the lung. And it's a labor intensive also. So there was a trial published in JAMA around 6 years back, which clearly showed that intermittent recruitment maneuver every 6 hourly or every 8 hourly doesn't help in the outcomes at all. So now as of in 2024, recruitment maneuver is beneficial only in patients with severe hypoxic spells like 6 a.m. story which I just mentioned, temporary disconnections during bronchoscopy, during suction or during sampling where inevitably there is loss of recruitment occurs. So in that time, transient recruitment maneuver may be help, otherwise recruitment maneuver doesn't help much. So patient was in prone position, and this is the benefit of, this is the slide which my colleague from Hyderabad already showed you, that this is the lung where you want to open your therapies. You don't want to do anything to this lung which is already open and well ventilating, and this is the lung and pleura which is going beyond the scope of any mechanical ventilation. Nothing happen, even if you apply pressure of 60 centimeter of water, nothing will happen to that. You will just burst open this lung. So you have to focus upon this part of the lung, and which you cannot do every day in your clinical practice because you are not going to do CT scan every day. But by and large, if you adjust the PEEP correctly and maintain the plateau pressure below 30, then you will be in a safe zone that you will be ventilating this area well and you are not over distending this area at the same time. So how you strike balance with this? Balance is struck with the adjustment of the correct PEEP. And to date, there are at least 11 methods of adjusting PEEP in your ARDS patients. You can choose any of this. This simply from gas exchange means if you start with PEEP of 10 and your saturation is still 84 to 85, you go on increasing PEEP by 1 centimeter after every 30 minutes, right? And see at what level of PEEP your saturation is good. This is gas exchange method, which is very simple, and all of us do this every day. Then the compliance of the respiratory system, calculate the compliance of respiratory system, and depending upon the best compliance calculation with multiple permutation of combinations of PEEP and tidal volume, you choose it, or use echocardiography, or use ultrasound, or use electrical impedance tomography, or use ventilator curves to decide lower inflection point and decide the PEEP. So there are at least 11 methods, these are described here, to adjust your PEEP. You can choose any one, but the simplest method I would suggest is gas exchange method, ARDS net table, which shows comparison of PEEP and PF ratio, or comparison of PEEP and FiO2 to maintain your PEEP and FiO2, echocardiography, which is simple and almost everybody of you can do this, and lung ultrasound. So these are the 4 good modalities to adjust your PEEP in any mechanical ventilation. On day 3 of ICU, after 3 prone position, PEEP adjusted to 16, no RV dysfunction, PF ratio still 92. Is this PEEP adequate or not? This PEEP is adequate or not, we really don't know, for which there is a modality called transpulmonary pressure measurement, which we do routinely in our ICU. And we came to know that in this patient, the PEEP of 16 was also less. And the ideal PEEP requirement for this patient was actually 22 centimeters of water. So we increased PEEP to 22 centimeters after diagnosing transpulmonary pressure by putting esophageal balloon catheter in this patient. I will skip that part, but beyond the scope of today's talk. Remember, these safety limits of mechanical ventilation in ARDS is very, very important, because ventilator is a therapy, is a healing device, but at the same time, it can be killing device if you don't apply your buttons correctly. And what are the correct buttons, or what are the correct limits? Your tidal volume has to be around 6 ml per kilogram of predicted body weight, not actual body weight, and this is the reason why we do this. This is trial published in NEGM 2000, almost 24 years back. Plateau pressure 30 centimeter. If plateau pressure goes beyond 30, then the risk of barotrauma and ventilator-induced lung injury is very high. There is a risk of death as well. This is also shown in ARDS net study in 2000. PEEP, there is no consensus definition which is appropriate PEEP for individual patients. So you have to individualize the PEEP and check at what PEEP your plateau pressure going beyond 30, at what PEEP your oxygenation is better, at what PEEP your RV dysfunction sets in, or at what PEEP your recruitment on lung ultrasound looks better. So you have to choose PEEP individually, and there is no consensus definition for this. Respiratory rate around 30 is perfectly okay, from 25 to 30. As you go higher on respiratory rate, more number of times you inflate and deflate the lung, which leads to atelic trauma, and which is a very primum reason for transferring more energy to lung. And energy-induced lung trauma or ergotrauma is nowadays very new concept, and is probably will explain many things in ventilator-induced lung injuries. So try to keep respiratory rate somewhere around 30, not more than that. And transpulmonary pressure, which we use by putting esophageal balloon pressure somewhere around 22, inspiratory pressure and expiratory pressure above 1. So these are the safety limits of mechanical ventilation. And of late, the driving pressure, which we just mentioned in the morning, the driving pressure is nothing but the gap or the pressure gap between the plateau pressure and the PEEP. If the driving pressure is above 15, there is a risk of poor outcome. And if the driving pressure remains below 15, I'll show you with this graph. So this is the plateau pressure, and this is my PEEP. If the PEEP is 10 and plateau pressure is 25, my driving pressure is 15. This is the upper limit of driving pressure. As the driving pressure goes beyond 15, 16, 17, 18, the risk of death or risk of poor outcome is there. So try to maintain driving pressure below 15. That's another safety limit which has been added in last few years in our safety limits of ARDS. So let's recapitulate the safety limits of ARDS. Tidal volume, plateau pressure, PEEP, respiratory rate, transpulmonary pressure, driving pressure, and mechanical power of 17 joule, which is beyond the scope of today's talk. But just remember the number. The mechanical power depends upon the PEEP, flow, respiratory rate, and plateau pressure. Okay, and my last slide, when do we do ECMO? I think Niranjan has already discussed about when we shift to patient to ECMO. It's nothing but the same thing which I am saying. Only thing is, I little disagree with Niranjan's talk in the morning. He categorically showed Gattinoni and Claude Guerin's publication, which showed that if after the prone in all 4 quadrants, mean oxygenation, CO2, plateau pressure, and driving pressure, all are not improving, that's an indication of early ECMO, but that's a presumptive hypothesis. Nobody has proved this. So this is a bunch of people who have gathered together and thought that this may be a good idea to start ECMO for this patient. But this has been proven at all. And medical science or practice is based on expert opinion. It has to have strong proof for this. Okay, thank you very much.
Thank you, sir. I would like to call.
Yeah, thank you, Dr. Zog, for that excellent talk. Just remembering your 4 Ds about doctor, drugs, disease. I would slightly disagree with the destiny part of it. I would like to put their dollar. Particularly in the dollar instead of destiny, and particularly with the context of your comparison of a corporate hospital with a charity. The moment you say charity, it becomes a slightly difficult sector, because any intensive care is going to be a costly care.
Yeah, it's a costly affair, but I cannot put a dollar, because how is the charitable trust hospital? If the patient say, we cannot afford, we cannot say, then go home, go lama, go dama, go hama. We have to treat that patient even if he doesn't pay a single rupee. So that's the part of the story. So anyway.
Yeah, again, thank you very much, sir. So I just have a quick question for you. So how frequently in the ARDS patients, you monitor your PEEP setting with the transesophageal pressure monitoring, and
I tell you.
How do you do it regularly or in the kind of regular practice?
We never do regularly. If the PEEP requirement is around 15 centimeters of water, if your plateau pressure is reaching about 30, and the patient has got extra parenchymal component which is affecting your ventilation. For example, very obese patient, right? In very obese patient, what happens? The ventilator pushes the lung through endotracheal tube, but it has to work against the tight chest wall and the subcutaneous fat as well. So the ventilator doesn't distend only parenchyma, but it distends the chest wall as well, because it has to work against both. So you have to differentiate, if there is a technique which differentiate what is the stiffness of extraparenchymal component and what is the stiffness of parenchymal component. And this typically happens in very obese patient with multiple fibrosis, bilateral pleural fibrosis, patients with intra-abdominal hypertension or abdominal compartment syndrome, where we little difficult to prone for them because they are distended significantly. So it's not that impossible, but it's not commonly done. We are also scared for that. In those patients, transpulmonary pressure measurement really helps because it can segregate extraparenchymal elastance and parenchymal elastance. So that's how it helps to adjust the PEEP in select class of patient. I won't say in every single patient. In fact, if I'm ventilating around 20 patients of ARDS in non-season, this is a non-season. Our season of ARDS is typically July, August, September, October, where tropical diseases and chest infection common. And again, December, January, February, where our winter pneumonia or winter viral infections are high. In those periods, we almost at any given time in our hospital, which has got 108 bed ICU, at least 3 to 4 patients are in prone position. But in non-season like this, there is only 1 or 2 patients who are in prone position.
I think this is the absolutely as per the published study that has been published on the esophageal pressure monitoring. They have found it beneficial only in that group only, like obesity patient, somebody who is obese. It's always better to have a esophageal pressure monitor to identify what is the transpulmonary pressure, and based on that we can adjust the PEEP. So that is exactly the kind of that has been published. Any other question? Otherwise we can wind up. Thank you, sir.
Thank you.
I would like to call Dr. Akshay Chalani sir to felicitate Dr. Sameer Jog. Cytokine storm is an important but mostly underdiagnosed clinical scenario. So next I would like to call Dr. Sanjay sir, consultant critical care medicine, Bangalore Apollo, Bannerghatta Road, to talk about and enlighten us about cytokine storm. I request moderators to please be seated for the next 2 talks.
Good evening, everyone. Thank you so much for inviting for the talk. It's been very well organized. We had a wonderful session since morning. I'm Dr. Sanjay. I'm from Bangalore, Apollo Hospital. Today I'll be talking about cytokine storm, in particularly in sepsis, and how immunomodulation can help us in having better outcomes. Before we actually start off with cytokine storm, I would like to take you through some of the basic definitions. So infection basically is lodgement and multiplication of pathological microbes, which can be virus, bacteria, or fungi. The same with the parasite is called as infestation. So sepsis is basically a dysregulated host immune response secondary to an infection, which leads to life-threatening organ dysfunction, which in turn leads to an increased mortality. In the last 2.5 decades, all of us know that the mortality in sepsis has significantly come down, probably from 45-50% to about 30%, thanks to the early goal-directed therapies and universal application of the early goal-directed therapies. Now, coming to the cytokine storm per se, it's recently identified in the community of critical care, though it was first mentioned in the year 1990s in probably the transplant medicine journals. First in the graft versus host disease, that is the first time it was mentioned in the journals, and probably in 2000s, that is when the infectious disease, they started mentioning about cytokine storm. From the last decade or so, the critical care has started mentioning about cytokine storm. Probably the last 3-4 years during the COVID, we started talking more about the cytokine storm. We don't have a universally globally accepted definition of cytokine storm, but this is probably the best I could find. The 3 components of cytokine storm is hypercytokinemia, excessive systemic inflammatory response, and disproportionate mods. Now, the reason why we are talking about the cytokine storm is the mortality in sepsis is about 30%. Despite following the early goal-directed therapy, the mortality is predominantly because of the cytokine storm per se. So the question is, by modifying or immunomodulating the cytokine storm, do we have any benefit in reducing the mortality benefit? That will be the focus of discussion. The basic of how the body identifies and treats the infection. The human bodies are naturally quite resistant to infections. Thanks to the natural barriers and immune system, though we keep coming across a lot of infecting pathogens on every day basis, it's rare that we all catch up infections. The immune system basically consists of cellular and humoral immunities. We have innate and adaptive immune systems. Let's presume that an infective agent has bypassed the natural barrier system and it has landed up in a body. The body identifies these pathogens through pathogen-associated molecular patterns. PAMs are basically highly conservative structures for all these organisms. For example, the virus, the body recognizes through the DNAs and the RNAs. The gram-negative organism, the body recognizes through lipopolysaccharide antigens which are present on the surface of the gram-negative bacteria. The same with gram-positive, they have lipoteichoic acid or the peptidoglycan. So when these things enter into the tissue, the body, through the help of pathogen-recognizing receptors, it identifies it. So the union of PAMs and the PRRs leads to a series of transcellular signaling, which in turn causes an inflammatory or an immune response, which includes the activation of local immune cells, for example, the dendritic cells or the tissue macrophages. There is an activation of local inflammation and release of chemical mediators, importantly the cytokines. There's also activation of complement system. The activation and release of cytokines and complements will cause recruitment of the innate immune cells, for example, neutrophils, the monocytes, the eosinophils, and the basophils, which are there in the circulation, to recruit from the circulation to the site of infection. There is also endothelial cell modification, which makes the cells easy to come into the tissue spaces. Finally, when you have all the immune cells in the proper space, it helps in killing the microbes, and it kind of curbs the infection. The immunity doesn't stop there; it also progresses, presents these antigens to the next level of cells, or the adaptive immunity, the T cells and the B cells. So in case if there is another infection, or in the next few days or few weeks, if there's another infection, the body is already ready to fight this kind of an infection. The next slide, I'll just show you about the interaction between the PAMs and PRRs. The viruses are recognized by three major classes of PAMs, which is glycoprotein, DNA, or RNA. The PRRs are basically cellular and extracellular. The cellular, these are the receptors which are present on the surface of the cells, which is there in the innate immune cells like dendritic cells, macrophages, and also on the other immune cells like neutrophils. The toll-like receptors are the predominant one. The toll-like receptors 1, 2, and 4 are the most commonest ones, though we have toll-like receptors 1 to 10. The glycoprotein on the virus surface is recognized by TLR 2 and 4. The RNA DNA can be recognized by TLR 9 and 3. There are other transcellular or the cell surface PRRs like rod receptors and NIG receptors. On the gram-positive, as I already told you, the DNA or the lipoprotein or the peptidoglycan or the lipoteichoic acid recognized by toll-like receptor 2 and also NOD and NALP receptors. The gram-negative predominantly through the lipopolysaccharide or the flagellin receptors through TLR receptors. With the fungus, we commonly keep assaying the galactomannan and the beta-D glucons. These are again present on the surface of fungus. They act as PRRs and recognized through TLR2 and TLR4. The protozoans, again, they have surface protein GPA anchors recognized through TLR2 and 4. So this is the picture which depicts all the things that happens in the local tissue when there is an infection. If you can see, when there is a pathological organism, the PAMs, DAMS is basically damage-associated molecular patterns. Obviously, when the infection is there in the tissue, it can cause damage to the the cells which is surrounding, and that releases certain cellular byproducts or like the DNA of the cell. These things interact with the toll-like receptors, which causes activation and release of the cytokines and activation of chemokines. These in turn causes endothelial changes, which causes like endothelial cell contraction, opening up of the interendothelial spaces. There's also expression of CAM molecules on endothelial cells. What it does is, the circulating immune cells which are there in the circulation, like neutrophils and the monocytes, they bring these cells to the endothelium. There is an attachment, activation. There is conformational change in the cell. It induces diapedesis and movement of this immune cells into the interstitial space. So the cells which are supposed to come and kill the microbes are there in the right space. In the process, it also causes a lot of capillary leak. So the plasma which is there in the circulation leaks into the interstitial space. Now the interstitial hydrostatic pressure increases. So now the microcirculatory dysfunction starts setting in. The organ perfusion pressure reduces, and this leads to organ dysfunctions. Also, that when there is a complement activation and also there is an activation of monocytes, there is release of procoagulant factors, which in turn causes activation of coagulation pathway, which leads to microvascular clotting. There are many other things which happens, which probably I'll discuss a little later on. Again, increasing the tissue hydrostatic pressure and microvascular coagulation finally compromises the tissue circulation. It reduces the organ perfusion pressure. This leads to increased incidence of multi-organ dysfunction. So all in all, when there is increased inflammation, the same thing when it spreads to the systemic circulation, because of the increased cytokines, endothelial dysfunction, and activation of procoagulant pathways leads to multi-organ dysfunction. So the thing is, how do we control all this to have mortality benefit in sepsis and cytokine storm? A simple slide again, a local inflammation is compromised by 5 cardinal components, Kaller, Rubert, Dollar, tumor, and functional SEO. When this inflammatory response or the cytokines leaks into the circulation because of overproduction of cytokines at the site of injury, or because the infection load is quite high that it starts entering into the circulation, there is an excessive inflammatory surge in the circulation. This leads to a same thing systemically called as systemic inflammatory response. Quite commonly we recognize it by the 4 components: hyperthermia or hypothermia, leukocytosis or leukopenia, hypotension, and tachycardia. When we look at the time-scaled immune response, in the first 2 or 3 days, it's the pro-inflammatory state which predominates. Though both of them get activated at the same time, first 2 or 3 days, it is predominantly pro-inflammatory state. The basic point is the body is trying to fight off the infection. In the later stages, it is anti-inflammatory response. Again, once the infection is all curbed, the body wants to step down the inflammation so that the body can start healing from the damage which has happened during the process. The outcome influencer in sepsis, it probably can be divided into 3 different phases: the pre-sepsis, sepsis, and the post-sepsis phase. In the pre-sepsis phase, it depends obviously on the agent and host factors. The agent factors depends on the pathogen infectivity, virulence, resistance, the site of infection, and the inoculum dose. In the host factors, it probably depends on the comorbidities, age, genetic and epigenetic of the patients, and also the microbiome. All in all, it basically depicts the immune status of this particular individual. During the phase of inflammation or sepsis, there is an immune homeostasis. As I showed you in the previous slide, there is a balance between the pro-inflammatory and anti-inflammatory. When all the things are going fine, you have a better outcome. But unfortunately, the body doesn't have a greater control of managing those things. Very often in sepsis, there is either hyperinflammation or there is immunosuppression. And again, in the time scales, the body wants the inflammation in the early phase, wants the immunosuppression or anti-inflammatory thing in the later phase. Hyperinflammation causes more organ dysfunction and mortality. Immunosuppression predisposes the person to catch more infections and increase the mortality. And the third phase will be the post-sepsis. After all the insult, the body wants to recover in terms of physical, physiological, metabolical, and immunological status, come back to the baseline status. If this thing is delayed, again, this leads to a lot of secondary infections, critical illness, post-sepsis syndrome, and increased death post-septic phase. These are all the cytokines reacting with their particular receptors, which in turn leads to endothelial dysfunction, inflammatory response, and increased capillary permeability and activation of coagulation pathway, which will come a little later. Now the cytokines per se, these are small proteins. They help in interaction between the immune cells. They act as intercellular signaling and communication. It can be autocrine, paracrine, or endocrine kind of interaction. Basically, cytokine helps in immune and inflammatory response, cellular proliferation and differentiation of the immune cells, and also the healing. regulation of angiogenesis, and repair and healing of the tissues. There are 5 major classes of cytokines: interferons, interleukins, chemokines, colony-stimulating factor, and tumor necrosis factor. Interferons, they help in regulation of innate immunity. They are basically concerned with the innate immunity. They have antiviral properties. They also have anti-proliferative properties. Interleukins, basically they help in growth and differentiation of leukocytes. They are very strong pro-inflammatory cytokines. Chemokines, they help in chemotaxis of the immune cells, the movement of the immune cells to the site of infection. Again, they are very strong pro-inflammatory cytokine. Colony-stimulating factor basically helps in stimulation of progenitor cells so they can differentiate and proliferate into the neutrophils or macrophages. Tumor necrosis factor, a very strong pro-inflammatory, probably the strongest of pro-inflammatory cytokines. They activate the cytotoxic T lymphocytes, and there are a few more functions. As you can see, interferons, it interferes with the viral replication. It's part of the innate immunity. It is a very strong pro-inflammatory cytokine. It is secreted from the virus-infected cells. When the virus enters into the tissue macrophage or the dendritic cells, they cause release of interferons. Once the interferons are released, they bind to the interferon receptors. There is a series of intracellular communication through JAK-STAT pathway. This induces interferon-induced antiviral proteins. These proteins prevent the replication of virus-infected cells, also prevent they downregulate the receptors through which the virus enters into the cells. They cause activation of new natural killer cells and probably kill the cells which are infected with virus. There are 3 major classes: interferon 1, 2, and 3. Interferon 1 again has interferon alpha, beta, omega, epsilon, and kappa. Interferon alpha and beta are the predominant one. They are encoded on chromosome number 9, and they are secreted from leukocytes, macrophages, endothelial cells, and fibroblasts. Interferon 2 is encoded on chromosome number 12. Again, interferon, it's called as interferon gamma. Interferon 3 is interferon lambda. The therapeutic uses of interferons, which is clinically used, is in treatment of hepatitis B, hepatitis C, multiple sclerosis, leukemias, and lymphomas. Interleukins, basically, these are the cytokines which kind of, the body uses it for intercellular leukocytic communication. There are at least 30 plus of interleukins. Most of these interleukins are pro-inflammatory in nature. Very few of them are anti-inflammatory. Interleukin 10 and probably interleukin 6 in a little later stage can work as anti-inflammatory leukocyte. These interleukins can also help in maturation of, or it helps in adaptive immunity in the maturation of T helper cell. When the antigen presenting cell like a dendritic cell or a lymphoid cell, when it engulfs this bacteria, digests and processes the antigen, when it processes the antigen and presents it to a major, through a major histocompatible complex to CD T helper 0, it can undergo maturation into either T helper cell 1, 2, 9, 17, or it can become a cytotoxic CD8 T cell. If it matures into a T helper cell 1, in the presence of interleukin 2 and interferon gamma, it causes stimulation of macrophages and dendritic cells, which again mobilizes the cells to the site of infection and helps in treating the infection. If it matures into T helper cell 2 in the presence of interleukin 4, 5, and 13, it mobilizes eosinophils and basophils, predominantly involved in allergic and fighting the parasitic infestations. If it becomes T helper cell 9 in the presence of interleukin 9, 10, causes activation of mast cells. T helper cell 17, which is again very predominant one, it causes recruitment of neutrophils in the presence of interleukin 17, 21, and 22. Neutrophils, again, in the fighting of most of our bacterial infections, you need T helper cell 17. Cytotoxic T lymphocytes, they themselves are active, they are cytotoxic. They get stimulated when there is a viral infection, they kill the viral infected cells. Most of the times it activates the pro-inflammatory pathway. It also can stimulate or activate the anti-inflammatory pathway by activation of T regulator cells, which is an anti-inflammatory cell in the presence of interleukin 6 and interleukin 23. In the presence of interleukin 10 and tumor growth factor beta, it kind of steps down the inflammation and curbs the inflammation. So all this initial activation of pro-inflammatory cytokine usually happens in the first 2-3 days. In the later phases, it is anti-inflammatory upregulation of T regulator cells. Chemokines, basically chemoattractant for immune cells. Based on the chemical structure, basically there are 4 different types, but there are at least 30 plus of chemokines. Based on the cysteine molecules which are present at the end terminal and their relative arrangement, they can be classified as C, CC, CXC and CX3C. Basically helps in mobilization of the immune cells to the site of infection. As explained earlier also, the chemokines helps in movement of this neutrophil from the intravascular space to the site of infection. So there is a series of things. There is upregulation of selectins and CAMs. There is margination, rolling, then there is a structural change in the neutrophils, diapedesis, and it comes to the interstitial space. Similarly, with the neutrophils, as the time goes on, it also causes mobilization of macrophages, monocytes, and T cells. The overall function of cytokines, there are 2 major functions. One is a pro-inflammatory cytokine. Also, if the person is not in an infection, helps in maintenance of homeostasis like the Th1 and Th2 development, lymphoid organ development, wound healing. Colony-stimulating factor, they help in amplification of the inflammatory cascade. We have 2 major classes, granular and macrophage colony-stimulating factors. Helps in amplification by increasing the cellular immunity. The tumor necrosis factor, again, it's a very strong pro-inflammatory cytokine secreted from the pathogen, which are secreted from the dendritic cells or the macrophages. Once the infective agent enters into these cells, they cause upregulation of tumor necrosis factor genes, and there is release of TNF. Now, this TNF is a very strong pro-inflammatory cytokine. As in the previous figure, previous slide, it helps in mobilization of the inflammatory cells to that space, and this causes the killing of the microbes by both oxidative and non-oxidative mechanisms. They also recognize the cancer cells and induce apoptosis by upregulation of apoptosis genes like caspases. They also cause activation of dendritic cells and the activation of Th cells and activation of production of T cells. If the TNF alpha persists for a very long time, it causes continuous activation of macrophages, especially in a chronic infection. You can see that continuous activation of macrophages leads to granulomas. So this is a slide that represents the whole cytokine storm. Triggers can be many. What I'm talking about is sepsis-induced cytokine storm. The same cytokine storm can happen with many other things like CAR T-cell therapy, which are used in malignancies. It can happen with cancers. It can happen with monogenic autoimmune diseases. So this causes release of pro and anti-inflammatory cytokines. The first ones to come is interleukin-1, interleukin-8 tumor necrosis factor, which in turn again activates many other pathways to cause release of interferon gamma and interleukin-6. So this is a slide that represents the homeostasis between the immune system. If there is a hyperinflammatory response, that causes cytokine storm. If there is activation of anti-inflammatory cytokines quite a lot, then it causes immunosuppression and infections. The endothelial dysfunction or the capillary leak syndrome, the increased tumor necrosis factor during the process of cytokine storm, and the anaphylatoxins which are released because of the activation of the complement system like C3, 4, and 5. And there is increased production of vascular endothelial growth factor and reduction in the receptors of vascular endothelial growth factors. And there is damage to the endothelial glycocalyx because of multiple factors. All in all, it causes leaking of capillaries and movement of plasma into interstitial space, rising hydrostatic pressure and reduced organ perfusion. The coagulation abnormalities, it induces a procoagulant state initially. The activated monocytes releases the tissue factor, which in turn activates the extrinsic pathway. The endothelial dysfunction itself causes activation of the coagulation pathway. There is decreased antithrombin, tissue factor pathway inhibitor, protein C, increased heparinases and plasminogen activator inhibitor, increased von Willebrand factor multimers, and the low levels of ADAMs. All in all, it induces microvascular thrombosis, which is also called as immunothrombosis, microcirculatory dysfunction, and MODS. So the pathological thrombus and consumptive coagulopathy, we commonly call it as DIC or otherwise sepsis-induced coagulopathy. So this was about the cytokine storm and the various checkpoints. Having gone through all this, let's see if there are focus of immunomodulation targets. There are many targets for immunomodulation, but very few of them are actually clinically translated into a clinical benefit. The lipopolysaccharide interactions, the inflammatory mediators, the endothelial dysfunction, cytotoxin or endotoxin removal, immunostimulation, steroids, nutrition, antioxidants, and others. Coming to the lipopolysaccharide interactions, as we saw in the initial slide, the interaction between the PAMs and the PRRs leads to a series of intracellular signaling, which in turn causes the activation of the cytokine pathway. IC14 is basically a monoclonal antibody against the CD14 molecules, which is there in the it acts as a PAM. The antibody, which is directed against the PAM, it kind of controls or downregulates the activation of cytokine storm. The studies are still ongoing. Only the preliminary studies have shown some promise, but the major studies have not come up to say that this is probably beneficial. The bacterial permeability increasing proteins has multitude of function again. It can act as an antitoxin. Again, it can also downregulate the cells which are involved in the pro-inflammatory state. Again, the studies are very preliminary. The major studies have not come saying that it can be routinely used. Anti-lipopolysaccharide antibody, again, the lipopolysaccharide on the gram-negative bacteria serves as a major pathogen-associated molecular pattern. If there is a very high dose of gram-negative sepsis, or probably 2-3 days down the line when the bacteria are lysing and you still have a lot of lipopolysaccharides circulating in the circulation, anti-lipopolysaccharide antibody probably binds to them and probably helps in curbing down the inflammation. This is the logic why anti-lipopolysaccharide antibody was used. Again, phase 1, phase 2 trials, some benefit, but major benefit is still to be proven. The lipoproteins, erituran is another drug which acts on TL4 receptors. TAC242 is another drug which acts on TL4 receptors. Both of them have no benefit. TREMS antibody again didn't have any benefit. All these are basically blocking the interaction between the PAMs and PRRs, especially in little later stages of inflammation. The inflammatory mediators per se, TNF antibodies and the receptors. The anti-TNF antibodies, there were a couple of studies. One study which was meta-analysis of about 17 studies, also smaller studies. About 7,000, 8,000 patients they analyzed, and they said probably there is a small reduction in 28-day mortality. But again, they are trying to do a larger study to see if it can really translate, because TNF is a very strong inflammatory mediator. There's one study with a 2,000 patient population which said probably there's a marginal benefit with 28-day mortality. So the studies are still ongoing. The macrophage inhibiting factors again show some promise, works similar to that of a steroid, but again there are no major studies to support the use on a regular basis. HMG-B1 antibody, again similar way. Interleukin-1 receptor antibodies, there were few studies. The popular drug is anakinra. There was one retrospective analysis with anakinra. Patients who were already on anakinra who had sepsis probably had better outcomes. So the next study was a prospective study with around 500 patients. The same thing, when the IL-6 levels were high, they used IL-1 receptor antagonist anakinra. They had some mortality benefit, so they are planning to do a bigger study on that. IL-6 receptor inhibitors, we have used tocilizumab in the time of COVID. There were mixed results. The studies were also not very conclusive. When we look at the meta-analysis, probably the selected set of patients probably had benefit, especially in the little later stages of infection. The recombinant IL-10 antibodies had no benefit. Platelet activating factor receptor antagonists again had no benefit. Heparin, because we know that in the sepsis there is, in the cytokine storm, it's a procoagulant state. Heparin in a therapeutic dose, either as an infusion or intermediate dose. This was studied. Heptrace trial proved negative, so we don't have, the study says that we don't have to use therapeutic dose of heparin, but the DVT prophylaxis dose can be continued. Albumin helps in maintaining the endothelial glycocalyx, especially if you're using it as isotonic albumin for a fluid resuscitation. Albumin can be beneficial. The other classes of drugs like antithrombin, tissue factor pathway inhibitor, activated protein C, recombinant thrombomodulin R23, selectin, they did not have any benefit, so they're out of practice. The cytokine and endotoxin removal. The cytosorb initially proved promising, but cytosorb has no benefit, so it doesn't help in reducing the cytokine storm, or it doesn't have the mortality benefit. Probably a set of surgical, post-surgical patients who have cytokine storm used early may have some benefit. So the plasma exchange, the therapeutic plasma exchange has a proven benefit now. The plasma exchange, basically it helps in removing the endotoxin, removing the cytokines from the plasma, also replacing some of the factors which are necessary for coagulation, taking away the heparinases, replacing Adams 13, it is proven beneficial. It helps in reducing the cytokine storm, also helps in preventing the sepsis-induced coagulopathy. So plasma exchange in this category has mortality benefit. The polymyxin B filters, coupled plasma adsorption filters, CRRT and hemofiltration have no benefit. Immunostimulation, all this while we were talking about suppressing the hyperinflammatory state, but in the later phases when there is the immunosuppression, is there a role for immunostimulation? Because that is the time when the patient, when the people catch secondary infections. So the immunostimulation drugs, we have IVIG. IVIG, again we have very mixed results. Polyclonal IVIG could be beneficial, but it is not statistically proven. Interleukin 7 and 15, which are slightly lesser potent pro-inflammatory cytokines compared to interleukin 1, 2, 8 and 12. So again, in the later phases, there are some results to say that it could be beneficial. The colony-stimulating factors and interferon gamma have no benefit in immunostimulation during the immunosuppressive phase of cytokine storm. The nutrition and antioxidants. The early enteral nutrition, just like any other sick patient in ICU, could be beneficial. The glycemic control, the standard conventional control of 110 to 180 could be beneficial. The immunonutrition per se using glutamine, polyunsaturated fatty acids or probiotics had no benefit. Selenium as an antioxidant again did not have benefit. So early enteral nutrition and glycemic control helps in faster recovery. The other immunomodulators, steroids. Steroids in sepsis only if somebody is refractory to septic, somebody is having a refractory shock even after fluid resuscitation and they still require higher dose of Prasas. Only for the reversal of shock probably has benefit, but to suppress the inflammation and have a mortality benefit, steroids are not beneficial. In COVID-19, obviously dexamethasone showed the benefit. The macrolide and tetracycline antibodies have favorable immunomodulating properties, especially somebody who is having cystic fibrosis or they have bronchiectasis. The use of azithromycin and clarithromycin can have favorable immunomodulatory effects. The tetracycline, again, very interesting. There was one study with patient was put on a tetracycline for a possible tropical infection, and they turned out to be dengue positive. And those set of patients with use of tetracycline apparently had lesser cytokine storm. Thiamine and vitamin C, no conclusive evidence. The latest trials with citrus, vitamins and Lovett study, they have proven that they don't have to be used for immunomodulation. Ulnastatin, probably in acute severe pancreatitis, 3-4 days, slightly larger dose could be useful. Alpha-thymosin probably has favorable immunomodulating properties. Smaller studies have shown them. It induces the adaptive immunity and kind of suppresses the pro-inflammatory cells. The anti-C5a antibody, which can activate the coagulation pathway and causes microvascular thrombosis. It was a small study with 3 different doses of C5a antibody. The one with a larger dose of C5a antibody has shown some promise, so they're planning to continue the study. The bioactive adenomodulin antibodies. This adenomodulin molecule is secreted from the endothelial cells. As long as they are there in the intravascular compartment, they kind of reduce the capillary leak state. But unfortunately, these molecules will leak into the interstitium. Once they reach the interstitium, their activity changes. They cause more of capillary leak. So the bioactive adenomodulin antibody binds to this adenomodulin. It prevents the leakage of this adenomodulin to the interstitial space. So the antibodies could be beneficial, so they are studying that. The beta blockers, because a shock-induced endotheliopathy is a known entity. Whenever there is a shock, there is catecholamine surge. They act on the endothelium, cause more of endothelial dysfunction. A small study using esmolol infusion probably had favorable outcome in reducing the endothelial dysfunction, also in reducing the cardiodynamic factors. So beta blockers in a selected patients who doesn't have too much of a shock could be beneficial. So going through all this, we still don't have very strong recommendation or the magical drugs to modulate the immunosuppression. Probably the factors which could affect going forward would be to identify the trigger of cytokine storm. So early addressal of cytokine storm or the trigger of cytokine storm. The magnitude of cytokine storm, more the magnitude of the cytokine storm, more will be the catastrophe. The trajectory, when, as I showed you in the previous slide, in the initial phase has pro-inflammatory cytokine. The later stage it has anti-inflammatory cytokines. So the trajectory is also important. So addressing the right trigger at the right time probably could make a difference. In the morning, we were also talking about artificial intelligence, machine learning. There is a lot of things which is going on in the molecular biology as well. With genotyping and phenotyping, probably we can have personalized therapy or we can have precision medicine. We can also identify and analyze more about the agent and host specific interactions. Probably that could give us better results. So the genomics, proteomics, transcriptomics, and metabolomics, this is what the people are looking at to have better drugs. And also to identify people who can actually benefit with immunomodulation cytokine storm, we need a practical and clinically feasible profiling. You need markers to say that this patient probably could be immunomodulated in sepsis. So all these things have to be kept in mind. Probably going forward in the next few years, we may have some meaningful therapies to curb the cytokine storm in sepsis. Thank you.
Thank you. Ajay, can I ask one question? What is your take on compensatory anti-inflammatory syndrome? And how do you feel these scars affect the mortality and the morbidity of somebody?
So most of the cytokine storm related studies have been on the anti-inflammatory cytokines. Only one slide, as I showed you, the increased chance of secondary infections and candidemia also will affect the outcomes. One of the slides when I was showing you sepsis, pre-sepsis, sepsis, and post-sepsis phase, the outcomes also depends on the post-sepsis phase when the anti-inflammatory cytokines or the anti-inflammatory status, kind of up-mounted. They are prone for secondary bacterial infections and candidemia. The studies so far is regarding use of interleukin 7 and interleukin 15. In that stage, the interleukins are totally down-regulated. They are not as strong as interleukin 1, 2, 8, or 12. They want to use a smaller, probably lesser potent immunostimulating drugs like 7 and 15. So the smaller studies have shown some benefit. So they're focusing if that can be made use of. There is also down-regulation of interferons in that stage, which is a very potent interferon. And interferons have been used in the treatment of other infections like hepatitis B, C, and lymphomas, leukemias. They've used that in the post-inflammatory, post-infectious CAR state to reduce the infections. Again, there was no benefit. So as of now, what we have is probably interleukin 7, interleukin 15, and yeah.
Thank you.
The last slide I was showing you about the trigger, magnitude, and trajectory of treating the cytokine storm. Apparently, the benefits of curbing the cytokine storm in other triggers like CAR T-cell related therapy, leukemias, lymphomas, and monogenic disorders like HLH. The therapies are, the treating cytokine storm in those patients are much more satisfying because they don't have multitude of things going on. Here in infection, the problem is when you try to curb the pro-inflammatory state, you lead to an anti-inflammatory state and you lead to a higher chance of secondary infection or flaring up of the primary infection itself. Whereas in those cases, when you're trying to treat the cytokine storm, the pathology is different. You can still accommodate or you can accept the immunosuppressive state in that phase as long as there is no infection. The problem here in infection-related cytokine storm is you try to overdo something, you actually counterdo the primary disease itself. So in other diseases, probably there are better ways of treating. I mean, it's more satisfying treating a cytokine storm rather than sepsis-related cytokine storm.
I would like to call Dr. Gunada Padi to felicitate Dr. Sanjay. Now, I would like to invite Dr. B.D. Bande. He is HOD Critical Care Medicine at Noble Hospital, Pune, to take us through the spectrum of obstetric emergencies that we encounter day to day. Thank you.
till it comes. So good evening to all. Thank once again to Akshay and the whole team of Apollo here for giving opportunity to be with you all here. And thank to your patience that till last lecture everybody is around. Coming back to basics, this particular topic is titled Obstetric Emergencies. Obstetric emergencies is one of the commonest things because we have had discussion on very futuristic topic just before, and now coming back to basics, as I said, very challenging issue to all of us at peripheral as well as urban level. Obstetric emergencies take major share of any intensive care unit, about 5 to 10%. So discussions will go on these topics, and obviously the hemorrhagic shock being the most common, going to liver failure and other things. So postpartum hemorrhage is one of the commoner to the hemorrhage category, where commonly you have a blood loss to the tune of only 500 in vaginal delivery, but in emergency cesarean section it can go up to 3000 ml, and that really creates a problem. Now common causes are also antepartum as well as postpartum. There's a little bit change in demography of the etiology because abruption used to be a very common cause. Now we have so many cases of acrita, percrita, increta, etc. because of obvious reasons of having delayed kind of conceptions and terminations, etc. In postpartum, of course, uterine atony leads the list, but a little change in that we have coagulopathies and pregnancies coming together. In that, by that I mean there are patients who are coming with dengue fever. There are patients with hepatitis A and E. E being, I think, coming as an epidemic slowly, will also have number of, more number of patients coming with pregnancy. And besides that, there are genetic coagulopathies, etc. But we'll not go into details of that. I'll straight go to the case description, which will take us through the steps and challenges what we face. So, 22 years, primary gravida, PI diagnosed at 23 weeks on treatment, but ultrasound showed intrauterine fetal demise. Pregnancy termination done, and there was a PV bleed and shock, and the patient was shifted to the institution, accompanied by the doctor. Accompanied by doctor underlined for the simple reason that anybody transferring a patient from anywhere has the responsibility to take that patient safely to the other place where the patient is getting referred, and this is a Supreme Court mandate. So just keep in mind that if you are transferring a patient, it's your responsibility to take the patient safely. In emergency room, of course, it was circulatory crash there and needed resuscitation, practically intubated, ventilated, cross-match, etc. was sent, and some colloid she received. There was a pressure requirement and shifted to ICU. Now, shock of BP of 40 or something is not only the blood pressure, but this is a huge continuum which goes wrong inside the body. Hypovolemia causes impaired perfusion, tissue injury, and of course mediator release. So many mediators we have now learnt about. And of course it becomes a multi-system disorder, and what we see as the hypertension is just the tip of the iceberg, and there are so many things underlying inside which we get reflections of at some point of time. Unless you look for it, may not be very evident. So we have to look for that there are metabolic problems, and practically each system may get affected. Fondly it was called a triad of death, and one more component making it quadrant is hypocalcemia, which has always been there but was not included in this, and this is actually surely a triad of death: acidosis, coagulopathy, and hypothermia, unless we have very, very aggressive treatments which we'll try to go through. Now our simple goals are to have a blood pressure around 80 to 100, have a good perfusion and achieve a good oxygenation and provide enough oxygen to the tissue. And of course there are some additional problems because there will be some coagulation alteration, there will be some metabolic problems, and the temperature changes, and we have to correct all of them at a time. So to have aggressive management in the emergency itself, we need to have a 2 large bore IV cannulas put in as early as possible, and if possible central line, if you are proficient enough in that rush period. You have to have some some devices to have a fast infusion, like these pressure bags we commonly keep there, and that is the commonest to be used. And there should be some warming mechanism in the emergency itself, because to have about 1, 2, 3, 4 liters of fluid going in a very short time, if the fluids are not warm, then that itself causes severe hypothermia, and patient might recover from shock but will die of hypothermia and related metabolic and coagulopathic changes. So what happens once you give large volume of crystalloids, many things go wrong. Basically, there's a dilution, hematocrit obviously goes down, and of course coagulopathy due to dilution itself is there. Hypothermia also occurs, and besides that, there are some chemical changes. If you give large volumes of sodium chloride, obviously chloride being much higher in content as compared to what normally serum has, it leads to hypochloremic acidosis. People have started using these balanced salt solutions, but there is no scientific evidence as yet that they are going to be very, very superior to the ringer lactate or normosaline which you are going to use. So there is no clear-cut evidence that these solutions are better. Besides that, they are also costly. So in the emergency unit, the management was done as follows. The temperature was low. Patient had fixed dilated pupils called periphery. Severe shock. All these cannulations were done, arterial line as well as central venous line, and you can look at the hemogram and other reports which are received. Counts on higher side, platelets going down, altered coagulation already, and VBG showing absolutely incompatible blood gas picture at this point in time itself. And patients obviously received some blood components here, but was in severe shock, and she needed double vasopressor support. Now, invasive BP monitoring is very essential at this point, because otherwise, in a very vasoconstricted patient, it's very difficult to have a very optimum vasopressor infusions going on. We often overshoot, and it causes further vasoconstriction leading to perfusion failure. So even if you are improving blood pressure, but you are not precise and optimum enough, you might have overshoot, and that can be counterproductive. So intraarterial line is very must. Adequate ventilation in a metabolically altered acidotic environment, you have to have adequate ventilation. So in-time support of ventilation is very essential. You may go ahead with investigations and management of shock with currently available point of care, ultrasound, etc. as in detail been dealt with. So I will not go into that indices of this thing, but it is very useful. It might help you to optimize the load of the volume which you are going to give, because otherwise overshooting is almost certain, and most of these patients land up into pulmonary congestion at the point, because later on there is a renal failure, etc. So optimizing with additional tools now available in terms of ultrasound should be utilized right in the emergency and subsequently in operation theatre as well as intensive care unit. Now, most important one which keeps on bothering continuously during all this process is coagulation monitoring, because besides these simple tests, up to thromboelastogram if available, can help you to optimize what component you need to give so that you don't overshoot regarding any one of them. So these typical patterns are there, not in the purview of this lecture, but it can help us to have definite component selection as to which will be appropriate at that point of time. And mostly we start with 1-1-1 because that time we don't have any clear-cut idea as to how much to give, but we have to have continuous monitoring going on, at least by the simple coagulation test which we have. And starting with that, in a rather jumpstart manner. So as early as possible, instead of giving crystalloids and colloids, if we have by chance blood components available, that will be the best. But anyway, since the time patient comes, it takes at least 30 to 40 minutes to have these components being available after cross-matching, etc. So as early as possible, blood components should be given and then monitored for all the components like RBC, coagulation, etc. The metabolic changes are also important because massive transfusion often lead to hypocalcemia, and hypocalcemia because of cytotoxicity can itself be killer. Hyperkalemia because of heavy potassium content of the transfused blood may also be the matter of concern in due course, because it will need immediate treatment if detected. So monitoring electrolytes besides having all other monitoring is also essential. Hypothermia, I don't want to emphasize, but this is neglected, and that's why the emphasis is needed, because it does have effects on metabolic functions of the cells as well as arrhythmias, which can be killers, and coagulopathy, which can lead to further bleeding. So we have a lot of devices now. Such indigenous devices are also available. This is just a warming cabinet. Then we have inline heating mechanisms in terms of these. Then There are hot air blowers which are there. So all these should be there, mattresses as well. So unless you have these right in emergency carried to operation theatre and OT, while the patient is being treated continuously, the hypothermia may be inevitable. And these are neglected, and that's why I'm emphasizing that all these equipments needed to have warming mechanism in place. That will be essential. We do have competing priorities, but everything is one because it has to be simultaneous. There is nothing like first, second, or third, and we have to have all the efforts going in all the directions at a time. So you need a manpower, you need a teamwork for that. These are the guidelines WHO, they are commonly available, and the recent review in 2023, they just added one component, that is objective assessment of blood loss, which has never been mentioned, but a lot of emphasis on that. Somehow I just went through that. So they have some calibrated drips which will be coming in, probably yet not available. But rest of the recommendations are, I think they are same. We have been using oxytocin, ergometrin, and prostaglandins. Isotonic crystalloids in presence of colloids. Colloids are of course not used because we know the side effects of colloids, because starches have more problem in causing coagulopathy, and gelatins have some allergic reactions. So there are limitations, but if you don't have anything, we are still using it. It's not completely banned. Tranexamic acid was definitely proved to be useful in woman trial, and 1 gram IV given if the bleeding has not stopped, and it has a typical action. We know that it is antifibrinolytic. Rest of the management goes as per the advice, and this has been, I think, over years or last few decades it's been going on. So intrauterine balloon tampon or temporizing measures in terms of uterine compression, vaginal pack, aortic compression, and ultimately uterine artery embolization also is now available in some institutes where there is a cath lab easily functioning, and intervention radiology is available. So this also can be used, but there are a lot of limitations, pros and cons. But best is to have a decision of hysterectomy being taken at appropriate time, because often there is a delay in taking this decision on various grounds. Relatives are not ready, consent is not being given, and center may not be equipped with transfusions needed, or even expertise for that matter, professional expertise. This is in there, we will not be talking much about, but this have importance preoperatively, and even to have a therapeutic option to stop the bleeding. This particular patient obviously went for life-saving hysterectomy, and the consent has to be taken by a team who is competent enough, because junior level consent being not acceptable to relatives, in the sense that they later on they have a complaint, and somebody very senior, that to team of 2-3 people, including anesthetist, surgeon, and maybe intensivist, have to have together consent to be given as early as possible, because any delay further, it can be costly there. So patient is quite unstable at this point of hemodynamics as well as metabolic, hypothermia, etc. So it's a life-saving surgery. All these said management has to continue, including prevention of hypothermia at least. Surgical options delay can be a problem, but the fitness will be argued, but there's nothing like fitness here. It's life-saving surgery, and you have to just have appropriate documentation to be legally very clear, because quite a few cases have come up in legal issues have been there. Obviously, because young patients, though there is a life-threatening bleeding, relatives sometimes fail to understand the gravity of the problem, and the legal cases keep on happening. Shifting is actually neglected. The special point to mention is because it is given to the juniors, but that is the time when a lot of mishaps have occurred, and it is more challenging than managing a case in emergency or ICU bed or even in OT table. Shifting has to be taken seriously, and somebody senior has to accompany and guide, and obviously the monitoring, ventilation, everything has to continue with in advance information to operation theatre. Intraoperative cell salvage is coming in at some places, it will be there, and it is one of the venues available in case we have to use. Regarding anesthesia, obviously this patient is in severe shock, and there is no question of any regional anesthesia here on the local infiltration with usual cardiostable general anesthesia. Chosen this particular patient. It's a little older case, so these were the agents that time being used. Uterus was quite flabby, and there was no bleeding tendency, but infusions and transfusions continued. Once the uterus was out, obviously hemodynamic starts improving with all your efforts. Increased GTCO2 at the same minute ventilation indicate that the perfusion is improving at tissue level, and it's very significant. There is no bleeding tendency, it can happen subsequently. Post-operative care is typically, obviously, we have to have other avenues to be looked into, like antibiotics and DVT prophylaxis, etc. The patients obviously have problems. They definitely have coagulopathy persistent, metabolic improvement is there, renal failure ensues because of acute tubular necrosis due to shock. The overload can be there, that needs to be treated, and obviously appropriate ventilatory strategies have to be in place. She had a renal failure, which was obviously subsequently done. This is the typical blood product list. You can see the second last column, which so many components are needed for this particular patient if you go into the aggressive management of this particular patient. So gradually improved and ultimately survived. So what it needs is a very aggressive management right from the beginning, that is emergency, and even during the transfer if you get the previous call from the referring hospital. Coming to second major problem is PIH. Obviously it's another common problem. Systolic blood pressure is supposed to be killer in this patient due to intracranial hemorrhages. So unless there is a prompt control or aggressive management, again there can be a lot of problems. The aims obviously are to have confirmation of diagnosis. There can be a lot of confounding factors in diagnosis itself, but doesn't matter, we have to anyway control the blood pressure and try to prevent the central effect, that is in terms of eclampsia and convulsions. So if the target obviously is to go to around 105 diastolic and 160 systolic, nothing beyond. What we commonly available are having is labetalol. Hydrolyze also nowadays become available, but this is one is used more commonly, and 20 milligram IV given over 1 minute, and doses repeated to have a blood pressure coming down below 180 to 160 millimeter of mercury is the target for systolic, and diastolic about 105 and nothing lower. In initial stages, that is the target. So you don't have to overshoot because there can be counterproductive problems. Hydrolyzing can be used. It is little stronger agent, so lesser doses needed, 5 milligram IV slowly as compared to 20 milligram of labetalol. And similarly, infusions also of the labetalol as well as hydrolyzing can be needed later on. But the best evidence is for the magnesium sulfate for eclampsia prevention, that is convulsion prevention, and it is commonly available and commonly given intramuscularly also in about 4 gram or 8 gram at a time. And in intensive care unit, of course, we have infusions needed to be given, and average dose is 1 gram per hour. Obviously, you need to monitor clinically as well as by doing the blood levels, and if the seizures are, of course, persistent, then you need additional doses, and it can be given as a slow bolus up to 2 milligrams intravenously. Monitoring is obviously by clinical, because we need to have reflexes being checked, respiratory depression, etc. being taken care of, and of course arrhythmias if at all they come in. Otherwise, you have to keep on monitoring the levels, and these are the levels which normal level 1.5 to 2.5 and therapeutic between 4 and 7. Anything beyond that can be toxic, and one has to treat the toxicity if it happens by giving IV calcium and managing the other side effects like respiratory depression by necessary respiratory support. Alternative agents obviously are in midazolam, lorazepam, phenytoin. Phenytoin is not being really commonly available nowadays, but it has been used for years together. If you have some resistant case, you can still think of it, but mostly benzodiazepines are usually available and used. Eclampsia, I'll not go into details, but both are possible depending on anesthetist choice and the limiting factors, contraindications. Even in between the intervals of convergence, now regional is accepted. So there is a lot of enough evidence to that effect, and I think anesthesiologist colleague will prefer that if possible. The killer, as I said, is systolic hypertension, and what aggression is needed to control the systolic BP, because by enough studies it has been shown that that is a killer. That was one category. The third category is peripartum respiratory distress, and we had a detailed lecture by Samir on ARDS basically. Respiratory distress can be due to various reasons, viral infections coming in, and ARDS due to some other reasons, including amniotic fluid embolism is seen related to the pregnancy. But this particular case had severe PIH, and all the necessary treatment as described in the previous slides was given. You can see this kind of picture obviously means there is a probably pulmonary edema there, and very severe rise in the BP to 20 to 110. Now, once you have all these, there can be multiple differentials in this. Like when a patient has eclampsia, there can be pulmonary congestion due to simply because of hypertensive left ventricular failure or neurogenic pulmonary edema, autocolytic or induced pulmonary edema, because if autocolytics are being given and if they are tapered later on, there can be congestion because vasodilated circulation pushes after vasoconstriction the whole volume into pulmonary circulation, causing pulmonary edema. That is the mechanism for autocolytic induced pulmonary edema. Aspiration also is possible and some other infections. So there are multiple differences at this point of time, but it's not very difficult now. Of all the tools which we have now available, it's not very difficult to diagnose what we are treating with. And in cardiovascular side, of course, cardiomyopathy is also seen once in a while, and there can be venous thromboembolism incidence also is high in pregnancy. And the anemia also can be the cause. So management goes on a very usual line, and I will not go into details because whatever applicable to ARDS, same ventilative principles or oxygenation support will be needed in this particular patient. So I will skip that part of it. So obviously this particular case was managed on those lines. Additionally, what we will need if the pulmonary edema is there, you will need, there may be associated renal insufficiency as well. So fluid management and the diuretics and the oxygen support obviously will be needed to be in detail to be looked into. BP controlled with usual agents, and then of course patients improve with diuretic therapy and BP control together. You can have echocardiography done to find out whether there is an additional component of LV dysfunction. All that can be done. These particular patients may come for at the end of them for the delivery, etc. The cardiomyopathy patients obviously can present, and it's not very difficult to diagnose cardiomyopathy because the moment you have breathless patient, the echo tells you that how is the left ventricular function. So, that can be diagnosed clearly. And this patient obviously had a bilateral congestion seen on this. Now, question comes whether these people can be, these patients to be delivered normally or cesarean section. Now, it all depends. The obstetricians can be a little aggressive on doing cesarean section, but it is possible that under epidural you can be giving a vaginal delivery trial. Now that has to be discussed appropriately by the team and decided. Well, this particular patient obviously was delivered by vaginal delivery, but needed intubation in between because had a hemodynamic problem. So it may not be a very easy thing to handle, and obviously will need a support of multiple specialists as per necessary. This is just another ARDS case, so I will not go into detail. H1N1. Amniotic fluid embolism is another challenge, and it's very easy to suspect but difficult to prove, but we can come to know, and there is no definite treatment. So all these problems are known to us. Again, treatment goes on lines of ventilatory support, and mainly there is a DIC-like picture. So we have to have hemodynamic as well as hematological problems to be overcome. We may need coagulopathy management rather aggressively. As I said, in jaundice category, we have hepatitis C coming up, and we may have, and of course, dengue and other tropical fevers also have some liver dysfunction. And they can come at term, usually they present with a challenge because at the end, there will be, at the term, there will be a problem of hemorrhage that sort of occurs. And this is typical differential diagnosis in liver. And it's not very difficult to diagnose, but the more challenging is acute liver failure occurring due to anything. And of course, acute fat necrosis of the pregnancy, that is also a challenge. So in acute liver failure, all these complications will be there, and we all know medically that these can be treated appropriately if the little bit of a differential and aggressive approach will be needed, whether it is SLO, edema, coagulopathy, or metabolic changes, including some organ dysfunction in left lung and kidney level. So that can be looked into. Acute issues, as I said, when to deliver, there has to be optimized, especially coagulopathy, etc., has to be properly optimized. And of course, if the encephalopathy is there, that needs to be looked into. The possibility of PPH is very high. The most challenging, obviously, is acute fatty liver of pregnancy, and it's known that it has a very rapid deterioration, and patient can actually die even before you think of delivery. But prompt delivery can, to some extent, help to overcome the problem, and management goes on these lines, like you treat coagulopathy and encephalopathy, and of course have an appropriate decision to have a termination done for the baby's sake at least. The last part is resuscitating pregnancy. Now there is a little difficulties are due to various reasons, and circulation, airway breathing, of course, all these principles are always there. What challenges is in the terms of ribs which are flared, diaphragm raised, and body edema, obesity, breast size enlargement. So all these, and of course supine position which we use for CPR routinely has a limitation because IVC compression is there due to gravid uterus. Other concerns obviously regarding different drugs, they're not much of a challenge, but even defibrillation can also be given. In PIH patients, serum magnesium, etc., may be precipitating factors. So all that history has to be taken into consideration when CPR is going on. And a word about perimortem cesarean section. Basically, there is a 4-minute rule that within 4 minutes you have to have baby out. Then only there is some chance that mother might survive, and of course fetus can be looked into. So there have been some success stories, and done promptly can have some success stories created. So it's obviously done with a midline incision, vertical incisions on abdomen as well as on the uterus, and within 4 minutes you have to take the baby out. So to summarize the topic, hemorrhage is very common. High mortality is still related unless you go aggressively, managing it in terms of prevention of the triad, which is the or quadrant, you can say, that has to be managed appropriately as aggressively. PIH, of course, the systolic hypertension is a killer, so BP control up to 160 systolic, not really below, is the prime goal in that. And for respiratory distress, of course, all the principles of ARDS management, depending on the cause. If it is cardiac, then management of cardiac failure with appropriate specialist opinions and evaluation will be needed. Jaundice is the real problem, so differentiation to the cause depending on the prognosis of the disease, because many dengue hemorrhagic fevers came for delivery, and there was real dilemma whether to go for delivery, what time to go for delivery. So it can be a very difficult decision, but has to be documented appropriately and done, because there can really be morbidity or mortality on table. And sepsis and renal failure or related emergencies are also there, and they are actually topics by themselves. So I'd like to stop here. If any questions can be entertained. Thank you so much.
Okay, I would like to call Dr. Akshay Chalani sir and Dr. Anjana to come felicitate the speakers and the moderators.
I request Dr. Praveen and Dr. Samir Zok to be on the dais, and Dr. Bharajya Kasi and Dr. Gunadhar on the dais. So we'll do a panel discussion actually. Dr. Praveen is heading Apollo ICU at Nashik. And Dr. Gunadhar is a senior consultant at Apollo Navi Mumbai. And Dr. Bande already you have heard is heading Noble Hospital, and Dr. Samir Zok sir in Dinanath Mangeshkar Hospital. I'll directly start with the case actually. This is a lady who was hospitalized around This is a 43-year-old lady, known hypertensive and diabetes. He came with the breathing difficulty, mild hemoptysis and fever on off from last 3 days. Outside, 1 month back, she was hospitalized for community acquired pneumonia. That time they did a X-ray. After antibiotics, she did improve. After 1 week, she went home. That point of time, she required oxygen. This time, she came with breathing difficulty. That sugar was HbA1c was 9.8. And around past history, she has a right-sided vocal cord palsy, which was seen by ENT person, and it recovered spontaneously. I think she received steroid, but exact details we don't know. So we tried to go back the history actually. This was the CT scan which was done before she came to the hospital. It's clear-cut showed left lower zone pneumonia. The problem is that this was the report, HRCT, it's collapse consolidation also with the thick walled cavity lesion noted at the lower lobe predominantly involving the superior segment, and this part of left lower is showed patchy ground glass opacity with the fibrous band. And there is small nodular lesion noted in the bilateral upper lobe and right middle lobe. Night she came around 1:30, 2 o'clock, and that point of time she had a breathless. Significantly she required oxygen around 6 liters per minute, and she was mild hemoptysis. Now the problem is that what to do actually, just put on nasal oxygen, just put NIV, directly go for mechanical ventilation, wait and watch. Any panelist can take this question. She has a mild hemoptysis. Now if you see the definition of hemoptysis in the literature, more than 100 definitions, what is mild, what is moderate and what is severe actually, but she has a mild one, around not more than 50 or 100 ml per day actually. She was tachypneic, rate was around 30 per minute. Hemodynamically she is stable.
There is no shock, there is no CO2 retention.
No sir.
And there is no other organ dysfunction.
Only the respiratory was around 30, creatinine was around 2 actually when she came. So that tachypnea is a part of only respiratory.
So I'm not very sure NIV maybe because hemoptysis is considered as relative contraindication for non-invasive ventilation. We really don't know what is the reason for hemoptysis for time being. And same is true possibly about high flow nasal oxygen. But considering her clinical status, I think NIV or HFNO can be a reasonable option with readiness for a mechanical intubation anytime. Once you start NIV and HFNO might be a reasonable option for this. Can I disclose the case?
Yeah, most welcome.
Isolated nerve palsy which is reversible, female, middle-aged, 2 episodes of community acquired pneumonia. The strong possibility of connective tissue disorder is there in her case.
Okay. Any?
I don't know this case.
So Praveen, any?
What did you say?
Collagen vascular disease.
Possibility of connective tissue disorder. Maybe lupus. I don't know, but possibility is strong.
Any treatment plan, Dr. Praveen, you want to add? Any in addition to NIV, antibiotic, and all that? Whether you?
I think HFNO, if there is massive hemoptysis, the respiration can be avoided. Regarding treatment plan, as CT shows the cavitatory lesion plus consolidation. So we have to differentiate regarding cavitatory pneumonia, and accordingly we have to evaluate. Patient is diabetic, HbA1c high, so possibility of fungal and tuberculosis both has to be kept in mind. Fungal need urgent treatment and evaluation also.
So, as you said, high flow nasal can be considered first, taking into limitation of cavitation being there, and fungal infection can be the possibility. Regarding metabolic, there is no disclosure. Is there any metabolic problem?
Creatinine was a 2.2. There is no significant metabolic.
So there is no severe metabolic problem. It's mainly respiratory with cavitation and hemoptysis. So possibility of fungal and tuberculosis obviously to be ruled.
So particularly this lady actually, if you see the patient profile, so elderly, diabetic, uncontrolled HbA1c, already had a vocal cord palsy, so it can maybe a recurrent vocal cord dysfunction, you don't know, aspiration, and of course he is in a very high risk of multi-MDR infections also, and this looks like a severe, so I have to keep my my threshold of intubation very low. Already he has gone into hemoptysis. We don't know if he can land up in massive hemoptysis also. We don't know the reason actually. So early intubation and counseling the relative in this case is very important, though I definitely like to give a trial of NIV initially, but if the tachypnea persists or we are not sure about the cause, like if there is a worsening of the condition, so early intubation, ventilation, and of course all the aggressive treatment should be started because she is falling into quite a high risk zone. So antifungal, antibiotic, supportive everything should be initiated.
And Dr. Zog, you say the SLE, basically suppose at the age of 43 till this moment, I assume the family must have been finished, Bachchu and all that. So at the age of 40, presentation with hemoptysis, without any premorbid till this moment, little unlikely. Anyway, but what I did, I'll tell you. Night that RM just put on NIV and then he informed me I have put and she's okay. So then I slept actually. So finally we were not sure. So immediately already workup has been done. So we did a PET scan actually. And the PET scan showed there is a most likely represent the fungal wall in the left lower zone actually. So and it is cavitated lesion. In addition to the lesion in the left lung, she had a lesion on the right upper lobe also. So we really don't know what we should started. I started everything actually. It's antifungal, antibiotic and all supportive medications. Till this moment anybody differ what I did, what I don't do?
What about the steroids?
Steroid we don't give. I'll tell you what I did actually. Then next 1 or 2 days she was little okay. This was the treatment what I started. I'll give you explanation why I did that. Initially started Magnex Fort and isaconazole. Initially I thought whether this is a fungal cavity, whether it is a mucor or whether it is aspergillus, we are not sure. So we started both. I was not very convinced about the antifungal, but given the fact, consulted a lot of people, infectious disease and chest physician because of pressure, because I was not very sure what I am dealing with.
Akshay, the only thing is cefoperazone has got some coagulopathy component and the Magnex has got cefoperazone sulbactam. So it is, if patient has got active bleeding anywhere like hemoptysis or any GI bleed, it is worthwhile not to give cefoperazone combination. It can be, you can give ceftazidime, you can give any other thing, but not cefoperazone.
I was literally okay, so I thought that I'll continue, sir. And it was day 6. So surprisingly, her BP just shoot up on day 2, day 3, NTG started, then it stopped. This is the initiation what we did. Sputum was negative, galactone negative, beta-glucan negative, culture negative, collagen vascular workup was negative. Only ESR was 144. This is the only positive finding actually. ESR was done by Dr. Mahindra. I just forgot to do that. This was the finding and she was relatively okay. She was doing reasonably okay. Patient, as we are not very clear to find out, the patient underwent the biopsy to find out the diagnosis actually. This is what we find, nothing acid fast baseline negative, this gene expert negative, beta-glucan, AFB, everything negative. Finally, we decided to take a biopsy, so we consulted radiologists and other people, and this is the report what we got actually, just show you. Basically, started injecting antifungal and isaconazole, shifted to floors, 2 to 3 days she was okay, became drowsy. One second. This is the report actually, this is the lung biopsy. Initially, we thought that we'll do a IBUS or we'll do a BAL to find out a diagnosis, but finally, when we consulted the radiologist, what he said ki, there is a lesion in the lung which will give you the exact results. So that is the reason we finally did a lung biopsy on day 5, day 6 when we were not sure about the diagnosis. And the lung biopsy showed features suggestive of necrotizing granulomatous inflammation. So we are neither here nor neither there.
My suspicion was correct. I
I
told you the first slide, this is autoimmune connective tissue disorder.
So, sorry, I'm only speaking.
Sir, regarding cavitary lesion and nodules, still BAL and bronchoscopy will help. We can send molecular testing also.
We did all possible site, all possible from the PET scan, from wherever we get a tissue diagnosis, we try to do that. Actually, because this ANA, DSDNA, all collagen vascular work was negative. And here when we talked and discussed with pathologists, they suggested necrotizing granulomatous inflammation. So whether it is TB, whether it is sarcoid, other thing, we were not very sure. But anyway, we put on antifungal. That point of time, we put on steroid actually. Shifted to flows, 2 to 3 days, she was doing okay. Became drowsy, not responding to oral commands. That time, sodium, PCO2, ammonia, lactate, everything was okay. CT brain was normal. This is after 6 or 7 days of andolafungin and antibiotic. She was okay, shifted to the floors and again became bad. And come back to the ICU actually.
So you have worked up for sarcoidosis also, like the ASA level and other things.
That all is negative actually. Any thought?
What about the cardiac functions and other any vegetations in the valves or the renal functions?
T not done, but the transthoracic echo did not show any obvious vegetations. Neither there was Only finding was high ESR, but culture subsequently showed all negative.
Was sputum biofire or anything tried?
It was negative, sir. We did all this biofire actually. This is not very clear, but the sputum, everything we did, all is negative actually.
Serum LDH level?
Number I don't remember, but if it would have been a number, I don't remember actually.
But it was in the normal range, like there is no...
I assume because if it is not mentioned, only abnormal parameters I have mentioned here actually. Sir, I did a PET scan on the day 2 only. Suppose you see on the PET scan, subsequently, categorically he said it doesn't look like lymphoma actually. This is a PET scan. And collagen muscular per se to comment on this, little difficult to explain this cavity, sir.
Ironically, the collagen vascular disorder workup, which commonly is done, the sensitivity of most of the tests, including ANA by IFA, blot, CNCA, PNCA, double-stranded DNA, and many other, sensitivity always lingers around 75%, 80%. And for ANA, the specificity also is not so good because in any chronic illness, any chronic infection, you get ANA positivity. In this case, all, you have mentioned all, but whether ANCA was done, CNCA, PNCA,
everything.
That's what I said, the sensitivity is little less for these patients. So many times the diagnosis is based on clinical, radiological response to therapy and ruling out many other things for this. So now you have got tissue diagnosis with necrotizing pneumonia where Langerhans giant cells and typical tubercular formation is not seen. So TB is reasonably ruled out, I would say. If the histopathology doesn't say, only possibility is still necrotizing pneumonia, which is Kikuchi, but Kikuchi is typically lymph node disease, which very, very rarely affects liver, spleen, and parenchyma is much, much less. In fact, I think not reported in lung parenchyma Kikuchi. So this again remains with necrotizing pneumonia, necrotizing granulomatous angiitis. This is the strong possibility for this, which is previously we used to call this as Werner disease, but Wegener disease, but now we call necrotizing polyangiitis. So it still believe it always prevents like, and this is the secondary neurological worsening can be an encephalitis manifestation of this, or rarely is possibility that the necrotizing parenchymal disorder has missed either by pathologist or it's a non-representative sample and it is still tuberculosis, and now she is landing up with tubercular meningitis with vasculitis, with TB vasculitis. So these are the two possibilities still there.
Was HRCT repeated second time?
No, HRCT we did not repeat, sir, because we only did a X-ray. X-ray did not show any worsening actually. So once she became very drowsy, that point of time I thought it is some antibiotic or some induced, or she is convulsing upstairs because of vasculitis. That is reason shifted down, put on anticonvulsant. But by the time we shifted 5 to 6 hours, she became okay. So she was okay on her own because of anticonvulsant. We don't know actually.
MRI brain was done?
No, CT brain was done that point of time, and morning there was a plan to do MRI brain, but by the time we planned, she became fully conscious.
What about the atypical like tubercular infections? And if you see the cavity, actually these are one big cavity and other also small cavitary lesions also, both these sides. So possibility of some septic emboli elsewhere from the body can be a possibility, particularly the infective endocarditis or some lung abscess, which is like cavitary lung abscess or septic emboli from any other source. So does the whole body PET scan has been done or only the lung?
No, it was a whole body PET scan actually. Okay. It is a whole body PET scan. Repeat CT was not done, sir. Repeat CT was not done because there is no significant hypoxemia. So I felt that there is no significant lung worsening. That is the reason that CT chest was not done. But this is a PET scan whole body actually.
Possibility of atypical infections like histoplasmosis or some like
whether
like pneumocystis
or typical mycobacter or something, whether it will, even if the Kikuchi, sir, it will not make her so tachypnic and so bad and so hemoptysis. Kikuchi per se to cause hemoptysis is a little unlikely actually, which I felt.
So hemoptysis settle after that or only
no, but initially 3 or 4 days she has a significant, she requires almost 4 units of blood.
Significant.
Pneumocystis, any possibility of pneumocystis?
PCP Because lung parenchyma by and large would show cavity, so I did not think of PCP, and HBNS was more
Actually, there are some described literature in very few percentage of cases. Atypical pneumocystis, you may get a cavity actually. Normally they don't get, but and also sir, like some coccidiomycosis or some histoplasmosis, some kind of atypical.
All possible fungal cultures were done actually. Now the present status, I will tell you, she is on day 14 of antifungal. Steroid in between give because the chest person felt that she used significant bronchospasm because of this. So she is better because of that steroid working on the collagen vascular disease, or per se she is okay, we don't know, but right now this is the last status actually. So plan is, what I'll do. So now what we have done, we have sent that biopsy report to outside lab, to outside hospital to find it out what is the diagnosis. All cultures till this moment, fungal from that culture taken from that lung sample is also till this moment is negative. Presently she is on antifungal only. And steroid, yes, in between she received steroid, but I did not give collagen vascular per se. We give because there was a significant bronchospasm, and we thought that hypoxia is contributed by this significant bronchospasm.
But any effusion on the left side? X-ray?
Left side? There is no.
CT doesn't show. If she is developing new bronchial obstructive airway disease after admission, it is more goes in the favor of polyangiitis, necrotizing polyangiitis. She has not history of bronchial asthma in the past, and you have not mentioned, so she doesn't have. And now if she has developed a bronchospasm, which needs steroid, obviously which is not treated with, not getting relieved with inhalation bronchodilator and steroid, and requiring topical steroids. This means the new pathology is worsening of bronchospasm. This goes more all in the favor of collagen vascular disorder.
But liquid CT and additional microbiological evaluation.
What I would suggest is now,
liquid CT we not done. We'll do.
You repeat the collagen vascular workup or autoimmune connective tissue disorder workup again, because this is well documented that organ manifestation comes first and serology comes later. This is quite common, not quite common, but this is very well known fact that the organ manifestation, for example, first episode of seizure, first episode of polycirrhosis, first episode of kidney dysfunction, and all serology is negative. But after 6 weeks, 8 weeks, often they manifest in serology in terms of ANA or dsDNA or CANCA. So it's worthwhile to repeat after 6 to 8 weeks if that period has passed away. And second is the biopsies, if the affordability is there, it is worthwhile to do next generation sequencing of the biopsy sample. To look for fungal diagnosis which Gunadhar was mentioning about. If the sequencing does not show any fungal element, and it's practically ruled out fungal infection from that biopsy. But if the sequencing does show histoplasmosis or coccidioidomycosis, we have clinched the diagnosis. So I think I would suggest sequencing of the biopsy itself, because the sequencing can be done on tissue as well. It's not only the blood. So tissue also you can do sequencing.
She became absolutely conscious, sir. So then I just kept a high threshold. MRI will plan, because right now she is fully conscious, but CT was normal and she improved dramatically without doing anything. So I thought MRI per se will not add anything, but anyway, CT, that fungal and MRI will get it done. And I thought around 10 days back the PET scan was done. That is unlikely to miss out something.
Developing renal function?
No, renal improved actually. It was initially 2.2 and then again became 1.1. And there is no active sediment in the urine to label as a collagen.
Developing fungal balls in such short history is very rare. Usually in tuberculosis they develop fungal ball afterwards.
No, what I thought that 1 month back she had that fungal.
CT was not done at that time.
So you feel now the patient is improving with the steroid, means the clinical condition you will see.
She's better, but I don't know what is the diagnosis.
Because
she's better without
most
diagnosis.
of whatever the history, I fully agree with sir actually. So multisystemic disease, so more goes in the favor of the autoimmune. Initial kidney involvement, better with steroid, then seizure, vasculitis, and all these necrosis.
Seizure, what was clinical diagnosis actually? Seizure, she was. AKT, we at one point of time we thought we'll start AKT and steroid, but subsequently doing so much of culture, taking tissue biopsy, it was negative. So.
Most likely she's behaving like
sure that the anti-fungus are matching the identity of the fungus. That's where I think the diagnosis is ready. Because anything else would not have behaved in such a slow presentation.
No, I'll get it done. Still, she's in the hospital, so we'll get it done. That's all from my side, and thank you, Dr. Jog, Dr. Gunadhar, Dr. Praveen, and Dr. Bande sir for your time and staying here till Sunday evening. I only request Dr. Bande and Dr. Jog sir to just facilitate our two DNB students who are working too hard from hospital. Dr. Ashwin. Dr. Praveen and Dr. Gunadhar. Dr. Narendra is here, Narendra Patil. And before I just sign off, I thank you all, Pharma, who without that it was not possible actually, for your kind gesture and complimentation and educational support. Thank you all, and thank you for your time.
I would like to felicitate Dr. Akshay Chalani, and I would like to call Dr. Mahendra for that. Thank you, sir, for the opportunity that you have given to us.